Good morning, esteemed guests and conference participants. Welcome to Sleep Summit 2024 in the Department of Pulmonary and Critical Care Medicine, KGMU, Lucknow. I am Dr. Shubhra Srivastav.
And I'm Dr. Mrityunjay Singh.
We are your hosts for the day. We all are gathered here to exchange our ideas and for open discussions on sleep and its disorder. As Mahatma Gandhi once said, each night when I go to sleep, I die, and the next morning when I wake up, I am reborn. This statement simply showed the importance of sleep in our lives, that how rejuvenating a good sleep could be. Even National Sleep Foundation recommended 7 to 8 hours of sleep for adult. It is estimated that obstructive sleep apnea affected nearly 1 billion individuals worldwide, with a prevalence exceeding 50% in some countries, and concluded that effective diagnostic and treatment strategies were needed to minimize the burden of this disorder. Sleep is essential to health, but measurable differences in sleep additional burden and reinforcing health inequities. World Sleep Day is the perfect opportunity to combine efforts towards sleep awareness, education, outreach, and community engagement that work toward reducing sleep disparities and ensuring equitable access to the healthy sleep for everyone. World Sleep Day celebrated every year in March, and this year's theme is Sleep Equity for Global Health. There is a saying, laugh and the world laughs with you, and snore and you will sleep alone.
Thank you, Shubhra. That's a good anecdote. Sleep is a subject that has historically fascinated doctors, philosophers, poets throughout the world, and when deprived of, has troubled people in agonizing ways that only the patients with sleep-related problems can understand its true pain. It is indeed a golden opportunity for each one of us to enrich and enlighten ourselves. Without further ado, let's dive into our promising schedule. For the first session of the day, that is spectrum of sleep disorders and workup in a patient of sleep-related breathing disorders, I request our chairpersons to please come onto stage and grace their seats. Professor K.B. Gupta, sir, Professor and Head, Eras Medical College, Lucknow. Welcome, sir. Professor Anand Srivastav, sir, Professor, Department of Respiratory Medicine, KGMU. Dr. Rajneesh Srivastav, sir, Senior Chest Consultant, Sahara Hospital, Lucknow. Dr. Muhammad Amir, sir, Senior Chest Physician, Vivekanand Hospital, Lucknow.
Should I start?
May I now request the chair to kindly introduce the speaker, Dr. Beeping Singh, sir, and conduct the session further. Thank you.
Good morning, everybody. First of all, my thanks to the organizer to just give me the opportunity to be here on this Sleep Summit. Now, friends, as you have been mentioned in the introduction, the sleep is very important for all of us. Adequate sleep, minimum 7 to 8 hours, is a daily requirement, and for the good health also. Sleep is subject to which the great awareness is required in the society, as well as among the physicians and practitioners. I remember the days when the sleep was the domain in the specialty of the neurology, and I am seeing that for the last 10 years, this has shifted totally toward the respiratory medicine. The reason is that the sleep-related disorders, breathing disorders, are very, very common. Not to say at least 30 to 50% of our population may be suffering from some kind of the sleep disorder or others. And their needs, you have seen that so many things in the recent past also, that the COVID is over, but post-COVID, sleep disorders are very common. Patients are coming in the OPD. ILD is coming up, And in the sleep disorders, in the ILD patients, they are also coming up like this, up to 20% we have seen. Insomnia is a very common problem. And I think it is a major sleep disorders. Sometimes you can have the narcolepsy, very, you can say, serious problem when we, especially when we are having these sleep attacks in the daytimes while you are doing active work like driving, something like this. It is wide spectrum sleep disorders, and today's our eminent speaker, Dr. BP Singh, will be highlighting on the sleep spectrums and sleep disorders and how to work up. That is very important. Still, I see in our clinics and the practice and the OPDs that we are not paying much attention on asking the questions regarding this screening for the sleep disorders. Dr. BP Singh is a very eminent pulmonologist of the city, a national and international faculty in all the meetings, and he is the director and chief consultant of the Midland Hospitals, Lucknow. So I invite Dr. BP Singh to kindly deliver the lecture.
Thank you, sir. Respected chairpersons, seniors, dear friends and colleagues. It's a privilege and honor to talk on this important subject, and Dr. Ved has invited me for this presentation. Actually, it is a very wide subject and very huge. To cover up in 20 minutes will be, although it will be difficult, I will just go through for most of the salient points. Sleep, as Professor Gupta has already mentioned, that it is a very widely, disorders have been very widely prevalent in the society, but unfortunately, many of them has not been taken very care very effectively. Sleep disorders are very poorly defined. Till date, although it is a subject from the last almost 5 decades, people have delved into it, and they have started searching about the various aspects of the sleep. I was in a sleep conference meeting in Canberra, and there Dr. Anderson was there who were working from the 5 decades, and many times he showed many videos, and he was saying that I'm humble at the presentation, that I do not know what it is. So still we are learning, almost everybody is, and the science is evolving, and whatever knowledge we have, we will just discuss it. Even though a comprehensive and universal diagnostic manual called the International Classification of Sleep Disorders has been proposed by the American Academy of Sleep Medicine, which lists more than 80 different sleep disorders, less than 20% of the individuals with sleep disorders are correctly diagnosed and treated. As sir has mentioned, almost 50%, various studies have shown 10% of the population impacting daily life. It is the most frequent had been the insomnia, the sleep-related breathing disorder, rest leg syndrome. There are 3 cardinal diseases which have been very widely prevalent. If you look at the classification of the sleep disorder, it has been given, actually various classification appeared in the literature, 1979, 1990, 1997, according to the cardinal symptoms, that is the insomnia for the poor sleep, hypersomnia, too much sleep and or the excessive daytime sleepiness, parasomnia, the abnormal behavior during sleep. There were 3 cardinal symptoms, and according to that, it was classified. The ICSD 2005 and 2014 were developed by the American Academy of Sleep Medicine according to the pathophysiology of the disease. The DSM-5, you all know, the Diagnostic and Statistical Manual of the Mental Disorder, it has been published, and it has classified the different diseases for the mental disease. Then International Classification of Diseases 10, it has also classified the various diseases developed by the WHO for the differentiation of the disease process. This is the most important given by the American Academy of Sleep Medicine, the ICSD-3. It has divided into the 7 categories. Insomnia, the sleep-related breathing disorders, the disorders of the hypersomnolence, circadian rhythms, sleep-wake disorders, parasomnias, the sleep-related movement disorders, and other sleep disorders non-specified. So there are the 7 categories which has been identified, and according to that, it has been discussed. If you look at the percentage, the insomnia has been the most common one, around 10%. sleep-related breathing disorder has been described in 3 to 7% of the population, or it may be much more than that. Central disorders of the hypersomnolence, as Professor Gupta has already mentioned, the narcolepsy, and it has been reported at 0.8 per lakh, and circadian sleep-wake rhythm disorders, 7 to 16%. The parasomnias in children and adults, 3 to 17%. Sleep-related movement disorders in 5 to 10% of the population, and other sleep disorders non-specified. And what is the insomnia? The patient suffers from the poor sleep. And there are different dimensions to it, the insomnia. The problem of initiating the sleep, problem of maintaining the sleep, problem of awakening too early in the morning, and being not refreshed in the morning, and there may be combination, various combination. Patient might have different difficulty in the initiation and also in the maintenance also. It has impact on the daytime performance in the form of sleepiness, fatigue, altered mood, irritation, memory, and concentration problems. There are various subtypes have been defined in the insomnia. The short-term insomnia disorder, the acute insomnia, or the adjustment insomnia. It occurs in around 35% of the patient of the insomnia, and less than 3-month duration. It is fewer than 3 times per week on an average. So it is the acute or short-term insomnia disorder. The chronic insomnia disorder, it is in the subgroup, around 10%, more than 3 months and more than 3 times per week. It has various subgroups and subheadings are there. The psychophysiological insomnia, the paradoxical insomnia, the idiopathic insomnia, the insomnia related to the mental disorder, inadequate sleep hygiene, behavioral insomnia in children, insomnia related to drug abuse or the substance abuse, insomnia related to the medical condition. So there are various subtypes which has been identified, and they have been subgrouped and discussed each together. Other insomnia disorder, for individuals that do not meet the full criteria and term to be used sparingly, and isolated symptoms and normal variants like excessive time in bed and short sleeper. These are all the various subgroups. So the short-term insomnia, the chronic insomnia, and other insomnia disorder, and few other like in isolated symptoms and the normal variants are also there. The chronic insomnia, the problem to initiate sleep, if you are taking more than 30 minutes to go to the sleep, that it means that you are having a chronic form of the insomnia. Problem of maintaining sleep in total more than 30 minutes. Problem of awakening too early in the morning, less than 6.5 hours of the sleep. In children, there is resistance to go to bed or normal bedtime. There is problem to fall asleep without intervention of a parent or caregiver in case of dementia. Symptoms during daytime reported by patient or the caregiver. While sufficient time and occasion to sleep, at least 3 times per week or during at least 3 months, the insomnia is there and symptoms cannot be explained by another sleep disturbance. So there is insomnia which is persistently occurring more than 3 months and more than 3 times a week. And these symptoms are not explained by any other disease. Idiopathic insomnia, here, as idiopathic you mean that you do not know the cause, but it appears from birth or early childhood. There's no identifiable cause, no long period of remission. 0.7% of the adolescents or less than 10% of the insomniacs are the idiopathic cause, and provoking of the determining factors are not known. Associated with the history of learning problems and ADHD, attention deficit hyperactive disorder, the neurological defect. There is often severe objective insomnia in the idiopathic insomnia. One word about the pediatric insomnia. Prevalence is estimated at 1 to 6% of the general pediatric population, but considerably higher amongst those children with neurodevelopmental delay and chronic medical or psychiatric condition. In these children, we have much more common insomnia. A recent study of 46 children, 5 to 16 years of age group, found that 50% of those presenting to a pediatric sleep clinic for insomnia had a pre-existing psychiatric diagnosis, and the remaining 50% had elevated psychiatric impairment scores on psychometric measurement and diagnostic interview. So those children who are suffering from a psychiatric disorder or neurodevelopmental delay, they have much more common incidence of the insomnia. The another category, the sleep-related breathing disorders, probably as a respiratory physician, which we are encountering predominantly this form of the sleep breathing disorders, and we are managing this. This is said to be around 3 to 7%. It is a very big number if you look at the general population, the population of this country. So, what are the basically the sleep-related breathing disorders? In the subcategories, the most important had been the obstructive sleep apnea, and the central sleep apnea syndromes, sleep-related hypoventilation disorders, sleep-related hypoxemia disorder, isolated symptoms, and the normal variant. You all know, and this is a very common slide actually you have seen in most of the sleep meetings, that obstructive sleep apnea in adult and obstructive sleep apnea in pediatric age group. That is a very common and prevalent disease, and it is said to basically around 4 to 5% in the general population, adult population, you have this evidence of having the obstructive sleep apnea in adults. And it is said, it is the same percentage which is occurring in the pediatric age group also. Unfortunately, it is not identified very well and not diagnosed and treated most of the time. Sleep-related breathing disorders, where the central sleep apnea syndromes, these are very important, but unfortunately not looked at very carefully. Central sleep apnea with chin stroke breathings, the number one. Central sleep apnea due to a medical disorder without chin stroke breathing. Central sleep apnea due to high altitude periodic breathing. It can happen at the high altitude. Central sleep apnea due to medication or the substance like opioid while you are using, it can cause. Primary central sleep apnea where the cause is not known. Primary central sleep apnea of infancy, in the early childhood you get this problem quite often. Primary central sleep apnea of prematurity, it has also been diagnosed, and many times it is in the early childhood, even up to at the age of 6 months it can happen, and you need to know exactly how this presents. And the treatment emergent central sleep apnea, this is a complex sleep apnea which occurs while you are titrating the patient for the severe obstructive sleep apnea. There is emergence of the central sleep apnea during this process, and this is known as the treatment emergent central sleep apnea. Sleep-related hypoventilation disorders. It is very common and important. The obesity hypoventilation syndrome. We encounter it quite often in our clinical practice. Congenital central alveolar hypoventilation syndrome, late onset central hypoventilation with hypothalamic dysfunction. This is a neurological disorder. Idiopathic central alveolar hypoventilation, sleep-related hypoventilation due to a medication or substance. It can also again happen with the opioids, and sleep-related hypoventilation due to the medical disorder. Then sleep-related hypoxemia disorder. Here once patient goes into the sleep, their hypoxemia starts occurring. And unfortunately, this is a serious condition, and many times it leads to further consequences. Isolated symptoms and normal variants of the sleep breathing disorders, like snoring, or catathrenia, means groaning during the sleep. It is also an isolated symptom of the sleep disorder. This is basically the hypnogram. You can see here that there is oxygen desaturation, there is an obstruction to the airflow, and that is the case of the severe obstructive sleep apnea. There is very little literature from India about the clinico-epidemiological profile of sleep disorders in the region. Similarly, there is next to no information about the referral pattern to the sleep clinics. In fact, a majority of patients does not get referred to such clinics. Most of the patients we are getting in our clinical practice is because they are come to us for the general symptom many a times. They do not specifically say that they have the sleep problem. But the referral to the sleep clinics is quite uncommon in our place here in this part of the world. But it has to evolve. There is an increasing awareness for recognition of sleep disorders in India. However, there is still a huge gap in the number of people suffering from the various sleep disorders in the community versus those visiting hospital clinics for the same. We do not have much idea about the sleep diseases as in the public, in the general population. And where to refer these patients for the proper knowledge and proper treatment, it is still undefined. The OSA, we always talk in every sleep forum that it is the most common disease, and it is a far more prevalent disease than generally believed. The global prevalence varies from 0.3 to 5.1 in general population. In Indian studies of obstructive sleep apnea, varied from 4.4 to 13.7, and obstructive sleep apnea hypopnea syndrome varied from 2.4 to 2.8%. OSA in Indian males varied from 4.4% to 19.7%. In females, it was between 2.5 to 7.4% in various studies. Obstructive sleep apnea hypopnea syndrome was observed in males 2.4 to 7.5%. In females, it was 1 to 2%. So the average had been around 4%. You all know the obesity is increasing globally. It is said around 1 billion population is suffering from obesity, and it is increasing day by day, and it is also a very important cause for having sleep abnormality. The central disorder of the hyposomnolence, Professor Gupta has in his address has mentioned the narcolepsy, around 0.8 per lakh. It is still a common number, not very rare, and you can have this type of presentation, those patients who are suffering from severe hypersomnolence. And hypersomnia of central origin, there is basically inadequacy of the alertness, and necessary for well-being. Alertness is required for good well-being and daytime functioning. In case of problem, there is increased risk of accidents. Hypersomnia, the primary symptom is the undesired episode of extreme daytime sleepiness or increased need to sleep at night. It should be present at least more than 3 months. Cause should not be related to the disturbed sleep at night or disturbed circadian rhythm. If present, first you have to treat that. There are different types of the hypersomnia. Narcolepsy with cataplexy, it is type 1, and one of the most important and a very distressing disease. Those who are suffering from this narcolepsy with cataplexy, narcolepsy without cataplexy is the type 2 disease, it is a distressing disease. Idiopathic hypersomnia is quite uncommon. In last 25 years of my sleep practice, I have encountered only 2 patients. So it is quite uncommon in the general population, but it is there. Kleene-Levin syndrome is still a very rare disease, basically presenting with the hypersomnia or hyperphagia and also the hypersexuality. The hypersomnia due to a medical disorder, because of the different diseases, especially the patient with a bipolar disease, you can have all these things. Hypersomnia due to a medication or the substance. Many drugs which can cause sedation, they can produce this. Hypersomnia associated with the psychiatric disorder, as you already mentioned. Insufficient sleep syndrome. It is a behavioral problem, and many times it has been classified as a different type of the hypersomnia. The narcolepsy in the hypersomnia has been the most important presentation. It leads to the excessive daytime sleepiness, presenting as the sleep attacks. Cataplexy, while the muscle weakness, it is provoked by the emotions, it is there, and narcolepsy with cataplexy. Hypnagogic hallucination, while patient is going into the sleep, falling into the sleep, at that point of time, there is emergence of the hallucination known as the hypnagogic hallucination. The sleep paralysis, the most often when the patient is awakened, and at that time, patient feels that he or she is paralyzed. So, disturbed sleep quality at night, and how you will diagnose this. The sleep latency, if it is less than 8 minutes, and more than sleep onset REM period, it is a narcolepsy, and it may be associated with catalepsy or without cataplexy or not. If hypocretin level, one level in CSF is lower than 1/3 of the normal, with cataplexy, it is the narcolepsy type 1. Without hypocretin 1 deficit in the CSF, it is type 2. So to differentiate between the type 2 and type 1, first thing is that you have to identify with the multiple sleep latency test. You have to do a overnight sleep study, it should be normal. Then in the daytime, you have to do the multiple sleep latency test. In the multiple sleep latency test, the onset of the sleep latency is less than 8 minutes, and the sleep onset REM more than 2 or more, then it is the narcolepsy. If the hypocretin level is 1/3 of the normal value, then it is the narcolepsy level 1, type 1, when it is associated with the cataplexy. While if the hypocretin level is normal, then you are dealing with the type 2. Idiopathic hypersomnia with long sleep duration, as I have already mentioned, it is quite uncommon, but it is still there. The excessive daytime sleepiness almost daily, and the duration is more than 3 months. More than 10 hours sleep per night, difficulty to wake up even after the long naps. That is one of the presentation. And often difficulty to awake and sleep drunk after awakening. Means the patient is not very well oriented after once patient is awakened. It starts most often before 25 years of age, and although it is very rare, I already mentioned, and it is 10 times less than narcolepsy. So it is quite uncommon, but it is still there. Idiopathic hypersomnia without long sleep duration. Patient sleeps around 6 to 10 hours sleep per night. There have been different diagnostic criteria. In the polysomnography, you have to exclude other sleep disorders, confirm more than 10 or less than 10 hours of the sleep. There is a shortened sleep latency. The sleep latency is less than 8 minutes, here again, like the narcolepsy. But there are less than 2 SOREM. The sleep onset REM is less than 2. When it is more than 2, it is the narcolepsy. If it is less than 2, it is the idiopathic hypersomnia. The recurrent hypersomnia, the often recurring episodes of hypersomnia are there, usually associated with other symptoms like cognitive symptoms, the confusion, hallucination, and derealization. Behavioral symptoms, the irritability, aggression, binge eating, hypersexuality. And in the normal period, there may be normal sleep and behavior. The clinical presentation of the recurrent hypersomnia had been the Klein-Levin syndrome. And here already mentioned the episodes of hypersomnia for some days to different weeks, at least 1 to 10 times per year, often preceded by the fatigue and headache. Sleep is 16 to 18 hours per day, and extremely rare, more often in men, 4:1, male to female ratio. Another variety of the hypersomnia is the menstrual cycle related, and there are other subtypes that have also been described. Then there is a behavioral hypersomnia. Chronic sleep insufficiency is there. There is excessive daytime sleepiness almost daily and occurring more than 3 months of duration. There is a habitual sleep duration based on the sleep diary or the actigraphy, which is shorter than expected according to the normal data of the age group. Sleep longer when the sleep schedule is not kept. Weekend and the holidays. Means most of the days the patient is having the normal sleep, but when the weekend is there or the holiday is there, patient sleeping for the excessive time of the day. Individual does not succeed in consistent way to get the quantity of sleep needed to keep normal alertness. It is voluntarily but not intentional. Chronic sleep deprivation is there. Here, polysomnography is not necessary, but demonstrates sleep latency of less than 10 minutes and sleep efficiency index of more than 90%. And MSLT, you can get less than 8-minute time to describe the hypersomnia. It is behavioral. Other causes have been the psychiatric disturbances, the post-viral hypersomnia, post-traumatic hypersomnia, neurological disorders, and the normal variant, as I had mentioned, the long sleepers. The fourth category is the circadian rhythm sleep-wake disorders, 7 to 16%. And then sleep-related movement disorders and other sleep disorders we'll just discuss in short because we are running short of time. And there may be delayed phase, means patient is sleeping late in the night, but duration of the sleep is normal, while it may be the advanced sleep phase. Then these are different, basically the circadian rhythm disorder, and the most important had been the delayed sleep-wake phase disorder, advanced sleep-wake phase disorder, or irregular sleep-wake rhythm disorder. Non-24-hour sleep-wake rhythm disorder, there may be shift worker, they can have this circadian sleep-wake rhythm disorder. And jet lag is very common thing you can have while you are traveling to the east or west, passing more than 3 time zones, then you can have the jet lag disorder. Circadian sleep-wake disorder, which are not otherwise specified. Then coming to the parasomnias, which are very important, 3 to 17% of the population. And the important parasomnia has been the non-REM or REM-related parasomnia. The non-REM-related parasomnia, they are the arousal disorders like confusional arousals, the sleepwalking, the somnambulism, sleep terrors, fever nocturnus, sleep-related eating disorder. These are the arousal disorder which happens in the non-REM sleep disorder. In the REM-related parasomnia, the REM sleep behavior disorder. RBD is one of the common things you have in the sleep lab. While you are doing the sleep study in most of the patients, you quite often get this problem, the REM behavior sleep disorder, where you are acting out of your dream and presenting the RBD. The recurrent isolated sleep paralysis, once or repetitive, it can also be because of the REM-related parasomnia. The nightmare disorder is also there in the REM-related parasomnia. And other parasomnias have also been identified. The other type of parasomnia, the exploding head syndrome, the sleep-related hallucination, sleep enuresis, parasomnia due to a medical disorder, due to a medication or substance use, and unspecified parasomnia has also been defined. There may be the isolated symptoms and the normal variants in the form of the sleep talking, which is quite common. Then sleep-related movement disorder, it is occurring in around 5 to 10% of the patient, and in general, it is relatively simple, most often stereotypical movements during sleep, while most often complex behavior in the parasomnia it can cause. The disturbed sleep or the contribute to complaints of sleepiness or fatigue can be presentation of the sleep-related moving disorder. Some movements during sleep are normal or even desirable, the hypnagogic jerks, depending on their intensity and frequency. Important disorder has been the restless leg syndrome. There is an urge to move the legs due to an irritant and inconvenient sensation in the legs. Sensation disappear partially or completely by movement, like walking or the stretching. So it is a quite common thing to have this restless leg syndrome in the general population. Periodic leg movement disorder is there. Sleep-related leg cramps are also quite common in the society. And sleep-related bruxism in children, 14 to 17%. Adolescents and young adults may 12%, in the elderly around 8%. So sleep-related bruxism is also grinding of teeth during sleeping is bruxism. So it is quite common in the society. And this is the hypnogram. You can see here the repetitive contraction of the tibialis anterior muscle lasting for 4 to 90 seconds. And that is basically the presentation of identifying the movement disorder. Does not always cause complaint at night. Often patients suffer from the sleepiness in the day. So just by doing this complete sleep study, you can identify. The sleep-related rhythmic movement disorder, the hand banging, rolling, body rocking, rolling, leg banging, rolling, isolated symptoms or normal variants are the hypnic jerks. So other sleep disorders, the fatal familial insomnia. It is a very rare condition where it is associated with dementia and chronic insomnia and often leading to the death. Sleep-related epilepsy, sleep-related headache, sleep-related laryngospasm, and sleep-related gastroesophageal reflux. And sleep-related myocardial ischemia has also been identified as one of the sleep disorders. So with these words, I like to thank for the patient hearing. Although it is a very vast subject, and this classification itself is very huge. So
thank you very much, sir, for very comprehensively and extensively you have covered the subject, sir. And I must congratulate the organizers and to you, sir, also choosing the right topic for the right day and right time. So the message is quite clear that after listening to you, that it is high time to wake up to the sleep. So not only, sleep is restorative, but if the sleep gets disturbed, each and every organ system gets disturbed. And this is the reason the patients may manifest with organ system disorders too, like hypertension, like diabetes, and many more. So I'm sure after listening to sir, there might be some questions which might be there in the minds of the residents. We can take up a couple of them, if there are any. If no, then I'll request my co-chair to say a few words if they are willing to. Thank you, sir.
Thank you, Dr. BP Singh, sir, for this insightful presentation. We are truly grateful for sharing your valuable insights. I now request Professor Ved Prakash, sir, to kindly come onto stage to felicitate our guest speakers and chairpersons.
May I request Professor Ved Prakash sir to felicitate our speaker, Dr. B.P. Singh sir.
Next. Dr. Rajni Srivastava, sir. And Dr. Mohammad Amir, sir. Dr. Rajni Srivastava, sir. Thank you, everyone.
Okay. One of the most interesting phenomena associated with sleep is sleepwalking. In earlier days, people used to link it with some supernatural or paranormal behavior. But now we are aware that night terror, nightmare, arousal disorder all come under the disorder called parasomnias. To explain it further, we have our next session dedicated to this. For our next session of the day, Parasomnia's Clinical Spectrum and Management, may I request the chairpersons to please grace the stage and take their seats. Dr. Rajesh Verma, sir, Professor, Department of Neurology, KGMU. Dr. Rakesh Chaudhary, sir, Senior Consultant, Saharaganj Hospital. Sahaj Hospital. Dr. Harish Nigam, Assistant Professor, Department of Neurology, KGMU. Dr. Ankit Khaitan, Assistant Professor, Department of Neurology, KGMU. Welcome, sir. I now request the chair to kindly introduce our speaker and take over the session.
Good morning, everybody. So, you see, we are in sleep throughout our life, 1/3 of our life, right? And number two, most of the waste which get accumulated during daytime, that has been washed away during night by glycolymphatic pathways. And many disorders, they give their first impression during sleep. So that's why sleep is sleep analysis, sleep study is very important for all of us. Often we have problems of nocturnal seizures versus parasomnia. See, there is some disorders which occur during sleep, and many epilepsy seizures or epilepsy syndrome, they have nocturnal predilection. So for giving insight about this aspect and then how to differentiate between different type of parasomnias with these type of nocturnal epilepsies and much more like REM sleep disorder, I would like to call Dr. P.K. Sharma. I would say Dr. Parveen Kumar Sharma, because P.K. Sharma seems to be better. So he's, I think, one of the excellent clinicians throughout the university, and he is very popular among ICU physicians. So, Dr. P.K. Sharma, please.
Thank you, sir, and thank you all the chairpersons. I thank at the outset Dr. Ved Prakash for inviting me to present here, and I thank again him for preponing my talk upon my request. It was scheduled in afternoon. So we know sleep is very important. It has got restorative function. The brain, which is very active during the daytime, restores back to its normal homeostatic phase during night time. New synapses develop during sleep. Our memories consolidate during sleep. Other organs' metabolic activities is minimal during sleep. So, sleep is very important. And one of the phenomena which I think all of us would have experienced at some point of time is parasomnia. Parasomnia is abnormal behavior experienced during sleep. And the beauty about this disorder is most of the parasomnias are benign in nature. They don't need any treatment and resolve spontaneously with the advancement in the age. So I will discuss this sleep disorder and its impact in next 15 to 20 minutes. So as it was pointed out by someone, like paranormal phenomena. So parasomnia word has taken origin from the Greek word, which comprises of two words. Para means something around and somnus means sleep. So this forms the term parasomnia. By definition, ICSD 3 defines parasomnia as pointer. Do we have pointer? No? No? Okay. This one. Okay, thank you. So, parasomnia is defined as undesirable physical event or experiences that occur during entry into sleep, within sleep, or arousal from the sleep. There are certain common characteristics of parasomnias, like the symptoms are usually associated with the muscle activity. Some sort of muscle activity is there. They are generally seen in childhood and adolescent age people. They are usually not associated with any medical problem. And on polysomnography, we don't find any specific abnormality. They spontaneously resolve, and there is no specific causes found. Mostly parasomnias are associated with a specific stage of the sleep. As I said, it is very common, and once, at least in children, 1 to 5 years age group, one single episode of parasomnia prevalence may be as high as 84%. Now, so before going into parasomnia, I must discuss something about normal sleep. So what happens during wakeful or awake state? Sleep requires two things. One is clinical features, another is electrophysiological features. So electrophysiology is assessed by electroencephalography. So what happens during wakeful state, our electroencephalogram will show a disorganized kind of rhythm. say we are awake, and if we close our eye, so we can find this anterior disorganized rhythm and posterior a rhythmic oscillation in 8 to 12 hertz frequency, that is called alpha frequency. As we pass into deeper states of the of sleep, the sleep is divided into two major sections: non-rapid eye movement sleep and rapid eye movement REM sleep. So, from wakeful state, we go into N1 segment of the REM sleep, NREM sleep, then N2 section of the NREM sleep, and then slow wave sleep. So, N1 section actually contains replacement, shows replacement of alpha with theta activity, which is 5 to 7 hertz rhythm. In N2 phase, we will see intrusion of the delta, 2 to 3 hertz, 1 to 3 hertz activity. And deep sleep state will contain most of the time, most of this part is formed by the delta. It should be at least more than 30% to say slow wave sleep, right? And what happens, this NREM sleep then, it actually periodically alternates with REM sleep. In REM sleep, what happens, the patient is asleep, but electrographic activity will show as if it is in, it is seen in wakeful state, desynchronized electrographic rhythm. So this is how the staging of the sleep is done. And if we do polysomnography in a patient, in a normal individual, we'll find from wakeful state, he goes into N1, N2, then N3, and then REM. So first half of the sleep, major sleep or night till 12, this segment is predominated by NEREM sleep. The REM sleep component is minimal. And in second half, the REM sleep component increases. Overall, this spectrum also of a spectrograph also shows this is wakeful, no? And REM and slow wave sleep components is almost 20 to 25%. Most of the sleep is N2 state, that is around 40 to 50%. Now, again, this pie chart shows most of the sleep is N2 and REM stage. During sleep also there are episodes of wakefulness, but this should not be more than 5% in a normal individual on PSG studies. And the maximum component of REM sleep is seen in newborn babies. Then it goes on to decrease as the age advances, and by the age of 12 years, REM sleep is around 20 to 25%, and it rests there till adult life. Now, something about sleep physiology. Actually, I made this schematic diagram to make you understand how this works. So there are regions in the brain which are actually sleep promoting, wakefulness promoting area. There are regions which are sleep promoting. So this region is actually in this small diagram you can see this is the midbrain, this is the pons, and this is the region where these two areas lie, right? So there is a switch on, switch off mechanism between sleep promoting areas as well as wakefulness promoting areas. So what happens, there is actually groups of neurons, abundant neurons are there in this posterior upper pons as well as lower midbrain and midbrain. And these neurons make a ascending arousal system. And the inputs from this arousal systems is goes to basal forebrain region, and from there to diffusely, it goes diffusely to cerebral cortex. Another important ascending pathway goes to thalamus, which carries sensory information. So arousal system also sends afferent to the thalamus, and from thalamus also it is distributed all over the cerebral cortex. So this area, when this area is on, it will keep patient awake. Another important reason is lateral hypothalamus, which contains a group of neurons which actually secrete one neuropeptide called oxyrin or hypocretin. And these neurons which secrete this neuropeptide are actually facilitatory to this arousal system. And whenever these neurons are damaged, this leads to what is called one pathological condition, narcolepsy. These neurons are also important to actually they keep check on REM sleep. So if these neurons are gone, the REM intrusions will happen anytime. And that is why narcolepsy patients get REM sleep attacks very frequently and very early. Now, the sleep promoting area is preoptic region of the hypothalamus and lateral hypothalamus and upper pons. From there, actually, they have reciprocal inhibitory connections. This makes a switch. Now, when this inhibition is maximum, it will make a person fall asleep. It will inhibit wakefulness promoting area. And when this inhibition is maximum, it will make one awake from the sleep. Transition from the sleep and wakefulness state happens very fast. So this suggests there is some sort of flip-flop switch kind of mechanism. Then embedded into this system is the REM off and REM on switch mechanism also. So this is again inhibitory, reciprocal inhibition is there, but it's REM on neurons, actually this group of neurons will send facilitatory, they are facilitatory to ascending arousal system. And they are, their actually output is distributed to the basal forebrain. And this reason is important for the dream formation, dreaming, whatever for dream, this reason is actually important in causation of the dreams. So that's why when REM is on, a lot of dream activity takes place. Okay? And at the same time, this REM neurons sends inhibitory inputs to medulla and spinal cord anterior cell. This inhibition will cause skeletal muscle paralysis. That is what muscle atonia is seen during REM sleeps. So this is how the sleep mechanism works. Now again, the classification I think has been discussed. We can classify parasomnias into NREM sleep, REM sleep, and other. Among NREM sleep, important one are confusional arousal, sleepwalking, sleep terror, sleep-related eating, sleep and REM sleep are RBDs, nightmare, isolated sleep paralysis. I'll discuss one by one, but for the diagnosis of parasomnia, we need clinical history, video recording by the parents, but not polysomnography. Most of the cases, PSG is not required. Polysomnography is indicated when there is self-injurious behavior, suspected seizure, or there is comorbid sleep disorder like OSA. So NREM parasomnias are mostly disorders of arousal, and they are defined as recurrent episodes of incomplete awakening from the sleep associated with inappropriate or absence responsiveness with limited or no cognition of the dream imagery. The important features are patient may appear confused. There may be important types are confusional arousal, sleepwalking, sleep terror, and sleep-related eating disorder. So these parasomnias are usually characterized by single episode in a night, During first third of the nocturnal sleep, they happen. Postictal confusion in NREM's parasomnias is there for a few minutes or more, and sometimes more than one parasomnia may be there. They usually are seen in children and resolve spontaneously by puberty. Differential diagnosis is nocturnal seizure or RBD. Pathophysiology exactly is unknown, but it seems that it is due to interplay of some areas of brain are active, some are hypoactive, leading to NREM parasomnias. There are specific triggers to the parasomnias, NREM parasomnias, like if there is increase in slow wave sleep. Sleep deprivation will cause patient to fall asleep early, and slow wave component will increase. And these NREM parasomnias are seen usually in the deep slow wave sleep. So if slow wave sleep content is more, parasomnias are more likely to occur. So sleep deprivation, zolpidem, lithium, these drugs can trigger slow wave sleep, and so parasomnia. Sleep fragmentation, OSA, chronic pain, narcolepsy, external noise and light, fewer late physical activity, anxiety, emotional stress. And another important feature of these parasomnias is the family history may be found in, and there is very strong family history can be seen in 80% people. Confusional arousal overall prevalence is 4.2%. The child or patient arises with confused behavior while in bed in the absence of terror or ambulation. Child may have a staring look or sees around, unresponsive or partially responsive. There may be murmuring or blunted response or crying. Duration is generally few minutes to 40 to 60 minutes, or onset is usually before the age of 5 years. Sleepwalking, it has got prevalence around 15 to 30% for sporadic episodes and 3% for the frequent episodes. When it is frequent, this is abnormal. It is a complex behavior which is starting during arising from the slow wave sleep. Patient may leave the bed, and there may be automatic behaviors like standing by the bed, walking around, leaving home in an agitated manner. There may be semi-purposeful behavior like eating, drinking, vocalization. And if you try to restrain the patient, you may find the patient becomes aggressive. Average duration is about 10 minutes. Age of onset is 4 to 8 years. Again, strong family history. Now, sleep terrors, the prevalence is around 1 to 6% and slightly more in boys. Age of onset is usually 2 to 4 years. Here again, child arises from the slow wave sleeps, and there are prominent autonomic phenomena with expression of terrors. Sudden onset partial awakening with the loud cry, intense agitation, and there are prominent autonomic features like tachycardia, sweating, mydriasis, and they are usually of short duration, may range from 30 seconds to 30 minutes, and rare to occur more than once in night. Now, sleep-related eating disorders, their prevalence is unknown, more common in women, and usual age is third decade, characterized by episodes of involuntary eating, drinking, during arousal from the sleep, associated with diminished awareness and subsequent recall. This is the actually summary of the differences in the clinical feature. We can say that night terrors have prominent autonomic phenomena, sleepwalking have complex behavior, and simple motor behavior can be seen during confusional arousal. The threshold from the arousal threshold is high in all of it, and post-ictal amnesia of the event is seen in all these disorders, and a very strong family history. Differential diagnosis is nocturnal frontal lobe type of seizure can be have like this. There can be night terrors or panic attacks during sleeps due to psychiatric comorbidities. Now, how to differentiate from the seizure if it is happening during night? Now, parasomnias generally start with arousal behavior. Normal arousal behavior may be seen, like eye opening, rubbing eyes, stretching limbs, or yawning. These may be seen. While seizures have abrupt onset and may be associated with some type of tonic or dystonic posturing. They typically occurs first 3 hours of the sleep, first third of the sleep, and seizure will occur any time during the sleep. Ictal pattern is variable from one event to another. The onset is slow and offset is slow. Here the behavior is stereotyped. Each type, same behavior will be repeated. Abrupt onset, duration is less than 2 minutes generally. Triggers are present for the parasomnias, while they are uncommon in frontal lobe seizures. So maybe these are some clues which can differentiate seizure. Otherwise, we will need a video electroencephalography. Now, management is only, as I said, medical management is limited to the mostly general, which is maintaining good sleep hygiene, avoid sleep deprivation, avoid environmental stimuli, and address if there is comorbid sleep disorder. This is how to prevent them to happen. Safety measures we should adopt for the sleepwalking individuals. And if a bystander notice, a sleep phenomena, then guideline for him is to just observe, permit this episode to run its own course, intervene only if the patient is going to injure himself or avoid physical restraining. A specific treatment is like if that kind of parasomnia is occurring at particular time every day in night, so we can do the scheduled awakening before 15 minutes of that time. So this will actually break the slow wave onset of the slow wave sleep, and patient will not have that event. Pharmacotherapy, the drugs which are actually which can induce a normal sleep, like melatonin, benzodiazepine, can be tried, and if coexisting other disorder is there, we should refer to sleep specialist. REM sleep parasomnias, the characteristics are they are linked to specific REM sleep stages, occur during the second half of the night. Dream enactment behavior is there, and absence of mental confusion post-ictally on awakening. In NREM sleep, there is post-ictal confusion. Here, there will be no post-ictal confusion. Patient will be awake and alert. Now, types are REM sleep behavior disorder, nightmares, and sleep paralysis. I'll go to one by one. I'll take 5 minutes more. So, RBDs are usually seen in elderly with neurodegenerative diseases. And if they are found in children, then we should think secondary cause. Any midbrain or pontine level sol or any infectious pathology or autoimmune pathology might be there. We should think secondary cause in children and adolescent people. They are characterized by unpleasant dream with complex motor acts. These motor acts may be small hand movements to violent activities like punching, kicking, leaping out of the bed, and that may hurt actually bed partner. Dream recall is usually present, and pathogenesis is linked to the absence of REM sleep associated muscle atonia, which we expect in REM sleep. It does not happen. That leads to the enactment of the dream behavior. Treatment is treat specific cause, and REM suppressing agent can be used like benzodiazepine. This is very commonly seen in extrapyramidal disorder, because the synuclein, Parkinson's disease has got some role to play in REM sleep promoting neurons. Now, nightmare disorders are seen in 1 to 6% children. They are recurrent, highly dysphoric dreams with disturbing mental experience, often resulting in awakening. There is rapid transition to an alert and oriented state. Little or no motor activity due to muscle atonia. This differentiates nightmare from the RBD. Dream recall is usually present, and emotional contents of nightmares are generally negative. Post-traumatic stress, watching violent electronic content.
Sharma ji, we all are awake now.
Before sleep may be trigger. Treatment is mainly reassurance. Now, recurrent sleep, isolated sleep paralysis, periods of inability to perform voluntary movements during wakeful state from the sleep. They can be hypnagogic at the onset of sleep, hypnopompic at the time of waking up. It occurs due to persistence of REM atonia into wakefulness. I think somebody at some point of time would have noticed he is unable to open eyes and seems paralyzed and is frightened. The individual who experience sleep paralysis are conscious and alert but feel paralyzed. All the muscles except diaphragm and extraocular muscles are involved, and episodes last for few minutes to few seconds. The hallucinations may occur during these events. Sometimes one may feel like someone is standing side by. They are common during adolescence, and around 6 to 40% prevalence is there. Sleep deprivation and stress may trigger isolated sleep paralysis. Treatment is reassurance. Generally, they are benign in nature. Maintain good sleep hygiene, and medication if needed. REM suppressing agents like tricyclics, alpha-2 agonist, clonazepam may be tried. I think I will stop here, Anna. There was one more slide, but these syndromes are not very important, not often seen. So, in summary, parasomnias are common and usually seen in children, mostly are benign and self-limiting. Sleep deprivation associated with other sleep disorder may exacerbate parasomnias. They are, if they are stereotyped and brief, then one may need to think about the possibility of seizure. Polysomnography is generally not required for the diagnosis, and mostly non-medical treatments like maintaining sleep hygiene, sleep extension, and safety measures are needed for the treatment. Thank you very much.
So thank you very much, sir. It's a very wonderful lecture given by you, because we are able to understand the neural pathway regarding the parasomnias. Although this is the disease which is the part of only to know about it's the clinical history only, because as you said that the polysomnography is not a tool to diagnose it. So very important that we should ask all the clinical history related to all these things, and again the management part, reassurance and things to be. So it's a very well excellent. It's a very wide sleep disorders there are, and you enlightened us to parasomnias, because we as a chest specialist, we are very fond and very like that the most of patient only we get is the obstructive sleep apnea, and we able to manage it, but it is very untouched topic, parasomnias. We also do not get so much patient about related to this. Maybe this is the these patients are going towards the neurology and all these things. So very thank you so much to explaining about these parasomnias very well. Thank you.
You want to speak something?
Thank you, sir, for a wonderful talk. Many times as a clinician, we are confused between the parasomnias and nocturnal seizures. But after listening such a vast talk on this, our concept has been cleared related to clinical and as well as of sleep physiology also. Thank you, sir.
Sleep terror is a one condition which can actually, we can get confused with the frontal lobe type of seizure. That is also basically orbitofrontal origin seizure, in which screaming or those kind of thing happen. So if there is doubt, we need to do overnight video EEG recording and record the event to actually distinguish whether it is sleep-related disorder or true seizure. Yes, sir.
So before inviting the questions from audience, I want to say something which is a sort of clinico-philosophical in nature. So we all are concerned with physical and mental health, right? And apart from that, emotional and spiritual. But we are neglecting our sleep health. And I think sleep health should have an equal emphasis, because your good sleep health will enhance your physical, mental, emotional, and spiritual health. Second point is, if you have a good sleep hygiene, your productivity will be much more, your decision-making ability will be much more, and definitely you will gain much more in your life. Dr. Sharma, thank you very much for this nice overview of parasomnias. Thank you very much.
Thank you, sir, for enlightening us with your knowledge. May I please request Professor Ved Prakash, sir, to come on the stage and felicitate our speaker and chairpersons. Sir, please felicitate Dr. Praveen Kumar Sharma, sir. Dr. Praveen Kumar Sharma, sir. Dr. Rajesh Verma, sir. Dr. Rajesh Verma, sir. Dr. Rakesh Chaudhary, sir. Dr. Rakesh Chaudhary, sir. Dr. Harish Nigam, sir. Dr. Ankit Khaitan, sir.
It is fascinating that the first ever reported detailed description of a person with sleep-related breathing disorder who would often fall asleep during his daily routine was described not by a doctor, but by a novelist, Charles Dickens. In his first novel, The Pickwick Papers, the term for which was later coined by doctors as the Pickwick syndrome, based on the novel's lead character, Samuel Pickwick. That what we know today as the obesity hypoventilation syndrome. To detail further on it, we have our next sessions. For our next session, that is the focus on CSA and hypoventilation, may I request the chairpersons to please grace the stage and take their seats. Professor R.A.S. Kushwaha, sir, Professor of Respiratory Medicine, KGMU. Professor Rishi Sethi, sir, Professor of Cardiology, KGMU. Dr. Rachit Sharma, sir, Assistant Professor, Eras Medical College, Respiratory Medicine. Dr. Jyoti Bajpayee, ma'am, Assistant Professor, Department of Respiratory Medicine, KGMU. Welcome, chairpersons. I now request the chair to kindly introduce our speaker and take over the session. Thank you.
So good morning, everybody. First of all, I would like to thank Dr. Ved for inviting us for this important CME session. So the speaker for this session is Professor Dept Gothi. Ma'am is a great researcher, renowned academician, and her work in sleep medicine is tremendous. She is professor and head Department of Pulmonary Medicine, ESIC, Basaratpur, Delhi. So I would like to invite ma'am for the lecture, Dr. Dept.
Thank you so much, sir, for kind words. I would like to congratulate and thank Dr. Ved Prakash for conducting a CME for an important topic. My topic is I want to go into the salient aspect of sleep apnea, and I'm very happy that all parts of sleep are covered, not only obstructive sleep apnea. Generally, we think sleep is equal to obstructive sleep apnea. No, it is much more than that. And I'll try and bring out some salient features which are important. Now, that's how I have first slide put it as what eyes does not see, what mind does not know. So one has to keep eyes and ears open, but before that, one has to know. And these knowledge base in terms of salient features are very important. Please try and listen to it carefully. So there was a 70-year-old gentleman. He was admitted, he was ex-smoker, he was admitted in casualty and in a gasping condition because of atrial fibrillation. He was intubated in casualty, and soon he could be extubated in a day or two. He had similar such episode a few months ago, and that time also he was intubated and could be extubated very easily. On detailed inquiry then, when he was admitted with us and when he was extubated, he gave history suggestive of something like AECOPD and sleep disturbance. That is a normal one, but when we went into the detail, we realized that he should be treated much differently. He had history of diabetes, he had myocardial infarct, he had CABG 3 years ago. He was on oral hypoglycemic, his HbA1c was okay, 6.5. He was on statins and he was on inhaler. When we examined him, he was average build. A normal COPD, if you know, they are thin build, but this man was average build. His saturation on room air was 96%. Normally, when you have a COPD who get extubated, they first don't get extubated very easily. He got extubated easily, and his saturation after extubation was something like 96% on room air, which is very good. Now, BMI was also not very low. It was 22.7. It was not very high though. And his neck circumference and BMI, etc., did not fit into OSA kind of a feature. His Mulder-Putty score was also good. Stop bang was 4 plus and minus. 2D echo, which was done 2 years ago, which showed a presence of akinetic inferior wall and LVEF somewhere between 40 to 50%, 40 to 45%. His ABG, if you see carefully, I don't know if there are how many students are there, and if somebody can actually point out the abnormality in ABG, if you all know how to write ABG, you should know that first part is usually the pH, the second part is CO2, the third one is PO2, and the fourth one is bicarb, and fifth one is saturation. So if anybody can point out any abnormality in ABG? What is wrong with the ABG? Or nothing is wrong with the ABG. Any idea? Huh? You would not call alkalosis, it is actually respiratory alkalosis, CO2 washout. So there is a low CO2 on the ABG. His FEV1 was fair, 1.3 is a good actually for somebody to go on ventilator. NT-proBNP was 250, normal limit is about 125. 250 is abnormal, did not have much of pulmonary hypertension or right heart problem. Can it be OSA? Can it be CSA? Can it be hypoventilation? Now the points which go in favor of OSA are that he was COPD with a reasonably preserved body mass index. When you have a reasonably preserved body mass index, that's a common manifestation of COPD with OSA. He did have sleep disturbance, etc. He did have a little bit of snoring. But there's something which was in favor of CSA. And what was that? Snoring was very simple snoring. It was not a loud kind of a snoring. He had presence of cardiac dysfunction and normal ABG, or what is called as a low CO2. And NT-proBNP was on a higher side, which suggested that he had a little bit of cardiac dysfunction or a left ventricular dysfunction and with a low CO2. He could have had hypoventilation too, but something which went completely against hypoventilation was that he had a normal or a low normal CO2. Somebody who is hypoventilation and gone on ventilator, when he comes out, he's not likely to have soon a normal or a low normal CO2. So that is something which you must look after in your clinical practice. This was his PSG epoch. It is a gathered one, I think 2 minutes or 4 minutes, 2 minutes, which shows presence of central hypoventilation and crescendo central apneas and crescendo decrescendo kind of a pattern, if you can identify. These are the diagnostic criteria for CSAs. Morning it was discussed the criteria for CSA. Criteria for CSA are similar to that of OSA. You require a 5 central sleep apneas, and when you have a central and obstructive sleep apnea both, 50% of them, more than 50% of them should be central sleep apnea. Also must remember that they can have atrial fibrillation, just not necessarily have a respiratory disturbance. So this man of ours had atrial fibrillation because of central sleep apnea. So atrial fibrillation, when you see, please, alert your mind and keep that. What I was saying, that what mind does not know, the eyes will not see. So when you see an atrial fibrillation, it should blink in your mind that it could be sleep-related disorder. It could be central, obstructive, whatever. Chain stroke breathing, 40 seconds epoch shows crescendo decrescendo patterns with 3 apneas or hypopneas and any absence of any other abnormality. Pathophysiology of CSA is little interesting and very, very complex. I've tried to simplify and try and tell you in 2 minutes. Please listen to it very carefully. Now, when you have central sleep apnea, it can be hypoventilation or hyperventilation related. Now, that hypoventilation related central sleep apnea is something that you see commonly with neurogenic tumor, neuromuscular disorder, etc. Rarely do, your COPDs will have a central sleep apnea due to hypoventilation. They just have plain hypoventilation. They don't have central sleep apnea related to hypoventilation. Whereas hyperventilation related central sleep apnea is classical of what is called as a chain stroke breathing or due to left ventricular failure. And this is much more common compared to the other one, at least in our clinical practice. Now, when you have the central sleep apnea related to hyperventilation, what is the pathophysiology? That is what I will cover. First and foremost part of it is you have what is called as high chemosensitivity. Now, when you have a high chemosensitivity, this is what I'm meaning by high chemosensitivity. This is your awake response of CO2 to alveolar ventilation. Means when you have a rise in CO2, how much of alveolar ventilation increases. So it is fairly like a slant. In sleep, it is not as awake, the center is sleeping, so it's not as good as what is in awake. So the response to increase in CO2 will not be as good. So that's that B. In patients who have hypoventilation related central sleep apnea, this is what it will be, because they don't just sense CO2 very easily, and that's why they kind of keep accumulating CO2. But when you are talking about hyperventilation related sleep apnea, central sleep apnea, they have like this. They are very, very alert, and they are, as soon as a little bit CO2 rise happens, they start hyperventilating. So one of the parameter that CSB or low CO2 can also give rise to central sleep apnea is that they have high chemosensitivity. The second part, which is a high loop gain. Now, all of us breathe with the loop gain, as in you have a center which is called as a controller. You have a periphery which is called as a plantar, and you have what is called as a feedback, that is a circulation. So when you have a patient who is having a high loop gain, what happens is the amount of CO2 is there in the system, that there is proportionately higher increase in the ventilation. There is a circulatory delay by the time it goes to the center. Center responds it, they keep hyperventilating. And they keep hyperventilating by the time it comes, that part of a loop wherein they respond much more than otherwise is further aggravated because of cardiac failure, because of the delay, circulatory delay. Then there is one more problem that happens in them, is what is called as a low apnea threshold. The low apnea threshold is like this. Apnea, this is what is apnea threshold. What I mean by apnea threshold is, his CO2 is at certain level. Now that certain level is what it drives it to keep breathing. Now when it goes below that certain level, which is this level, if it goes below that level, the person stops breathing because the CO2 is too low. So the center gets a symptoms or it gets a signal that you should stop breathing. Now this CO2 reserve, because they are cardiac failure, they are anyway congested. They keep hyperventilating in the daytime because of the congested lung. They have a low CO2. Now when they sleep in the night, the reserve is very low. And when that high loop gain and everything gets aggravated, they easily go into this apnea threshold. So the low CO2 reserve, which leads them to what is called as a central sleep apnea, and this is how they behave then. They come to, they remain salient. That's why my point was, they remain salient. And when they remain salient, you are the one as a physician to pick it up and treat it on time. So what is the management? The management is, it is a tailor-made management. First, control and stabilize the cardiac disease. Confirm, of course, with your sleep studies, ABG, 2D echo, and as I said, anti-pro-BNP. Anti-pro-BNP plays an important role in guiding you. LVF, if it is less than 45%, then myocardial scintigraphy to confirm the cardiac, you do MRI and confirm basically that there is a chance of cardiac failure. Otherwise, anti-pro-BNP itself is good enough if you don't have those facilities. It is important to find out what is NYHA class, because NYHA class is what decides the treatment. NYHA class, which decides the treatment, will, based on this, I hope you can read it. Yes, you can. There are 3 trials. One is called as CANPAP trial, second one is called as SERV-HF trial, and the third one is called as ADVENT trial. The CANPAP trial and SERV-HF trial basically reduce the role of ASV, that is adaptive servo-ventilator. But the newly picked up trial, which is ADVENT trial, wherein the mechanism of giving the adaptive servo-ventilator has been changed from MV, that is minute ventilation, to peak flow, and has now succeeded a little bit. But still, because of these first 2 trials, this flow chart remains the same. So if you have NYHA 3-4, or if you have the ejection fraction which is less than 30%, then you cannot give ASV. That is, you cannot give ASV. If you have ejection fraction which is more than 45%, then CPAP after correcting the cardiac failure. CPAP will help after correcting cardiac failure. Between 30 to 45, one has to take case by case. You give CPAP, it doesn't work, you can give ASV, that is PF, the newer variety of the ASV. I have a little time, I don't have much time. Somebody needs more information than that, please come to me and discuss it. Back to our case, our patient was optimally treated for cardiac function. He was titrated at 8 centimeter, and he has continued CPAP for now more than 3 years, and he has not come back in casualty, unlike back-to-back 2 intubations that he required. Now back to hypoventilation, somebody mentioned Pickwickian and all, he gave a good story. The only thing I will not be covering is really not obesity hypoventilation syndrome right now, because COPD with hypoventilation is more prevalent, and obesity hypoventilation syndrome does not meet what I does not. So I wanted a theme of what you can't see should be able to see. Obesity hypoventilation is all over, you can make out very easily, and the treatment of it is primarily treatment of obstructive sleep apnea. So I will be covering the second one, and just a brief up on normal sleep. Quickly, in normal sleep, all of us hypoventilate, and how we hypoventilate is by center sends less signal to the periphery. Even periphery, that is the respiratory system, functions poorly. The bucket handle movement, etc. is poor. The diaphragm is up. There is bronchoconstriction in the night. All these factors together make us skeletal hypotonia. All this, in NREM, your minute ventilation decreases by 10%, and that in REM, all of us, have a decrease in minute ventilation by 20%. So 10 to 20% is normal. Now going to the patients who already have respiratory disorder, like your COPD, like your neuromuscular disorder, like your kyphoscoliosis, etc. They have a further decrease in the CO2 at night, or they further hypoventilate in the night, and to the extent their minute ventilation decreases by 20% in NREM and 40% in REM sleep, because of which they have reduction in reduction in PO2 at night and increase in the CO2 in the night. So somebody who's borderline will dip further in the night, and when they dip further in the night over a period of time, the normal gas exchange also, there is a reset, and you keep having accumulation of bicarb. That over a period of time will lead to further respiratory depression and CO2 accumulation in the daytime also. So they have a borderline abnormality when they meet to you in the OPD, when they come to OPD. You do their ABG, you do their bicarbonate, you realize that they have a high bicarbonate. And these are the patients who get hospitalized with ARF. The minute change in the homeostasis, they get admitted. Little bit of respiratory infection, little bit of abnormality in the breathing, they get admitted and they require NIV and stuff like that. But if we catch them before, they will be able to live a much better life. So the disorders which can cause hypoventilation are many, but by and large it is neuromuscular disorder, chest wall abnormality, lung disorders like COPD, advanced disease, and ventilatory control abnormality. Definition is interesting. You have, this is ASM defined one, more than 55 PCO2 in the night for 10 minutes, or 10-minute elevation in CO2 above 50 and 10 millimeters above the baseline. So if they have 40 baseline, they go beyond 50 for 10 minutes in the night, that is also hypoventilation. So that's the definition of hypoventilation. Clinical presentation is usually not significant. They are asymptomatic and they'll just roam around without much of a distress or complaint to you regarding disturbed sleep unless you poke and probe. Diagnosis is easy. It is with CO2 monitoring as far as possible, type 1 study. And the patient, if he has undergone type 3, please try and ensure that it is type 1 study and you do the REM sleep. Lack of REM sleep itself can be diagnostically important for the sleep hypoventilation. The saturation may be helpful, but what is most important is CO2 monitoring. The CO2 monitoring is done by invasive arterial, just keep the arterial line and keep drawing the ABG in the night without disturbing them. Or a better way is by doing a ET CO2 or transcutaneous CO2. The ET CO2 is something which costs about 2 lakhs, 1.5 to 2 lakhs. Transcutaneous CO2 which costs around 12 lakhs. The transcutaneous CO2 and ET CO2, as far as the diagnosis are concerned, not much of a difference, because ET CO2 can diagnose much more easily. You just apply in the night, and I'll show you the subsequent figure. Whereas TCCO2, you have to keep changing the position because it gets perspiration and it keeps accumulating the sweat. So for your monitoring purpose in terms of pressures required, you require transcutaneous CO2. But otherwise for diagnosis, ETCO2 is good enough. And monitoring, if you don't have TCCO2, you can monitor with the help of ABG every day morning. Keep increasing the CO2, keep increasing the BiPAP levels, and you have the ABG follow-up, and then you'll be able to get your pressures. This is the ETCO2, or this is attached to our sleep machine. When you attach to the sleep machine, this is what it looks like. You'll have one of the parameters like oxygen, the CO2 values, and this is how the final report will come. We'll tell you that for how long the patient has had how much of CO2, and then the diagnosis becomes very easy. The treatment is oxygen alone, of course, may not help. So you'll have to have either a CPAP or a BiPAP. CPAP may be beneficial in certain cases of OHS, that is obesity hypoventilation syndrome. That obesity hypoventilation syndrome is the only hypoventilation syndrome which improves over a period of time. Yesterday only I had a patient in the OPD who was discharged because of obesity hypoventilation syndrome on BiPAP and oxygen. When she came to me yesterday, she was carrying her saturation probe in her pocket and she was saying, "Mera 99 ke upar rehta hai aajkal." So she was roaming around without oxygen and she now did not require oxygen. The point I'm trying to tell is that that is the only hypoventilation which improves over time. You treat them with CPAP, BiPAP, whatever you have, they will improve over a period of time and oxygen may not be required. Your BiPAP, if it was required, only CPAP they may be requiring. But the other hypoventilation all worsen, like COPD, like your kyphoscoliosis, like neuromuscular disease. So when you're dealing with OSA, you may treat with CPAP alone, that's good enough. But when you're dealing with other hypoventilation, please treat it with BiPAP. Please try and treat it. If you can't, then even CPAP, small amount of CPAP will do, but it is important. The other part is that when you have COPD with, COPD patients coming to you and you suspect hypoventilation, please try and eliminate obstructive sleep apnea, because many obstructive sleep apnea with COPD, they behave in a similar manner, except for the fact that those with OSA and COPD will have a higher lung function. So like my first patient was, they had a higher lung function. But that with hypoventilation will have a lower lung functions. So the point to be remembered here is that please eliminate obstructive sleep apnea, because by and large BiPAP means we give 8, 12, 8, 16. We don't try and eliminate the OSA part and then their hypoventilation or their CO2 gases will not improve. Please remember to eliminate them. AVAPs can be useful in some of the patients. Titration is easy. First, titrate with the help of CPAP, eliminate the obstructive apnea, then try and improve, make sure that saturation is more than 90, switch to BiPAP with the IPAP more than 4 millimeters above the EPAP. So once you eliminate obstructive sleep apnea, you know what is the EPAP and then IPAP. If they're still not being titrated well or oxygen is still less, then you can add the oxygen. So first CPAP, then BiPAP, and then oxygen. That's the titration. Quickly, the case vignette, if you want me to eliminate, I can eliminate this. But this patient, I'm trying to say that this patient came to me and I had picked up sleep hypoventilation in him. He's COPD patient. Sleep hypoventilation did pick up, but then the guidelines are not such that I could treat with BiPAP or oxygen. He came after 6 months in a full-fledged acute respiratory failure, the kind of manifestation that I was saying. He was admitted in acute respiratory failure, and then I gave him a BiPAP and LTOT. He followed up 3 to 4 days ago with normal CO2, and he is doing okay. He's doing well. So take home, central sleep apnea and hypoventilation is something like what eyes does not see, it does not, what one does not know, eyes will not see. It may present with sleep disturbance. There are 2 types of central sleep apnea, hypercapnic and hypocapnic. One must remember that hypercapnic is the one which is easy to treat. Hypocapnic, or the one with cardiac failure, difficult to treat. One needs to, tailor-make the therapy. Mechanisms, I did explain to you. Somebody really wants to understand further, please come to me. Treatment of the central sleep apnea with CSB is usually cardiac failure and CPAP or ASV. Hypoventilation is because of multiple reasons. The management of hypoventilation is BiPAP, and OSA should be ruled out before COPD, before treating with BiPAP in COPD. Thank you. Thank you.
Thank you very much, ma'am, for enlightening us this beautiful talk. And you have covered all the practical aspect of central sleep apnea and hyperventilation. Your message is very loud and clear. You have to identify central sleep apnea patients, different mechanism, what are the mechanism, why this central sleep apnea happens, and very beautifully, ma'am, describe what are the newer guidelines. When the ejection fraction is less than 30%, don't give adaptive servo ventilation to your patients. So management is very important. And in obesity hyperventilation syndrome, madam already said, you have to identify all the causes of obesity hyperventilation syndrome before treating your patients. So thank you, ma'am. If any question from the, yes.
Very good morning, madam. I'm a cardiologist, so I'm a little less well aware, but we just turned to work on obstructive sleep apneas and the basic simple parameters. I got a little, 2 points. In your CO2 monitoring, you mentioned arterial cannulation is also non-invasive. Is it
No, it is invasive.
invasive? So that
I
slide.
said that maybe, yeah.
Yeah. That slide was.
Yeah, it is invasive.
So I thought
No,
the second
no.
second thing is that I got a little confused, and I'm more intrigued about the role of ASV. You said that's a parameter I don't understand. CPAP, ASV, and how it correlates to various ejection fractions. What is the basic, common language understanding of this game?
Okay, so adaptive servo ventilator was the ventilator which was discovered only for the treatment of central sleep apnea. When they discovered it, this is what is called as a PF variety. It was called as minute ventilation. So they tried and matched the minute ventilation by minute ventilation every breath. That was the mechanism of adaptive servo ventilator. Now first to come in the treatment was what is called as a CPAP, just a plain CPAP for central sleep apnea. Cardiac failure treated, but still central sleep apnea sometimes does not get treated. So CPAP was more. Now for the CPAP, there was a trial what is called as a CANPAP trial. Now CANPAP trial did not really improve the survival, did not give the survival benefit, though it gave the quality of sleep benefit, but did not give survival benefit. So then that ASV came into picture, that is adaptive servo ventilator, MV variety. Now based on that MV variety, there was something called as a SERV-HF trial. That SERV-HF trial bombed very badly. Means there was increase in the mortality in the treatment group. So then they tried and post-hoc analysis and all that. Then they realized that one of the reason why they died was they had severe this, and whatever the body mechanism, they had ejection fractions 25 or less. The patients who were taken into that trial were having less than 30%. So 30% and less LVEF did very badly. That's why it's a contraindication. Those with 30 to 45 did okay when their sleep apnea improved. So that's how this kind of a thing. Now then, to improve on that, they made a newer adaptive servo ventilator, what is called as a PF variety. So MV variety started with 415, means the baseline pressure they gave was 4. Now that 4 pressure also was too much in some patients, and that also probably caused hyperventilation and worsening. So that PF started with 0 pressure, and plus it picked up the obstructive sleep apnea and treated it. And based on that, Advent-HF trial came, but because of that SERV-HF, there was a black box warning, and the number of patients recruited were like 1/10 of what was recruited in the previous trial. Now that because the number was not that good, it didn't meet the endpoint efficacy variable, that is survival benefit, but it did help in improving the quality of life, improving the number of exacerbation, admissions, etc., and overall, quality of life.
So the lower the ejection fraction, if it's low ejection fraction, it will be probably CPAP, and if higher the ejection fraction, then CPAP plus minus ASV.
Yes, based on the trials.
Sure, thank you. Thank you so much.
Thank you, ma'am, for the wonderful session. Now the questions are to be, if any questions from the house, it is open. Any PG student?
It's a very pragmatic point of view, perspective of the central hyperventilation syndromes. I'm a neurologist. I'm just curious to know what are these anatomico-neural correlates of central hyperventilation syndromes. Even to say brainstem structures like total rapid nucleus.
Central apnea syndrome.
Yes.
Central sleep apnea syndrome.
You're talking of central hyperventilation?
So in hypoventilation,
you
I
have
covered neuromuscular disorder, I covered
transmitters theory. I want to have some idea about these anatomical correlates of this hyperventilation. Central hyperventilation, not obstructive, central hyperventilation. Brainstem structures.
I did not cover in my talk central hypoventilation. What I covered was central sleep apnea. That was the first cardiac patient. The second part I covered was hypoventilation. In hypoventilation, I covered what is called as COPD related, kyphoscoliosis related, etc.
Because you talked about neuromuscular junction like myasthenia gravis, stroke, tumor.
So that is the.
So what are those structures affected basically?
Okay.
Apart from these disease state per se, where we can have early heralding manifestation of hyperventilation.
Okay, so that would be usually in terms of, so this will term as central sleep apnea. You can have a, head trauma, head injury, a central tumor, a stroke or anything which can give rise to suppression in the respiratory center, and that will lead to a hypoventilation related central sleep apnea. So that is usually medulla. So it's in respiratory center. Around this, any tumor, anything around the respiratory center, the center, that is medulla.
So, paucity of time, we are concluding this session. Thank you, ma'am, for enlightening us this beautiful talk. Thank you.
Thank you, ma'am, for that wonderful presentation. I now request Professor Ved Prakash, sir, to kindly come on stage and felicitate our guest speaker and chairpersons. Professor Deepti Gothi, ma'am. Professor R.S. Kushwaha, sir. Professor Rishi Sethi, sir. Dr. Rachit Sharma, sir. Dr. Jyoti Bajpayee, ma'am.
Did you know that till 1979, the gold standard treatment for sleep apnea was tracheotomy? And when patient of Dr. Colin Sylvan with severe sleep apnea refused to get it done, he asked him to participate in his experiment that he had done on dogs that was sending pressurized air through a mask into their snouts while sleeping. Patient agreed and the treatment worked. The patient had slept properly for the first time in last 10 years. That was the first CPAP titration in history. Our next speaker will throw some more light on this matter. For our next session of the day, Management of OSA, Positive Airway Pressure Therapy, may I request the chairpersons to please grace the stage and take their seats. Dr. Ajay Kumar Verma, Sir, Professor, Respiratory Medicine, KGMU. Dr. Ankit Katiyar, Sir, Assistant Professor, Respiratory Medicine, KGMU. Dr. Mohammad Arif, Sir, Assistant Professor, Pulmonary and Critical Care Medicine, KGMU. Dr. Atul Tiwari, Assistant Professor, Pulmonary and Critical Care Medicine, KGMU. Welcome, sir.
So after diagnostic and other criteria of sleep apnea have been elaborated by previous speakers, now it is time to management of OSA and role of positive airway pressure therapy. So it's my pleasure to invite my friend Dr. Hemant Kumar to deliver his talk on management of OSA PAP therapy. He is additional professor and head in Department of Respiratory Medicine, Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow.
Thank you, Chairpersons, for kind introduction. At the outset, I am very thankful to my Head of Department, Dr. Ved Prakash, my colleague Sachin, and Dr. Arif, who has given me this opportunity to speak in front of you. And this is my first lecture after going from this department. So let's start with PAP therapy in OSA. So overview of this topic was already given by Professor Dept Madam. So just I'm briefing it. So I am going to talk about some introduction, anatomy, pathophysiology, non-PAP treatment, PAP treatment. I'll talk about basic modes like CPAP, APAP, BPAP, advanced mode, already spoken by Dept Madam, interfaces, and at last concluding remarks. So I'll start with the real case scenario. This photo is not original, but case is original. So he is a 55-year-old male, obese, with BMI 32, known case of uncontrolled hypertension, diabetes, and he met an RTA brought to emergency. So he was obese patient, met in accident, and managed well. And after stabilization, further history was taken. He was found to have snoring, daytime sleepiness, fatigue, lack of interest in doing work, past history of CAD, and underwent angioplasty. So this is classical history, classical presentation by which patient used to present in emergency or any department. This is classical one. So these type of patient, they don't come directly to the sleep physician. Either they used to send by physician for uncontrolled diabetes, hypertension, or any cardiac problem. Many times they used to brought by their wives for loud snoring, that wife is not able to sleep in same room. And many times they are supposed to visit sleep physician by job authority like a pilot job or truck driver. A very less amount of patient, less many patients, they used to come self by complaining that they have excessive daytime sleepiness. So this is classical case scenario we used to have patients in our day-to-day OPD. So just brief about anatomy. We know that upper airway is extend from posterior margin of nasal septum to larynx. So it has 4 parts, and the middle 2 parts, that is retropharyngeal oropharynx and retroglossal, means area behind soft palate and area behind tongue. This is very prone for collapse because it don't have any rigid bony support. So whenever there is negative pressure inside the upper airway, it used to get collapse. So what happened during sleep? In daytime, there's no problem. Patient can manage. But while sleeping, there is loss of wakefulness drive. It's already covered in physiology. And loss of chemoreceptor sensitivity. It causes hypotonia of this upper airway respiratory muscles. So what happens? It gets collapse. Tongue and the soft palate fall backward while sleeping and obstruct upper airway. So this is how OSA used to get developed This is pathophysiology by brief. So once airway is getting collapsed, it leads to hypoxemia, and because of hypoxemia, many complications are there. And while obstruction is there, the chest cavity is trying to open it by creating negative pressure. So negative pressure, patient used to get up, they used to have sleep fragmentation. So excessive sleep fragmentation, hypoxia, and negative intrathoracic pressure, they lead to many problems like sympathetic surge, oxidative stress, inflammation, and they used to do all type of disease like cardiac disease, neurological disease, this arrhythmia, diabetes, all these complications is used to happen by this mechanism. So it is essential to identify these problems and we are supposed to treat. So coming to my core topic, that is management of OSA. In OSA, if we classify by American Academy of Sleep Medicine, it is 3 types: mild, moderate, severe. We can identify by sleep study. So mild is 5 to 15, 16 to 30, and more than 30. So 5, 15, 30. This is mnemonic for that classification. So coming to my uncle again. So he was suspected to have OSA because he was having high BMI and all comorbidities and met an accident. He was advised sleep study. Now he has to be questioned whether I should undergo home study or hospital-based study. So remember, if any patient, those who are having multiple comorbidity and already got accident and the patient is obese, so we have to do hospital-based study only because we have to identify all sorts of problems like central sleep apnea or carbon dioxide, anything. So we have to do hospital-based study only, no home study. So patient underwent the sleep study and RDI was 65. So this fall in severe OSA. And before managing any patient, we have to rule out hypercapnia because treatment may differ. If patient is having high CO2, the treatment may differ in the form of BiPAP of any other modality. So in this patient, PCO2 was normal. So he was having pure severe OSA. So goal of treatment in this type of patient is we have to reduce sleepiness, improve quality of life, and important is that this treatment will decrease long-term cardiovascular consequences because the cause of mortality in this type of patient is due to MI, arrhythmia, or any cardiac comorbidities. And of course, reduce morbidity and mortality. So OSA management, this is not a single disease, but a spectrum of disease. So we should consult our all colleagues like dental people, ENT people, gastrosurgeon. Then by multimodality only, we should do treat. So I'll focus upon medical management because surgical and dental management will be dealt by another speaker. So overview. So I'll talk about supportive care, PEP therapy, and other management strategies. So before advising treatment to any patient, we have to explain the severity of disease, consequence of disease, what will happen if they will not get treatment. Because OSA is OSA is disease that people don't accept easily. जैसे आपने देखा होगा कि patient snoring है, उसको मानेगा ही नहीं कि आपको disease है. So we have to explain, we have to do counseling, we have to explain what is the risk factor for worsening OSA like obesity, smoking, excessive alcohol consumption. Consequence of untreated OSA. If you don't treat OSA, it may lead to heart disease, hypertension, which would be resistant, stroke, diabetes. So we have to explain patient before treatment. Increased risk of motor vehicle crashes, like my uncle in previous case scenario. So this causes excessive daytime sleeping and patient used to met in accident. So we have to explain if they are working in pilot or truck driver, so they should avoid activity requiring vigilance because it may cause accident. And if there is female with childbearing age, we have to explain that OSAs not only harm you, it will also harm your baby in uterus. So these counseling we should give to patient before treatment, then only patient may accept. Notice, may accept. We cannot take guarantee that patient will accept, may accept. Now, this is the first advice physician used to give or patient used to ask. If I lose weight, my problem will be solved or not. So what American Academy of Sleep Sciences says about weight loss, that weight loss we should advise, but it is not primary treatment. So we should give treatment, other treatment along with weight loss, because weight loss reduce pressure requirement. And the problem is, if patient will lose weight, OSA will get cure, but it may recur in future. So we have to explain patient that you can lose weight, but don't depend on weight losing only. You have to take primary treatment in the form of PEP or dental device or anything else. Bariatric surgery, it is adjunctive only. It's not primary treatment, because after surgery also, 1/3 of patients, they used to have residual OSA, residual high AHI. So along with bariatric surgery, they need PEP therapy, preoperative as well as postoperative. So this is non-PEP modality, like patients in non-supine sleep position, like position-dependent OSA, they used to have mild OSA, less obesity. So in these patients, we can try positional therapy by keeping this pad on the back, so patient cannot sleep supine position, and we can tie this neck band. So this is accelerometer. So whenever patient will lie in supine position, it will vibrate. It will vibrate and patient will have the change position. So by this method, we can try in patients, those who are having position-dependent OSA. Now coming to PEP therapy. So PEP therapy, these are the various devices available in market, like CPAP, APAP, BiPAP, ASV, WEPs, etc. So what PEP we should choose, it's depends on patient condition. It's not our choice, but we have to explain patient and what is suitable for patient. So what ASM recommend for treatment, if any patient, those who have moderate OSA, he needs treatment. Any patients, those who have mild OSA but having symptoms of OSA, like daytime sleepiness, gasping, choking, habitual snoring. So even patient is having mild with symptoms, these patient needs treatment. If patients having any job like pilot or driver, even mild disease also, they should be treated. And patient, those having RERA more than 10 with excessive daytime sleeping, even if AHI is mild, then also they need treatment. But the dictum is, higher the HI, more compliant the patient with CPAP. If lower HI, patient may not comply with CPAP. So this is beautiful article, and in this meta-analysis, this patient was given positive airway pressure, and positive by PEP therapy, they have decrease in OSA severity, decrease in sleepiness score, patient decrease in nighttime systolic BP, mean BP, and diastolic BP. So PEP therapy is better than no therapy. So why CPAP initial treatment? Because it is most efficacious treatment which causes nearly complete resolution of OSA. So we should try CPAP in all patients of OSA, moderate to severe. So how this PEP work? CPAP means continuous positive airway pressure. So what does it do? In this diagram, you can see there is airway collapse by tongue and soft palate. So what CPAP do? It causes pneumatic splint. So in inspiratory and expiratory, both phase, it giving pressure which is not letting airway to close. So it keeping airway open. And second thing, by giving CPAP pressure, it increases FRC, functional residual capacity. So once lung is getting expand, it causes traction over the neck. So it pulling the neck muscles and causing airway opening. So these are two mechanisms by which CPAP function in pure obstructive airway disease, OSA. So once you will give pressure, more dilatation of airway. So this is directly correlation with the amount of CPAP. So initial preparation of patient. So what happens when we are diagnosing OSA patients, we are not counseling. So what we are doing, we are just giving PEP, this machine. So patient is not accepting. So we have to explain patient that he should need treatment. If we don't treat patient, what will happen? He will have cardiac comorbidity, all these things. So whenever possible, introduce the patient to PEP therapy prior to the titration of night. Encourage patient to accept therapy. Explain benefit, co and pros, and describe how PEP works. Like I have described in last diagram, you have to explain same manner to patients also. Explain rationale and side effect, and you have to anticipate patient concern and anxiety, and allow adequate time for question. Then only your patient will accept CPAP. Otherwise, he will apply CPAP for a week or two, then he will discontinue. So we have to explain why we are giving CPAP therapy. So coming to my uncle again, he was having severe OSA. He was advised CPAP therapy. He asked me two questions. How much pressure do I need in my PEP machine? So I told we have to do titration. We have to find out how much pressure is required to relieve your OSA. Second thing is where to do titration, at home or at hospital. So regarding titration, there are two types of titration, as already spoken by previous speaker. In lab titration, there benefit that a technician is there. He can the troubleshoot mask problem, humidification. We can identify treatment emergent central apnea, which we cannot identify in home sleep titration. And the problem is, patient may not have good sleep in the day, in the night when you are titrating the machine. So that is the problem. So in home, APAP titration is comfortable for patients. No, means the problem is that no trained technician, we cannot identify treatment emergent central apnea. So these are pro and cons for in-trap titration and home-based titration. So how to titrate CPAP machine? So this is like a glass. If you give glass of adequate power, then only patient will be happy and will bear the specs. So overcorrection or undercorrection will lead to treatment discontinuation. So this is how CPAP to be titrated. We should start pressure at 4, and every 5 minutes, we should increase pressure by 1 centimeter in each 5 minutes. So our aim is to abolish all apneas, all hypopneas, all RERAs, and all snoring. So you have to increase one by one until there is more than 2 obstructive apnea or 3 hypopnea, more than 5 RERAs, or 3 minutes loud snoring. So we have to increase it progressively. If pressure is more than 20, then we can switch over to BiPAP. So adequacy of CPAP titration is optimal, good, and adequate. So optimal is when by CPAP therapy, RDI is less than 5 events per hour. And he should have comfortable supine REM sleep. Then only it is optimal. Good is RDI is reduced to less than 10 or more than 50% if RDI is less than 15. But again, he should have comfortable supine REM sleep. Inadequate, if these two are there, optimal or good, but patient is not having supine REM sleep, then it is adequate. Or RDI is not reduced to less than 10 events per hour, but reduced by 75%. So these are optimal, good, and adequate. We have to mention in our report whether titration was optimal, good, and adequate. So auto titration by auto PEP machine. So it has flexible pressure. We have to give window of 4 to 20, and we have to titrate again. So this auto PEP will diagnose itself how much pressure needed during the night. So we have to give APAP for 7 to 14 days, and we have to see what mean pressure is coming, which is relieving this obstructive events. So this is P90 and P95. It means that 90 to 95% of time, all apneas, hypopneas are reduced. So this is the pressure we can give in auto CPAP. So CPAP or auto PEP, so indication for auto PEP. So any condition which can lead to variation of pressure, like use of alcohol, recurrent nasal allergy, wide variation of body weight, REM dominant sleep apnea. Limitation, it cannot detect inspiratory efforts. it detects only flow. So whenever a patient is struggling to take breath, it will not recognize and will not give pressure. Another thing is patient is having central sleep apnea, and that APAP will think that patient is having not flow, it will give pressure. So this is disadvantage of auto PAP. So if patient is feeling uncomfortable by CPAP, there's new mode called flex, C-flex or EPR. So in this, there's leave of pressure while expiratory, because in CPAP, there's continuous pressure in inspiratory and expiratory. So patient is feeling difficulty expiring while in expiratory phase. So if you release pressure by 1, 2, or 3, these are 3 flex level, so patient will feel comfortable. So like C-flex, there's flex in auto-PAP also, and C-flex plus. In C-flex plus, so not only pressure release in expiratory phase, but also comfortable in inspiratory phase. So at inspiratory, it reduces pressure. So in both phases, it's called C-flex plus. So my uncle, so lab titration was done, AHI was, that pressure requirement was 18, and he was uncomfortable. So what to do? So we have to give BiPAP. BiPAP is ST mode, S mode, or T mode. So these are indications. I'm not going inside. So BiPAP in OSA, BiPAP has 2 pressure, expiratory pressure and inspiratory pressure. Expiratory pressure is relieving obstructive events, and inspiratory pressure is relieving hypopnea, RERA, and snoring. So we have to titrate as we titrated in CPAP. So we have to start with 4, and we have to increase EPAP up to that obstructive event are going. It's same. Auto PAP, like auto CPAP, this is auto PAP. So pressure is varying over the night. Interfaces, very important. Many interfaces are there, but most commonly used are nasal and oronasal. So which one is better? So in chronic NIV, means you are giving NIV at home, nasal mask is best mask. For acute condition is oronasal. So remember, we should give nasal mask to all patients for OSA patients. Follow up every 1 to 3 months, we have to follow. We have to identify problem and we have to correct it. So coming to my uncle, he was given 12/16 this pressure, hypertension, diabetes were controlled, EDS gone, and he was very happy with treatment. He told, my life has, मेरी life change हो गई है, पता नहीं तब तक कैसे मैं जी रहा हूँ. So this is very wonderful treatment. If you give very good titrated pressure, patient will feel very happy. And more than him, his wife was happy because she was able to sleep. So last 2-3 slides only. So my uncle has asked few questions. How many hours per night should I use? So ideally 7 hours per night. This is ideal. Beyond 7 hours is no added advantage. But ESSM told that at least 4 hours in night for more than 70% of night is adequate adherence. How long should I use BiPAP? Then it's lifelong. What will happen if I don't use 2 to 3 days while traveling? Then I told that if you even not use for 1 day, then you will have excessive daytime sleeping and will have reduced work efficiency. So we have to carry CPAP along with you while traveling. If I lose weight, can BPAP can be removed? So I advise that it may be, but less likely. So this already cover, volume assured VAPs already cover. Pharmacological therapy, no FDA approval treatment for OSA. And to summarize, so lifestyle modification, because this is first treatment we should advise regarding weight loss, the alcohol abuse, role of sedatives, etc. PAP therapy, I have explained various PAP therapy, CPAP, auto PAP, BiPAP. Positional therapy, if patient is having positional sleep apnea, we have to follow regularly, because if patient will have side effect, patient will not apply CPAP. Pharmacological treatment, no use. So my uncle was using for 5 years and he's fully satisfied. So with this, thank you.
Thank you, Dr. Hemant, for excellent lecture on the management of OSA and also with the example of your uncle. Now, this session is open for questions and answers from the audience.
Yes, sir. Actually, lack of time, I didn't cover. I had slide. So, luckily, my uncle didn't have any problem. But patient used to have problem. Like patient, they used to have means increased nasal secretion or nasal dryness or this ulceration on that bridge of nose. So these used to have problem. And we have to apply, if there's nasal block, we have to apply that nasal decongestant or humidifier. Like that, we have to do troubleshooting, sir. Actually, I had slide, but I couldn't show you.
Has he gone any drug-induced sleep endoscopy and finding of any obstruction site in the?
No, sir. No, sir. He didn't undergo. And yeah, actually, by this sleep study and titration, he was happy. So we didn't think of any surgical management, sir. But he should have gone, sir.
Okay, thank you.
I think no more question. Thank you, Dr. Hemant.
Thank you, boss. Excellent talk.
Thank you, sir. That was an incredible session. It's always a pleasure and delight to listen to you. Now I request Professor Ved Prakash, sir, to kindly come to his stage and felicitate our guest speaker and chairpersons. Dr. Hemant Kumar, sir. Dr. Ajay Kumar Verma, sir. Dr. Ajay Kumar Verma, sir. Dr. Ankit Katiyar, sir. Dr. Muhammad Arif, sir. Dr. Atul Tiwari, sir.
Henry Gasta in 1964 presented the first diagnostic test to give complete picture of OSA and published it in 1965. And this was the first official sleep study which diagnosed OSA. At that time, we had only pulse oximetry, ECG, and EEG. But now the diagnostic modalities are quite diverse. So our next speaker will detail further on this. I welcome for our next session, Diagnostic Modalities in Sleep Apnea. May I request the chairpersons to please come on to the stage. Professor Darshan Bajaj sir, Professor of Respiratory Medicine, KGMU. Dr. Hemant sir, Additional Professor, Ramanohar Lohia Institute of Medical Sciences. Dr. Sachin Kumar, Assistant Professor, Pulmonary and Critical Care Medicine, KGMU. Dr. Prashantha AP, Assistant Professor, Pulmonary Medicine, Sanjay Gandhi Postgraduate Institute. Welcome, chairpersons. I now request the chair to kindly introduce our speaker, Dr. Mansi Gupta ma'am, and take over the session. Thank you.
So our next speaker is a very renowned faculty member from SGPJ, Dr. Mansi Gupta. She's a very good friend of mine, and whenever she is around me, she makes me a little bit more wiser. And she will be speaking on the diagnostic modalities in sleep apnea. So Mansi, stage is all yours now.
Thank you, Darshan, for the kind words. A very good afternoon to all of you. So I'll be talking about diagnostic modalities in sleep apnea, which is the first step to start managing your patients. As we have understood since morning that sleep apnea is a very common problem. However, it is very commonly misdiagnosis also because nobody is actually interested to diagnose this condition. We try to look for other factors which could be responsible for a person's ill health, and sleep apnea doesn't really come into a physician's purview till we actually, are told by some sleep specialists. So my idea would be to sensitize all doctors here, irrespective of their fields, as to how to go about diagnosing sleep apnea, where to start and how to do it. I don't know how the alignment has gone, but we are going to talk about this sleep apnea. So first we're going to talk about the screening tools basically, because they play a big step towards making a good diagnosis. So when do you want to screen patients? American Academy of Sleep Medicine is basically the organization in sleep medicine which is giving guidelines to all the physicians across the world, and it is the most advocated guidelines. So they say that physicians, they have to ask all adult patients about signs and symptoms of OSA as a part of their routine health maintenance evaluation. This is very important to understand that in all patients, whenever they're coming for their health checkup, this should be screened. Now, how do you want to know that which patients are having risk factors? So these are some broad risk factors which are, they can catch anybody's eye. The age, if it is an adult more than 40 to 70 years, he's a motor vehicle driver. It is very important to know if he has any symptoms of OSA. If there is a family history of OSA, genetics also play an important role. Male gender is almost 3 times as predisposed to women. Obesity, we all know obesity is a risk factor, so there is nothing much to elaborate on that. And post-menopausal women. So hormones also play a very important role. So once the women cross their menopause, their propensity to have OSA increases.
also as a part of preoperative evaluation for bariatric surgery, and otherwise also certain other surgeries, especially if you're targeting as a risk stratification. And retronadia. If you feel a patient has retronadia on clinical examination, these are the risk factors. Other thing is there are certain health conditions which have been associated, found to be having a good association. It is not a causal association, but it is an association that patients can have OSA. So if you are a cardiologist and your patients are having atrial fibrillation or congestive heart failure, uncontrolled hypertension, coronary artery disease, so the odds of having OSA is much higher. Similarly, for patients who are doctors who are in neurology or neuromedicine, if your patients are having depression, stroke, so these are also significantly causally associated with OSA. And diabetes is also one such association. So this is the patient, and now you have to ask him questions. What questions are you going to ask him? So patients, if you ask him about their sleep hygiene or sleep diary or whatever the sleep routine that they have, they may commit to having excessive daytime sleepiness. This word is something which is commonly used in OSA symposia. So this means excessive daytime sleepiness or EDS. I will elaborate a bit on that. They will say that they have unrefreshed sleep, frequent awakenings at night. They can have morning headaches. They can have dry mouth. They have to get up in the night multiple times to just sip on water. Pathological nocturia. So more than one time, if you're getting in advanced stage also, more than equal to 2, that is known as a pathological nocturia. Again, it could be a pointer towards an OSA. Then cognitive symptoms like mood disturbances, loss of memory, and difficult to focus on work. Then they can have symptoms at work also. Very interestingly, symptoms are many times reported by the bed partner or the spouse. So they say that the person is having loud snoring or choking or gasping spells. They're quite restless in bed, multiple time awakenings, and they have a lot of limb movements. And this very interesting sign, elbow sign, it's actually described as person being elbowed by their bed partner. Now the study says that in 97% of the patients with positive PSD, they had also reported being elbowed by their bed partner multiple times in the night for snoring or apneic spells. This is a very significant history, so you can now ask your patients, do you have to wake up your spouse like this? Because karate bahut le rahe ho, saans nahi le rahe ho, bahut ruk rahe ho. So those kind of things, this is quite significant. Sometimes you have atypical symptoms like insomnia, which is totally opposite to what you would be expecting in a patient. You think that they are excessively drowsy, but sometimes they have difficulty in maintaining and initiating sleep, which is the insomnia thing. And resistant hypertension and shortness of breath. What I was saying was excessive daytime sleepiness, you have to differentiate it from fatigue, lack of energy, and tiredness. So fatigue, lack of energy, and tiredness are different from EDS, which is, these three things are basically subjective lack of physical or mental energy. And they have difficulty in initiating an activity and reduced capacity to maintain that activity. In EDS, you have inability to maintain wakefulness or alertness during major waking episodes of the day, with sleep occurring unintentionally or at inappropriate times for at least daily or at least 3 months. So how are they correlated to sleep apnea? This is a study which was done in 190 patients, 200 patients way back and published in Chest. That sleepiness, excessive daytime sleepiness was reported in almost 25% of the patients. However, low energy and fatigue are also symptoms of OSA, and they are reported in up to 40% of the patients. How do you assess for, so there is an objectivity to everything in medicine. You cannot just say that I am excessively sleepy during the day. So you want to quantify that excessive daytime sleepiness. So there are scales available which have been well validated in the population now. So what scales we are using commonly? One is Epworth Sleepiness Questionnaire. So there are some 8 points in here which you can ask, and then you can mark them. This is easily available on internet, so you can download on your phone and do it ASAP in the OPD. And the score ranges from 0 to 24. If your score is more than 10, then the chances of a person having EDS is very high, and more than 16 has been correlated very significantly with the OSA. So what are the advantages of this scoring? It is easy and quick to apply, and it is reliable for assessing subjective sleepiness. However, the disadvantages is that it is not a good measure of short-time sleepiness. So don't apply on your friends who are doing night duties. So sleep deprivation related EDS is not what we are talking about. Like I said, you have to have a sustained good
environment to sleep, all those things have been looked into. Only then you can think of EDS as a symptom for OSA. Then if your score is more than 10, it is correlating with OSA. And high, it has got, the limitation is that retest variability is there. So when you apply it again, the patient may give different answers. This study showed that the severity of OSA, which is mild, moderate, and severe OSA, as described by the AHI, which I think Hemant has already covered, that AHI more than 5 is diagnosis of OSA, but you have to grade it to mild, moderate, and severe based on the AHI 5 to 15, 15 to 30, and more than 30. So you can see the ESS is also rising in this population. More severe disease you have, more ESS you have. The other scale is Stanford Sleepiness Score. So this can be used for short-term acute sleep loss assessment also. And there are 7 statements, and you can give a rating, and then you can judge the sleepiness. Now it can be given multiple times in the day. This scoring system is easy to apply, and it also correlates with acute total sleep deprivation. So this can be used in patients who have short-term history of excessive daytime sleepiness. In the examination, if you are getting any positive history, you have to look into the vitals of the patient, the BMI, the Mallampati scoring. ENT evaluation should be ordered for, especially to look for any upper airway problems. And certain things are very visible, like a problem of short neck and retronadia. Those things can be assessed by the physician at the bedside. Now we come to screening questionnaires. So you want to know how probable is my patient for OSA. So suppose you did screening with history and examination and found that there is a forthcoming history for suggestive for obstructive sleep apnea. So one commonly used questionnaire is stop bang questionnaire, which is mainly used for pre-op evaluation. It was developed like that, but its validity in normal population is also good enough. The sensitivity specificity ranges around 85%. So it has got eight components, and everything stands. Stop bang is a mnemonic basically for snoring, feeling tired, observing any apneic spells. P is for blood pressure if you have high BP. B is for BMI. A is age more than 50. N is neck circumference more than 17 inches in male and 16 in women. And gender if you are a male. So if you go by this chart, if your patient has a score of 0 to 2, he has got low risk of OSA. 3 to 4 is intermediate risk, and more than 5 or equal to 5 is high risk for OSA. So we don't stop at stop bang only. One more questionnaire which we are commonly using here, Berlin questionnaire. This is assessing patients' 3 components, sleepiness and apnea. Second category questions are for fatigue and somnolence. Very easy to do again and available on internet. And more than 2 categories, if they are positive, it is high risk for OSA. This gives you a background that if you have screened your patients well for OSA, now you can proceed towards what diagnostic modality to apply in what patients. So most important and the gold standard modality for diagnosis is polysomnography or sleep testing. This is the fundamental objective diagnostic tool. So it allows for continuous monitoring and simultaneous recording of physiological activities during sleep. And it has got various components like we can see the sleep stages, the eye movements, EMG tone, the respiratory parameters, and ECG. So you have got multiple factors to look into. So this is a very complex kind of a test. However, this is the gold standard, and it is less likely to miss any cases. There are 4 levels of sleep study. So not all setups can have a good level 1 lab. So I'll show you how a level 1 lab looks like. This is how a setup looks like in level 1 lab. So you have a workstation where you have a technician always in house to look into the technical glitches, and there is a microphone to communicate to the patient. There is a separate room which is separated by a soundproof wall, and there's a video camera. The patient is sleeping nicely. There's a head box, micro base, speakers are there, and then there's a PAP device here also. So this is how a full sleep lab looks like. Now this is not possible in all the setups when you start off with. So there are level 2 and 3 devices also and 4 devices also, which have less number of channels, but definitely in comparison to the gold standard, their accuracy will be slightly lower, especially in milder cases. In severe cases, they are likely to pick up all the disease, but in milder cases, mild to moderate OSA, they are likely to miss it. So these are the standard channels. This is by the ASM guidelines. You can go through it. EEG channels, EOG, EMG, ECG, airflow monitoring, and respiratory effort, and pulse oximetry, body positioning, and there is a video for recording any abnormal behavior. There are certain additional channels which already ma'am has talked about in the talk on hypoventilation. They are routinely not connected if you are not suspecting other problems. In sleep apnea, these are the channels which is most commonly used. And this is how a hypnogram or an epoch will look like on a sleep study, where you are recording the brain activity also, the respiratory activity also, pulse oximetry, leg movements, and position of the patient. These are all very important components of level polysomnography. Now, what are the indications? It is done for sleep apnea or sleep-related breathing disorder. Also it is done for recording seizures during sleep, with these EEG channels. Narcolepsy can be diagnosed, and periodic limb movement disorders, PLMDs, are also diagnosed using polysomnography. So it is to be done at what levels? As a diagnostic test, it is done when you are suspecting OSA, as I have told you, or in a pre-op evaluation where the patient has come with snoring or the surgeon has referred for evaluation in terms of risk stratification. You have to repeat it when your clinical suspicion is high, but your initial PSG at some other center is negative, so you are suspecting that. Or your patient has got significant weight gain or weight loss. Again, you have to do it in order to be able to judge the severity or need for CPAP. And as a follow-up PSG, you do it after surgery. If a patient of severe OSA was not manageable on devices, then surgeons come into picture and dentists come into picture. So all those things have been set in place. You repeat a PSG and find out what problems have been solved. Again, never forget that I told you there are some causal associations. If nobody is referring a patient to you, you can pick your own cases based on these risk factors that I have already discussed. These are the conditions where sleep studies should be done if you have the facility. How to do a sleep study? Either you do a full night diagnostic sleep study or a split night study. So split night study, you are actually diagnosing the condition as well as you are giving the PAP therapy and titrating it in the same night, so you are saving patient a visit. But you cannot do it in all patients as per the guidelines. Only if your AHI is more than 40 during 2 hours of monitoring of initial diagnostic portion, or your AHI is 20 to 40 with long apneic spells and severe desaturations, and at least you have 3 hours remaining for your PAP titration. Okay, so these 3 conditions should be fulfilling, only then you should be aiming for a split night study. Okay. This is how obstructive sleep apnea will look like, as you can see in this. So this is the flow channel where you can see this complete cessation of the flow here. This is the apneic spell and it resumes after that. But the chest movements here are going paradoxical. So this is basically an obstructive event. In central events, what you will see is that there will be loss of the flow along with loss of chest and abdominal movements also. That is a central event. Now another thing is when we do a sleep study outside via technician, the softwares and the machines that companies are offering, you're using by any company, ResMed or Philips or whichever company you have, lab you have in your place, they have an automated generated report with them. So this is the automated report for one of our patients. As you can see that these are the lines, respiratory events here, and this is hypopnea, obstructive events marked in red, central events kuch nahi hua, respiratory events 1-2 mark hue hain, mainly hypopnea 1-2 and some bit of arousals here. Can you see this? And patient has slept well going by the reported, and this is the red lines in the sleep thing show that patient has gone into REM. So if you see actually this report, you will say the patient has actually got very mild disease or no disease at all. But this is when you have manually validated the report, the sleep stages have changed, the respiratory events have increased in numbers, this is the hypopnea now, the obstructive events and the arousals. So this patient now has a significant problem. So what I'm trying to highlight here is do not depend on the machine generated reports by sleep labs and go for a manual validation. You can also combine esophageal manometry with polysomnography, and that increases the sensitivity and specificity to pick up cases, right? Now we come to second part. Do all patients need to come to sleep lab and get them tested, or you can have a home testing for them? So this is probably due to that increasing burden of the patients, and also, not many patients would like to come to an advanced center to do it. Patients have a lot of stigma, patients have a lot of work. Some patients can't sleep in a hospital-based environment. They need their own bed to sleep. So a lot of issues are there. So PSG is sort of, having some disadvantages in terms of being labor-intensive and expensive. So what home testing does is, it is basically providing you accurate and reliable and convenient reports without patients having to come to the hospital. And meta-analysis has already been done to show that they correlate very well with the gold standard devices. This is a study that we had done in our center. This is published by me, that we did diagnostic accuracy and feasibility in patients, in Indian patients, where do we stand. So the overall sensitivity was almost 94%, and diagnostic accuracy, as you can see in different categories, it's mild, moderate, and severe. So the sensitivity was not, the accuracy was not very good for mild cases. It's almost 70%, but for severe cases, you can actually get a good diagnostic accuracy of 92%. So if your screening shows you high probable case, you can advise them for home sleep testing. It's good enough for the patient. The overall correlation was also found to be very high, and it has also got very high specificity. So your chances of having a wrong diagnosis in severe cases is almost nil. What do guidelines tell? So this is the guideline that came after we published this data. Again, there are many data. So extrapolating all the studies, and there is a meta-analysis also now recently published. They say, when can you do home sleep apnea testing? When you have high probability of OSA, when you have absence of comorbidities. So if you have patients who have comorbidities, don't go for home sleep apnea testing. And there is a delay in obtaining PhD. There is immobility, patient can't come to the center. There is any strong first night effect due to new environment. These are the indications where you can use home sleep apnea testing. These are the 4 devices which are available in the market right now, which are basically for home sleep apnea testing. And you can actually see they have all got different number of channels and what all can be measured. And Apnea Link is by ResMed. Embleta is not available as of now. Stardust is available, which we have used. And WatchPad, I'll come to that. This is based on the peripheral arterial tonometry principle. So this is the device, peripheral tonometry device that I'm talking about. This is Night Owl ATM, which has been manufactured by Ectosense. But luckily, ResMed has obtained the rights for this device. So can you see this device here, tablet form? It is tied to your finger, and it has got pulse oximetry and peripheral arterial tonometry methodology. And it is connected to your, the software is connected, it's given in your smartphone, which you have to keep on your bedside. So it analyzes all the rhythms in your arterial pulses, the wave amplitudes and the variability, and also records the snoring noises and other things. And that's how you're going to make derivations about patient having sleep apnea or not. This is a very useful device. It costs around 2,000 to 3,000 for Indian market, but only has to be prescribed to be used by a physician. Patients cannot buy it on their own because, again, there's a lot of misuse potential in this. So this is a good technology that is coming up. And now AI is coming in a big way. So you have telemedicine applications. You have now smartphones acting as your sleep devices, sleep monitoring devices. Watches are also available. And new things which are coming, there's a thing called Somnomat. So it's a mattress which has got the technology to actually be able to pick up cases of apnea by picking up arousals and picking up desaturations. Just a couple of slides. Other modalities that can be used, again, they're non-invasive. One is ultrasound neck. So ultrasound neck as a screening tool for OSA, when you have patients in ICU or other who are critically ill, they are not very fit for obtaining a sleep study, neither they are very cooperative to perform their home sleep apnea testing by themselves. Those patients you can screen with radiological imaging also. The advantage is that it's a non-invasive test. You can analyze the upper airway. And there are 3 parameters in ultrasound that you look at: lateral parapharyngeal wall thickness, the distance between the lingual arteries, and the retropalatal pharyngeal diameter. These 3 things you have to look into, where a radiologist does that. And if you have these parameters, there is an increase in the wall thickness or increase in the distance, what is known as DLA, then the chances of having OSA increases. And if you combine it with retropalatal pharyngeal diameter, it almost is 100% sensitive and specific. So this study, again, as a screening tool, we have performed in our center, and this is giving good results, again, for screening and probably making a good diagnosis to start treatment. Even MRI is being explored. There is something called dynamic sleep MRI, where you can actually get to know
Ma'am,
patient
please
sleeps
conclude.
Yeah, just
You are running out of time.
and a patient will sleep in during the MRI, and they can actually give you not only the type of obstruction in the upper airway, also the level and the severity. This surgeons would know it better. This is drug-induced sleep endoscopy. This is actually a surgical procedure where you see the level of obstruction and the pattern of obstruction, and this is how they are going to tailor when they are going to perform surgery on a patient if at all it is needed. So these are some of the diagnostic modalities. Thank you for your attention.
Thank you, ma'am, for a very wonderful session. It covers all split night study, whole night study, all things. So since we are running of time and our guest has been arrived, so we'll take questions in lunch time. So I conclude this session. Thank you.
Thank you. Thank you for your attention.
Thank you, ma'am, for the wonderful session. May I now request our organizing chairman, Professor Rajendra Prasad sir, to kindly come on to stage to felicitate our guest speakers and chairpersons. Dr. Mansi Gupta, ma'am. Professor Darshan Bajaj, sir. Dr. Hemant Kumar, sir. Dr. Sachin Kumar, sir. Dr. Prashanta AP, sir. We'll be shortly ready for the formal inauguration ceremony for the day. Our chief guests and guest of honors have arrived. Please stay seated. All India Institute, Patna. Former director बोलिए, former director All India Institute, Patna, and former head of orthopedics department, KGMU. हाँ. KGMU. कर दिया सर. जीवन के परम ध्येय सुख को सारा समाज अपनाता है. देखना यही है कौन वहाँ तक किस प्रकार से जाता है धर्म पहुँचना नहीं, धर्म तो जीवन भर चलने में है, फैलाकर पथ पर स्निग्ध ज्योति दीपक समान जलने में है. Good afternoon, ladies and gentlemen. These beautiful lines from Rashmi Rathi by Ramdhari Singh Dinkarji have always inspired to focus on the journey and struggle to reach your goal in the righteous way. This holds apt and true to us doctors and our medical education, where we continue to learn and grow throughout our life to serve our patients, our fraternity, and society at large in the best possible way.
So we'll begin the inaugural function by inviting on his stage our esteemed dignitaries who have joined us here. On the behalf of department, we welcome our chief guest, Dr. Sonia Nityanand Ma'am, Honorable Vice Chancellor, KGMU. We are grateful to her for accepting our invitation and becoming the chief guest for today's event. Welcome, ma'am. Taking our event further, we heartily welcome our guest of honor for the event, Dr. Chandramani Singh Sir, Director, Ram Manohar Lohia Institute of Medical Sciences, Lucknow. Dr. Pinky Joel Ma'am, Mission IS Mission Director, National Health Mission, Uttar Pradesh. Welcome, ma'am. Moving ahead, now I would like to invite Dr. Amita Jain Ma'am, Dean Academics, KGMU. Professor G.K. Singh Sir, former Director, AIIMS Patna, former HOD, Orthopedics Department, KGMU. We cordially welcome Professor Dr. Rajendra Prasad Sir, Organizing Chairman, Sleep Summit 2024, ex-director VP Chest Institute and Director Medical Education and Professor Department of Pulmonary Medicine, Eras Medical College and Hospital, Lucknow. Next, I would like to invite our special guest, Professor Suryakant Sir, HOD Respiratory Medicine, KGMU. Professor Deepti Goti Ma'am, Professor and Head Department of Pulmonary Medicine, ESI PGI, Basaidarapur, New Delhi. We also invite on the dais our guiding force and mentor, Professor Ved Prakash Sir, Head of Department Pulmonary and Critical Care Medicine, KGMU, Lucknow, and Organizing Secretary for Sleep Summit 2024.
Now I humbly request our Organizing Secretary, Professor Ved Prakash Sir, to felicitate our esteemed dignitaries with saplings. First, I request him to felicitate our chief guest, Honorable Vice Chancellor, Professor Nityanand Ma'am. Professor C.M. Singh, sir. Dr. Pinky Joel, ma'am. Professor G.K. Singh, sir. Professor Amita Jayan, ma'am. Professor Rajendra Prasad, sir. Professor Suryakant, sir. Professor Deepti Goti, ma'am. I request Dr. Sachin Kumar sir to kindly felicitate our organizing secretary, Professor Ved Prakash sir.
लेडीज़ एंड जेंटलमैन, जैसे कि हमारे देश की परंपरा है, हर शुभ काम की शुरुआत ईश्वर के नाम के साथ होती है। तो आइए चले अंधकार से प्रकाश की ओर, पृथ्वी से आकाश की ओर, पदार्थ से सूक्ष्म की ओर, प्राणी से परमात्मा की ओर, ज्ञान से अज्ञान की ओर. With this, may I invite our chief guests and honorable dignitaries seated on the dais to light the auspicious lamp.
शुभं कुरुत्वं कल्याणं आरोग्यं धन संप्रदा शुभं कुरुत्वं कल्याणं आरोग्यं धन संप्रदा शत्रु बुद्धि विनाशाय दीपं ज्योति नमस्तुते दीपं ज्योति नमस्तुते शुभं कुरुत्वं कल्याणं आरोग्यं धन संप्रदा शुभं कुरुत्वं कल्याणं आरोग्यं धन संपदा दीपं ज्योति परं ब्रह्म दीपं ज्योति जनार्दन दीपं ज्योति परं ब्रह्म दीपं ज्योति जनार्दन दीपो हरतु मे पापं संध्या दीपो नमस्तुते दीपो हरतु मे पापं संध्या दीपो नमस्तुते शुभं कुरु त्वं कल्याणं आरोग्यं धन संप्रदा शुभं कुरु त्वं कल्याणं आरोग्यं धन संप्रदा बोधि ब्रह्मारूपस्तवं ज्योतिषा प्रभुराव्ययं बोधि ब्रह्मारूपस्तवं ज्योतिषा प्रभुराव्ययम् आरोग्यं देहि पुत्राशं मति स्वच्छाहि मे सदा आरोग्यं देहि पुत्राशं मति स्वच्छाहि मे सदा शुभं कुरु त्वं कल्याणम् आरोग्यं धन संप्रदा शुभं कुरु त्वं कल्याणम् आरोग्यं धन संप्रदा
Thank you for this beautiful recitation of Saraswati Vanna. Now, I would like to invite our organizing chairman, Professor Rajendra Prasad sir, to kindly give the welcome address.
So, good afternoon. Chief guest of today, Professor Sonia Nityanand, then Dr. C.M. Singh, a newly joined director of RML Institute, Pinky Madam, and all other dignitaries sitting on the dais, off the dais, my students, ladies and gentlemen. As organizing chairman of this Sleep Summit 2024, I welcome you all for this inaugural function. I was talking to Pinky, ma'am, probably in this audience, I don't see anybody who is senior than me. So I'm lucky one that majority of them, in one or another way, I have taught them. That is a fortune for a teacher, I must say. You know the Sleep Summit. If I tell you little bit about the sleep disorder, breathing, or sleep science, whatever you can call it, it's not very old science. First sleep lab of the world was established in 1970, so just about 45 years back in Stanford University, USA. And I'm very happy to inform that after, I think I was the one at that time head, we established sleep lab in KGMC Pulmonary Medicine Department in year 2008, I believe, 8. So you can say about 38 years back, we have established, and I will inform you, before that we have worked a lot on the sleep. Our department has worked a lot of sleep medicine. One of my students, Dr. R.K. Burma, who did first thesis on sleep lab, although at that time we don't have any sleep machine, but on the questionnaire basis, we worked and we published extensively, and I am happy to inform you, Dr. R.K. Burma is today is a great person in the medicine of sleep. He's in USA. So that is the idea of a teacher and doing the things in advance. Otherwise, in 2003-04, if I used to tell sleep, what is sleep, what it does, nobody was aware. But I'm happy today that we have thousands of sleep labs in this country. Even in Lucknow and UP, we have hundreds of sleep labs. So that's about, for younger generation, what I'm trying to say, that's an idea for a teacher. Teacher is one who innovates, who give new things to the society. So ultimately, benefit goes to whom? Benefit goes to the poor people, to the society. I think with this little bit of introduction, I'll not take much time. I once again welcome you all for this Sleep Summit 2024. Thank you very much.
Thank you so much, sir. Now I invite our guest of honor, Professor Chandramani Singh, sir, to deliver his message.
Thank you. Honorable Vice Chancellor, Professor Nityanand ma'am, Dr. Pinky Joel ma'am, MD NHM, Professor Abhijit Kaur, Pro Vice Chancellor, KGMU, Professor Rajendra Prasad sir, Professor Amita Jain ma'am, Professor Surikant sir, Professor G.K. Singh sir, Professor Dipti Gothi, and Professor Ved Prakash, Organizing Secretary of this event. Senior faculty member in front of me and dear students. A very good afternoon to all of you. Today's summit, that is Sleep Summit, we know it is very important, and we celebrate this day as World Sleep Day. And theme of this year is Sleep Equity for Global Health. As we know, sleep disorder is a major public health problem nowadays. Almost 45% of world population is suffering from one or other sleep disorder. And approximately 10% of the population is suffering from insomnia. So by this we can say that sleep disorder is major public health problem. Lots of things are being done. Lot of sleep lab are in process of making and already working. इस प्रॉब्लम को अगर कम करना है तो हमें और भी ज़्यादा इस डिपार्टमेंट को बढ़ावा देना होगा और भी हमें साइंटिस्ट और भी रिसर्चर को काम करना होगा जिससे कि नई चीज़ों पे हम नई विधाएं ट्रीटमेंट की डेवलप कर पाएँ और स्लीप डिसऑर्डर पे काम कर पाएँ। जैसा कि हम जानते हैं कि ऑब्स्ट्रक्टिव स्लीप एपनिया एक बहुत बड़ी प्रॉब्लम है और इसका जो मेजर काज है दैट इज़ ओबेसिटी, और ओबेसिटी अगेन एक मेजर पब्लिक हेल्थ प्रॉब्लम है. ऑलमोस्ट 23-24% ऑफ पॉपुलेशन ऑफ इंडिया इज सफरिंग फ्रॉम ओबेसिटी. To reduce the obstructive sleep apnea, we have to work on obesity also. Basically, this is behavioral science disease, obstructive sleep apnea and obesity both. And we know the consequences of OSA, that is hypertension, cardiovascular respiratory disease, and so many other diseases are there due to obstructive sleep apnea. By this, we can think how important is the issue, and for this issue, the Department of Pulmonary Medicine and Critical Care of this institute is organizing this summit. I congratulate to them. And I am feeling very honored that my two previous directors, Professor G.K. Singh sir and Professor Rajendra Prasad sir, I am sharing dais with these legends, actually living legends. So I thanks the organizer for inviting me for this summit and wish all the very best. Thank you.
Thank you, sir. Now I invite our next guest of honor, Dr. Pinky Joel ma'am, to share her thoughts on the occasion.
Good morning all. Respected Vice Chancellor Dr. Sonia Nityanand ma'am, Professor C.M. Singh ji, Professor Dr. G.K. Singh ji, Dr. Deepti Gothi from Delhi, Professor Suryakant ji, Professor Madam Amita Jain madam, बहुत renowned and the senior most, इसलिए आपका सबसे आखिर में नाम ले रही हूँ, डॉक्टर राजेंद्र प्रसाद जी, प्रोफेसर साहब, जिनके स्टूडेंट्स यहाँ बहुत मौजूद हैं, और I appreciate कि he is so enthusiastic even at this age. You are young enough to guide us, and expect करती हूँ कि आपके enthusiasm से आपके students ही नहीं, जो भी आपके साथ touch में आएंगे, they will be energized. And Professor Ved Prakash ji, thanks for inviting me here and calling me as one of the dignitaries here. My dear friends and students over here. So, I am not an expert in this topic. So, I am the Health Secretary of Uttar Pradesh and MD NHM, dealing with the health sector in Uttar Pradesh. Sleep Summit ke liye, when Dr. Ved Prakash has called me up and then he told you come. So, I love the word sleep because I love to sleep. बहुत लोगों का हॉबी होगा और बहुत लोगों के लिए ये एक ऐसी चीज़ है जिसको आप पाने के लिए रोज इच्छित रहते हैं. Being a doctor, I can understand the kind of workload you people must be having and the disturbed sleep schedules. So it is one of the rarest commodity आज के दिन में जो है कि सोना कैसे है. And it seems कि बहुत ही आम सी बात है. But if we go back and see our ancestors and maybe 1 or 2 generations back, there was no electricity. People used to sleep by 6 or 7, get up early in the morning, 3:30, 4 o'clock, 5 o'clock. Hardly anybody had diabetes and hypertension. No obesity, hardly any cholesterol. So I don't know whether the development has really done good to that extent, or underdevelopment of that sort was really a reason for somebody to be unhappy. There could be a number of debates and there could be a number of topics and discussions on that. But the recent challenge which we are facing right now, and which is very badly ignored in the rat race of modernization, materialism, success in the name of reaching somewhere where everybody wants to praise you and you want to be successful. There is no set criteria, but everybody is in a race. सब लोग दौड़ रहे हैं. अब उस दौड़ने में दिन में अनफॉर्चुनेटली 24 ही घंटे होते हैं, हफ्ते में 7 ही दिन होते हैं. अगर फरवरी को छोड़ दिया जाए तो 30 से 31 दिन होते हैं और साल में 365 या 66 दिन सबसे ज़्यादा होते हैं. So there is a limited time. और इच्छाएं बहुत हैं, दौड़ रहे हैं हम उसमें. We are running, 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 running. उस रैट रनिंग रेस में हमें मालूम नहीं है कि हमारी बायोलॉजिकल क्लॉक, हमारी बॉडी की रिक्वायरमेंट्स हमको कहीं और ले जा रही हैं एंड वी वांट टू गो समवेयर एल्स. सबसे इम्पॉर्टेंट पॉइंट अगर यही है कि अगर आपका स्लीप ठीक नहीं है, 2 या 3 दिन देखिए, आप खुद ही देखिए, आप वन विल बी इन काइंड ऑफ अ कन्फ्यूजन, अ स्टेट ऑफ कन्फ्यूजन. फिर थोड़ी देर में इरिटेबल बिहेवियर शुरू हो जाएगा. Irritable behavior के बाद then if you go for it, after some time there will be mood swings of different forms and that could be lead to depression and ultimately mental health status. So आज की डेट में especially when we are exposed to lots of gadgets, IT information, YouTubes, internet, whatever you say, कि कितना हमारा screen time अगर हम decide करेंगे तो screen time which is affecting our sleep patterns, हमारे आने वाले बच्चों के लिए especially, आज शायद हमको उतनी बात समझ में नहीं आएगी, बट आवर यंगर जनरेशन विल हैव बिगर इश्यूज रिलेटेड टू स्लीप एंड विच विल लीड टू मेंटल हेल्थ इश्यूज लेटर ऑन. एट अ वेरी यंग एज चिल्ड्रन आर कमिटिंग सुसाइड क्योंकि इरिटेबिलिटी है. 7 साल का बच्चा, 8 साल का बच्चा रात को देख रहे हैं तो दे आर कीप ऑन वॉचिंग गेम्स और सम उनके डिफरेंट फॉर्म्स ऑफ स्पोर्ट्स के गेम्स के बाहर के बजाय घर वाले जो बैठ के फ़ोन पे लगे हैं, एंड डिसीजन मेकिंग जो डिस्टर्ब्ड है उससे, it is leading to lots of not only social but it's leading to land order issues also. It leads to एक डिसीजन मेकिंग का जो पैटर्न है वो बेस होता है एक अच्छी स्लीप पे. इट मे वेरी फ्रॉम पर्सन टू पर्सन. पर्सनली किसी का 4 घंटे का स्लीप पैटर्न हो सकता है, किसी का 7 घंटे का हो सकता है, किसी का 9 घंटे का हो सकता है. बट देयर हैज़ टू बी एन इम्पॉर्टेंस विच शुड बी टैग टू स्लीप विद रिस्पेक्ट टू द एफिशिएंसी. बहुत सारे कंट्रीज में आपने देखा है कि नाउ दे हैव गॉन फॉर अ 10 minutes पावर नैग कॉन्सेप्ट में. कॉर्पोरेट्स में दे हैव मेड सम रूम स्पेसिफिकली इन द कॉर्पोरेट हाउसेज कि वहाँ पर जाके 10 मिनट का लंच के बाद में या वॉट एवर टाइम यू फील वन कैन हैव अ पावर नैप एंड सो दैट योर एफिशिएंसी इंक्रीजेज. सो जो चीज़ हमारी इम्पॉर्टेंट लाइफ में थी उसको हम दूरी को छोड़ते हुए वी आर रनिंग आफ्टर फ्यू थिंग्स विच वी थिंक विल गिव अस हैप्पीनेस. बट उस हैप्पीनेस, उस मनी का कोई फ़ायदा नहीं है विच विल मेक यू मेंटली सिक. And even if you have lots of facilities around, physical facilities or materialistic facilities, और अगर मानसिक संतुलन ही ठीक नहीं है तो वो facilities को enjoy करने का कोई logic नहीं बनता है. I don't think so anybody can be enjoying those facilities. You can't differentiate a 5-star and you can't differentiate a just a slum area if the mental status is not there. So देखने के लिए बहुत छोटी सी बात है कि देखने की क्या है कि नींद पे बात कर रहे हैं. But ये जो नींद है, this has been one of, I'm happy and I'm happy to hear that there are hundreds and of labs in Uttar Pradesh, and I don't think so NHM में कोई ऐसा proposal है कि हम नींद के बारे में बात कर रहे होंगे. So this is how, being into the health department, we are also not that much aware about the importance of this one topic. So I'm thankful and grateful to Dr. Ved Prakash and Dr. Sonia Nityanand ji for calling me here and just making me at least aware of this, that this could be one of the projects on the proposals or anything we need to work on in the longer run to get a really healthy, productive and a sensible decision making productive population in the future. So ये ना केवल बुजुर्गों की प्रॉब्लम है. लोग कहते कि अरे बुजुर्ग हो गया है. देयर इज छोटा सा एक चुटकुला है. एक बार किसी ने कहा कि बहुत पुरानी बात है कि एक आदमी ने भगवान से कहा कि जो है भैया भगवान ने 25 साल उम्र दिया आदमी को. तो उन्हें 25 साल की उम्र भगवान को बोला कि यार 25 साल तो बड़ी कम है, हैं? तो जो है तो फिर क्या करें? तो वो बोला थोड़ी 25 साल और बढ़ा दो. तो वहाँ पर भगवान ने पूछा किसकी उम्र बढ़ा दें यार 25 साल, क्योंकि सबकी लिमिटेड दी है मैंने, तो तुम्हारी तो 25 ही थी. तो वो जा रहा था खेत में काम कर रहा था. उसने कहा कुछ नहीं तो इस बैल क्या करेगा 25 साल की उम्र का, ये बैल की उम्र मेरे को 25 साल दे दे. तो भगवान ने 25 साल उसमें ऐड कर दी. 50 हो गई उसकी उम्र, 25 साल बैल की ऐड हो गई. तो फिर बात हुई तो बोला कि तीसरी उम्र क्या? बोला आप 50 साल का हो गया, मरने की बारी है. तो उसने कहा नहीं भैया भगवान मरना नहीं है अभी, आप 25 साल और दे दे. तो बोला किसकी दूँ? तो वहाँ पर कुत्ता बैठा कर ये क्या करेगा जी के कुत्ता जो है, तो ये उम्र मेरे को दे दे. तो भगवान ने 25 साल कुत्ते की उम्र जोड़ दी उसमें. माइंड मत करना प्लीज़, है ना. सो 75 हो गई उम्र. और 75 साल में जब मरने की बारी है तो फिर पीछे भगवान के पीछे पड़ गया. 75 साल की मरना नहीं है अभी तो और जीना है. तो बोला अब क्या करूँ? तो बोला ये उल्लू क्या करेगा बैठा हुआ, ये 25 साल उल्लू की उम्र मेरे को दे दे. तो भगवान ने 100 साल दे दी उसको. अब आई इंसान की 25 साल की उम्र. 25 साल तो खूब मस्ती करता है, ठीक. अगले 25 से 50 साल वो कोल्हू के बैल की तरह मेहनत करता है. अगले 25 साल जब वो बुढ़ापे में जाता है, जब कोई इसको सुनता नहीं, बच्चे सुनते नहीं, बहू सुने ना, बच्चे पोते सुने ना, कोई और सुने, तो कुत्ते की तरह भाव भाव करता रहता है एक जगह बैठा हुआ. और एक एज ऐसी आती है जब आंखें काम नहीं करती तो उल्लू की तरह वहाँ बैठा रहता है. सो द थिंग इज कि उस जिंदगी का फ़ायदा क्या जिसका कोई एक लॉजिकल कंक्लूजन पॉजिटिव ही ना निकले. सो द थिंग इज कि इवन इफ इट इज़ 25 ईयर इट शुड बी हेल्दी लाइफ, है ना. और उस हेल्थ में आई थिंक स्लीप इज़ वन ऑफ द मोस्ट इम्पॉर्टेंट एंड फ्री ऑफ कॉस्ट. जब हम सोते थे तो हमारी मम्मी हंगामा करती, सुबह उठते नहीं है, 5 बज गए, 6 बज गए, 7 बज गए, 8 बज गए, अरे सोने दो यार. तो मेरे पापा कहते सोने दो. मम्मी कहती क्या कर रहे हो? सोने दो. कहते कि माइंड रिलैक्स हो रहा है. तो उस समय हमको बात समझ में नहीं आती थी. टुडे आई अंडरस्टैंड एट दिस एज व्हेन आई एम ऑफ माई मदर्स एज, जब मैं भाव एज में हूँ, तो मुझे अब समझ में आ रहा है कि वो क्या कह रही थी और पापा का क्या कहना था. सो दिस इज़ द डिफरेंस. when you get a fresh, you take good decisions, you are happy. अगर आप सोए नहीं तो सुबह से शुरू होते हैं. वाइफ से लड़ाई करके घर से निकलोगे या पति से लड़ाई करके घर से सुबह निकले, क्योंकि रात को 3 दिन तो सोए नहीं ठीक से. निकलते ही पहले ड्राइवर के पीछे पड़ गए, पहले कुक के पीछे पड़े, फिर ड्राइवर के पीछे पड़ गए, इफ इन केस यू आर फॉर्चुनेट इनफ टू हैव दिस, इफ नॉट तो सुबह बर्तनों के पीछे पड़ गए, फिर बाहर निकले तो ऑटो वाले के पीछे पड़ गए, कार वाले ड्राइवर के पीछे पड़ गए, करते करते ऑफिस तक आते पूरा साइकिल ही सत्यानाश कर दिया. So this is one important thing as a layman which you can understand if we don't have a sufficient and ample sleep. So with this note, I thanks a lot again once again to all of you for calling me, and thank you all for listening to me. And I hope and I wish this 2-day summit is really going to give some futuristic concepts to you all, and we'll have a beautiful world to come, because it's ultimately it's a global health. And everything is linked to the sleep, whether it is diabetes or hypertension or hormonal issues, or it is obesity, or it is your mental health status. And along with this, the productivity of a state, of a country, and of a nation, and of the world as at large. So definitely, I wish you all good luck, and thanks for calling me again. Thank you.
Thank you so much, ma'am. Now, I would like to invite Professor Rajendra Prasad, sir, to come to podium for the release of his new book, and request Honorable Vice Chancellor, ma'am, for unveiling.
May I please request you, sir, to May I please request you, sir, to say a few words about your journey through the book? Thank you.
So I said in my welcome address that most of you sitting here has been my student. And I taught approach to chest X-ray and approach to respiratory cases for last so many, 50 years now. And some of the students whom I taught, they become even DG level they went up to. And some of them become friend on my Facebook. And they wrote on the Facebook, सर जो आप एक्सरे पढ़ाते थे वो एक्सरे हैं कहाँ? और मेरी उम्र को देखते हुए उन्होंने ये भी कुछ हिंट किया कि आपके संग ये सब चला जाएगा. Why not you create something which everybody could be benefited? हम तो benefit हुए ही. So then first thing I did, I must thank Dr. G.K. Singh who introduced me to the word of WhatsApp. Otherwise मैं नहीं जानता था पहले. Way back, long year back. So first lecture I put on the YouTube, approach to chest X-rays. About 45 minutes lecture I was taking in Erath, same was photographed. Video was made, and I put on the YouTube. Believe me, you will surprise, 4,40,000 people have viewed that. I never thought that such a simple lecture will be seen by so many. And thanks to COVID, I must say, during COVID period, since I'm a teacher, so I digitalized all my X-ray. Otherwise, I used to tell with the X-ray. And with that, this book is That is the genesis. When I made every X-ray picture, and beauty of this book is, it is based on Indian patient, not Indian. Even patients I treated in last 50 years, 99% of the X-ray picture you see into it of mine, of all Indian patients. Hardly any chest physician writes book on chest X-ray. Most of the X-ray we read of the radiologist. But this is I tried to this, and I'm very happy to present you this book. Thank you very much.
Thank you, sir. Now, I would like to invite our chief guest for the event, Professor Sonia Nityanand Ma'am, Honorable Vice Chancellor KGMU, for her blessing and message.
Thank you. Professor C.M. Singh, the guest of honor for today's occasion. Dr. Pinky Joel, who's again the guest of honor. And for people who don't know, she's not just an MD, NHM, and an IS, but she's also a doctor. And I've had a very long, I have had an association with her when she was the additional director of the Sanjay Gandhi Postgraduate Institute of Medical Sciences. And I think I would use this platform to acknowledge my thanks to you for helping me to set up the Stem Cell Research Center at SGPGI. You really played a very important role. Dr. Amita Jain, who is the Dean Academics of King George's Medical University. And unfortunately, we don't have the Pro VC. She's engaged in some important activity. But Dr. Rajendra Prasad, who's been my teacher also and the organizing chairman. Professor G.K. Singh, who's again been my teacher and the ex-head of the Department of Orthopedics. Dr. Suryakant, who's currently the head of the Department of Respiratory Medicine. Dr. Dept, who's the head of the Pulmonary Medicine Department at ESIC, New Delhi. Dr. Ved Prakash, the organizing secretary. So at the outset, I would like to congratulate two people, Dr. Rajendra Prasad for the book that has just been released. You must have put in a lot of effort, and it's a good gesture to capture your expertise. This will be everlasting. And Dr. Ved Prakash for organizing this Sleep Summit today on the occasion of the World Sleep Day, which he said has passed, but because of non-availability of many faculty on that day, he has organized it today. I would also like to acknowledge all the distinguished faculty in the audience today who've come from KGMU and who've come to lecture in the summit today. I can see Dr. Mansi sitting here. I can see Dr. Mohit Sinha, many other people sitting in the audience today, and all the other participants. So firstly, on behalf of the King George's Medical University, a very warm welcome to all of you. The theme today of sleep equity for global health, it's a very catchy and a very appropriate theme. Just highlighting how important is sleep for global health. Dr. Joel, to a large extent, brought out the importance of sleep in health. But I would just like to add on that Dr. Ved Prakash said that there are hundreds of sleep labs in Lucknow now. But this area of sleep disorders, even a grave disorder like obstructive sleep apnea, there is very little awareness about it, even in the medical professionals. Only yesterday night, I was in a dinner party, and the doctor who was sitting on my left side, young person, so he's a general physician, he's telling me, oh, recently my wife forced me to get sleep studies. Now the sleep studies can be done in the house also. So she forced me to get sleep studies done, and I have been determined to have a very advanced obstructive sleep apnea. And I just started thinking at that point of time that advanced, a doctor, and fairly young, which means it should have been caught early in a doctor, which means that there is not much awareness about sleep disorders. And one of the things which a department like pulmonary and critical care medicine in KGMU and, the departments in the other two institutes, the respiratory medicine, pulmonary medicine department in SGPGI and in RML, I think it's an important role to create awareness about sleep disorders, Now, if there is no awareness even in the doctors, so you can see how very little awareness there is in the public. So one goal should be to create awareness of the different kind of sleep disorders and also give the message that these are treatable, these are diagnosable, and these are treatable. And as already highlighted by Dr. C.M. Singh, that if you have sleep disorders, they adversely affect the cardiovascular system. There is increased incidence of hypertension, impaired cognitive dysfunction, and increased risk of strokes. So all this can be cut down if we catch the sleep disorders in time and treat them. There's very little awareness about it. I'm happy to note that there is a sleep lab which dates back to 2008 in King George's Medical University. And while Dr. Ved Prakash accompanied me from the VC office to this conference venue, he expressed his desire that he said, we have one. I started asking him, how many sleep studies do you do in a day? And he said, we are only able to do one because we have one machine. And he expressed his desire to buy another machine. And I assure you that this year, this financial year, starting from 1st of April, we'll get you another sleep machine. But take in patients, decrease the waiting list, but even more important, if there are hundreds of sleep labs in Lucknow, that means there is an ample infrastructure to carry out the sleep studies. I don't know how much of expertise, but at least the infrastructure is there to carry out the sleep studies. So create an awareness about it, Again, my congratulations to the department, to the team for holding this summit today. Sleep medicine is becoming a very, very important area globally. So congratulations for holding it. I know you have very good eminent faculty who will speak in it. And I would again like to thank our guests of honors, Dr. C.M. Singh and Dr. Pinky Joel, to come and grace this occasion. Thank you. Good luck. Jai Hind.
Thank you for your kind blessings, ma'am. Now I request Professor Ved Prakash sir to felicitate our dignitaries with mementos. Please come forward, sir. Honorable Vice Chancellor ma'am, Professor Sonia Nityanand ma'am. Our guest of I request our guest of honor, Professor C.M. Singh sir, to please come forward. Next, I request Professor G.K. Singh sir to please come forward. I request Dr. Pinky Joel ma'am to please come forward. I request Professor Amita Jain ma'am, our dean, to please come forward. I request Professor Ved Prakash sir to please felicitate Professor Rajendra Prasad sir. I request Professor Surikant sir to please come forward. I request Professor Deepti Gothi ma'am to please come forward. May I now request Honorable Vice Chancellor ma'am to please felicitate our organizing secretary, Professor Ved Prakash sir. Now I request Professor Ved Prakash sir to please come onto the podium and deliver his vote of thanks.
Thank you, Dr. Mithunjay. आज के बहुत ही खास मौके पर और बहुत ही व्यस्ततम समय में से हमारी चीफ गेस्ट प्रोफेसर सोनिया नित्यानंद मैम, जो पैट्रॉन भी हैं, चीफ गेस्ट भी हैं और हम लोगों के गार्जियन भी हैं, और परिवार की तरह ही हम लोग जब भी कोई भी काम लेकर के उनके पास जाते हैं तो जैसे घर से परिवार के मुखिया का आशीर्वाद जिस तरह से मिलता है, उसी हक से हम लोग अपनी बात कह पाते हैं, और मैम हमेशा ही हम लोगों की बात पूरी कर देती हैं। इसका अभी एविडेंस आपने देखा, मैंने गाड़ी में ही जब लेके आ रहा था मैम को तो रिक्वेस्ट की और उन्होंने इतना बड़ा अनाउंसमेंट कर दिया। हमारे पास लेवल 1 लेटेस्ट जो एक मशीन हम लोगों की है, उसमें मंथ्स की हमारी वेटिंग है, तो मुझे लगता है कि हमें एक और मिलेगी, और एक लेवल 3 या 4 लैब्स जिनमें हम होम स्टडीज़ को भी प्लान कर सकते हैं। मैम उसकी कॉस्ट कम होती है, तो मैं रिक्वेस्ट करूंगा कि ऐसी मशीन्स भी हम लोगों को दिलाएं, जिन टीचर्स को हम लोग यहाँ नहीं बुला पाते, उनके कम से कम उनके घर जा कर के हम स्टडी कर पाएँ। बहुत बहुत धन्यवाद कि आप हमारे बीच में आईं, अपने व्यस्ततम समय में से आपने समय निकाला। थैंक यू सो मच वाइस चांसलर मैम। MD NHM, सब लोगों को यही लग रहा था कि MD NHM है, हो सकता है PhD वाली डॉक्टर होंगी, लेकिन वो मेडिको हैं, और इस बात का मुझे लगता है कि उत्तर प्रदेश सरकार ने बहुत ही लाभ उनका लिया है, और जब हम लोगों को मौका मिला तो हम लोगों ने भी उनका बहुत लाभ लिया है। जब भी हम लोगों ने कोई बात कही होगी तो आउट ऑफ वे जा कर के मैडम ने मेडिकल कॉजेज को सपोर्ट किया, और जितनी अवेयरनेस की कमी है आप खुद एक्नॉलेज आप करते हैं इसको। मैम BC मैम ने भी बताया 80% लोगों को नहीं पता है कि उन लोगों को स्लीप का इश्यू है, इतना नेग्लेक्टेड इश्यू है। ये स्टेट ऑफ अफेयर्स है जहाँ 93 करोड़ लोग दुनिया भर में इससे ग्रसित हैं, 80% को पता ही नहीं है कि दे आर फेसिंग सम प्रॉब्लम विद द स्लीप। और जैसे कॉम्प्लिकेशंस की बात हुई या रिस्क फैक्टर्स की बात करें, ब्लड प्रेशर इससे हो रहा है, आपके इंसुलिन रेजिस्टेंस डेवलप हो रही है, ओबेसिटी की वजह से ये हो रहा है, और ओबेसिटी बढ़ती जा रही है इनएक्टिविटी की वजह से, ताकत ही नहीं है। तो एक विशियस साइकिल को कहीं ना कहीं ब्रेक करने के लिए हम लोगों को इन फैसिलिटीज़ को लाना ही होगा, और इस अवेयरनेस को आगे बढ़ाने के लिए मैंने इसलिए अलग से रिक्वेस्ट की थी कि मैम इस प्रोग्राम में आपका आना ज़रूर होना चाहिए, क्योंकि कई प्रोग्राम मैंने अटेंड किए हैं जब मैम यहाँ समय नहीं दे पाई। मुझे भी बड़ी घबराहट थी कि वाइस चांसलर मैम हमें समय दे पाएंगी कि नहीं, लेकिन थैंकफुली आप हमारे बीच में आई, और इस अवेयरनेस को आगे ले जाने के लिए हम लोग जो जिस कॉज के लिए काम कर रहे हैं, तो मुझे लगता है कि बेहतर तरीके से हम लोग कम्युनिकेट कर सकेंगे। और पिंकी जोयल मैम जो कि NHM का काम पूरे उत्तर प्रदेश का देखती हैं, अपने सरकार में भी और भारत सरकार से भी कोऑर्डिनेशन करती हैं, बहुत बड़ा प्रोजेक्ट्स NHM देख रहा है, तो मैं उनसे भी अनुरोध करूंगा कि स्लीप को लेकर के अवेयरनेस के साथ ही साथ इन फैसिलिटीज़ को किस तरह से हम लोग पेरिफेरी तक लेकर के जाएं, उसकी मेंटरशिप के लिए शायद KGMU बिल्कुल अपनी सारी सेवाएं देगा। मैं इसके लिए सोनिया नित्यानंद मैम को भी रिक्वेस्ट करूंगा कि इस फैसिलिटी को एक्सपेंड करने के लिए हम लोग इस फैसिलिटी को डिस्ट्रिक्ट लेवल पे कम से कम ले जाना चाहते हैं। आप इतने समय व्यस्ततम समय में से समय निकाल करके आई हैं, मैं बहुत बहुत धन्यवाद देता हूं आपको। प्रोफेसर CM सिंह साहब जो नवनियुक्त डायरेक्टर हैं लोहिया संस्थान के, आप अपने व्यस्ततम कार्यक्रमों में से हमारे बीच में आए हैं सर। मैं आपको बहुत बहुत धन्यवाद देता हूं कि आपने हमारी एक कॉल पे हमारे इनविटेशन को स्वीकार किया है। हमारे टीचर ऑफ टीचर्स प्रोफेसर जी.के. सिंह सर, आप हमें लगता है कि जितने भी यहाँ पे टीचर्स भी होंगे शायद ज़्यादातर लोग उनके स्टूडेंट्स हैं। मुझे याद है जब मैं एमबीबीएस में था और वो एक पीजी की क्लास ले रहे थे रिसर्च की, तो मैं उस क्लास में चला गया था और मुझे किस तरह से कितना मुश्किल रिसर्च के कंसेप्ट होते हैं उनको किस तरह से सिंप्लीफाई करके उन्होंने हम सबको समझाया है। मैं सर आपसे रिक्वेस्ट करता हूं कि जिस तरह से आप यूट्यूब और इनके माध्यम से तो बढ़ा ही रहे हैं, बुक्स के माध्यम से भी और जो भी तरीके हो सकते हैं, हम आपसे रिक्वेस्ट करेंगे कि कम से कम ये फॉरएवर ये चीज़ें हम लोगों के बीच में रहें। इसके लिए जो प्रयास हो सकते हैं सर मैं रिक्वेस्ट करूंगा कि आप उसको भी करते रहें। और मैं बहुत बहुत धन्यवाद देता हूं कि आपने स्वीकार किया कि आप डायस पे हम लोगों के बीच में हैं। बहुत बहुत धन्यवाद आपको सर। और रिसर्च का जितना भी है, इस एज में भी सर हमारी रिसर्च का थर्सडे को एक क्लास पर वीक डिपार्टमेंट में रिसर्च के लिए लेते हैं अभी भी। तो मैं आपको बहुत बहुत धन्यवाद देता हूं सर। हमारे ऑर्गेनाइजिंग चेयर टीचर ऑफ टीचर्स, हम लोग कहते हैं जब से टीबी से ये विभाग शुरू हुआ था और आज पल्मोनरी क्रिटिकल केयर और जितनी भी आप इसकी सब स्पेशलिटीज़ को देख रहे हैं, हमारे यहाँ पे स्लीप में फेलोशिप का 4 सीटें ये कार्यक्रम चल रहा है 1 साल के लिए। क्रिटिकल केयर में भी 4 सीटें हमारी चल रही हैं 1 साल के लिए पीडीसीसी की। हमारी एलर्जी और इम्यूनोथेरेपी में 2 सीटें चल रही हैं मैम। और इंटरवेंशनल पल्मोनोलॉजी में भी 4 सीटें हम लोग रन कर रहे हैं। डीएम के साथ साथ इन सभी सीट्स को भी रन करने का जो कंसेप्ट था उसको देने वाले प्रोफेसर राजेंद्र प्रसाद सर और प्रोफेसर सूर्यकांत सर, मैं आपको बहुत बहुत धन्यवाद देता हूं सर। सूर्यकांत सर को मेरे दोनों टीचर्स हैं। हमारे बीच में दिल्ली से दीप्ति गोठी मैम हमारे यहाँ एग्जामिनर भी रहती हैं कई बार। पिछली बार भी हम लोगों ने वर्कशॉप किया था जब हम लोगों ने यूपीटीवी से कॉन की थी, तब भी आपने समय दिया। हमारे शॉर्ट नोटिस पे भी आप हमेशा अवेलेबल हो जाती हैं मैम। मैं बहुत बहुत धन्यवाद देता हूँ। आप पायनियर हैं, डीएम कोर्स दिल्ली में शुरू किया है, हमारे बीच में आने के लिए बहुत बहुत धन्यवाद आपका। जितने भी हमारे टीचर्स मैं सामने देख रहा हूँ, प्रोफेसर आर.एस. कुशवाहा साहब जो ट्रेजरर भी हैं, प्रोफेसर राजीव गर्ग जो हमारे साइंटिफिक चेयर हैं, प्रोफेसर तुलिका जी, प्रोफेसर साइकेट्री से हमारे सर हमारे बीच में हैं, डेंटल से बड़ी संख्या में है, ईएनटी से बड़ी संख्या में हमारे फैकल्टी हैं, कार्डियोलॉजी से हमारे फैकल्टी और रेजिडेंट्स हमारे बीच में हैं, साइकेट्री, जीरियाट्रिक, मेंटल हेल्थ इन डिपार्टमेंट से हैं, फिजियोलॉजी से बड़ी संख्या में हमारे बीच में सभी लोग हैं। मैं आप सबका स्वागत भी करता हूं, सबको धन्यवाद भी देता हूं कि आप सब हमारे बीच में आए और इस कार्यक्रम को सफल बनाने के लिए अपना योगदान दिया। मेरी वाइफ भी यहाँ पे हैं, डॉक्टर मंजू जो हेल्थ डिपार्टमेंट में ही हैं। उनके बिना शायद मैं ये सब नहीं कर सकता, क्योंकि रात में 2 बजे इन्होंने कॉल किया कि कहाँ हैं, तो मैं उस पोस्टर को वहाँ पे जो मेन गेट पे पोस्टर नीचे लगा दिया, मैंने हटवा के उसको दोबारा ऊपर कराया। तो 2 बजे हम लोग पोस्टर लगा रहे थे, तो शायद इन्हीं की वजह से लगा पाते हैं। इसलिए मैं उनको भी धन्यवाद देना चाहता हूँ कि आपका हमेशा जो सहयोग रहता है, इस वजह से ही शायद हम लोग कर पाए। हमारे जो फार्मा पार्टनर्स हैं, रेस्मेड, फिलिप्स, ग्लेनमार्क, मैं सभी को धन्यवाद देना चाहता हूँ। क्योंकि ये अवेयरनेस की कमी है, तो हमारे मीडिया के साथ ही बढ़ चढ़ के इसमें हिस्सा लेते हैं। पिछली बार जो प्रेस की उसका भी बहुत वाइड कवरेज आपने किया है। इलेक्ट्रॉनिक मीडिया में भी बहुत नेशनल चैनल्स से लेकर के रीजनल तक सभी ने बहुत कवर किया है। मैं आपसे फिर रिक्वेस्ट करूंगा कि इस 2 दिन के इवेंट को भी आप अच्छी कवरेज करें, इसके लिए अच्छी जगह दें। मैं आप सबका बहुत बहुत धन्यवाद देता हूं। जिनके नाम छूट गए हैं, मैं सबको धन्यवाद देता हूं। बहुत बहुत धन्यवाद।
Coming to the closing of the inauguration ceremony, may I request everyone to please rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाए तब जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे भारत माता की जय भारत माता की जय भारत माता की जय
You are all requested to please proceed for lunch in the lunch area. We'll reassemble for our further scientific sessions in 30 minutes.
लाइए सर मैं तब तक अलग से मांगना
मैम को छोड़ के आता हूँ। सुनो, थोड़ा सा मैम ने बहुत अच्छा बोला है, मैम एक दे दीजिए।
सिंगल लेकिन मत पाई
एक मेरा भी सुनकर इसी से मेरा भी कर दीजिए।
इसको सेव कर लीजिए।
एक मेरा भी सॉरी इसी कैमरे से प्रियंका जी
आया अच्छा खींचो खींचो
सोनी करी मेरे में मेरी खींचो अरे जल्दी करो ऐसे सुनकर दीदी इससे हमारा खींचिएगा हमारे कैमरे से कुछ बोलो तुम ऐसे खड़ी हो
बस
दीदी इससे अभी एक और कैमरा ऐसे सामने आप आओ इधर आओ साथ में तो आती नहीं लड़की चलो आपका खींचते हैं यहीं ले लो कोई बात नहीं जल्दी आओ पूरे फुल खींचिए
एक फुल लाइए बांध दो जल्दी
एक लो खींचो पहले
बांध दो चलो
खींचो हमारी खड़ी जल्दी खींचो यार मेरा मोबाइल खराब है
बस चलो
खींचो पूरा बोले पहले खींचो सही हुआ कि नहीं
राखी दीदी के हो जाए इनको भी लेके चलेंगे ना ए मेरी खींचो अपने फोन मार देंगे तो हम कूट देंगे देखो हम बोलने जा रहे हैं हेलो इरीना कैसी हो और तीनों मैम के साथ खिंचा लेने मैम चली जाएंगे
निकल यहाँ से आओ बस दे ही रहे हम यार पागल इधर भी आ रही है हाँ इधर से लो प्रियंका भी आ रही है देखो कितना अच्छा रोशनी आ रहा है थोड़ा इधर हो जाओ तिरछा मेरा चेहरा ढक ले रही है कहाँ है बीच में क्लिक करो बहुत अच्छा बना रही वीडियो यार सोना तुमको बताएं चलो तुमसे बनवाती हूँ
नहीं वो तो फिक्स है.
Welcome back, everyone. We'll be beginning with our next session of the day, Management of OSA Dental Intervention. May I request the chairpersons to please grace the stage and take their seats. Dr. Balendra Pratap Singh, Professor, Department of Prosthodontics, KGMU. Dr. Sunit Kumar Jurel, Professor, Department of Prosthodontics, KGMU. Dr. Raghuvendra D. Singh, Professor, Department of Prosthodontics, KGMU. यहाँ पर है सर, इनके ये थे ऊपर नीचे हो गया. I now request the chair to kindly introduce our speaker and open the session. Thank you.
So dear audience, welcome after the lunch break. I hope you will not feel sleepy in the Sleep Summit 2024. Let me introduce about the speaker, Professor Puranchan, who is working as a head Department of Prosthodontics at King George's Medical University. Sir has so many scientific credentials regarding sleep. He has so many patents and copyrights for the different sleep devices. And sir has so many publications related to obstructive sleep apnea, about their different types of dental intervention, different types of appliances. So without wasting the time, I would like to invite Professor Puranchan. Sir will speak on management of OSA dental interventions.
Respected chairpersons, respected my senior teacher, faculty, and students. A very good afternoon after the lunch session. Okay, we are discussing here about all about the obstructive sleep apnea. We are here to discuss about the obstructive sleep apnea. We have discussed about the diagnosis, treatment planning, and other modalities. The treatment modality related to the obstructive sleep apnea, we can classify into primary care management, surgical management, medical alternatives, CPAP, oxygen therapy, and oral appliance. Regarding the primary management, we have discussed here in earlier session. Prevention is better than cure. So you have to counsel the counseling of the patient is the most important step in treating the patient, because It is not only a disease and disturb to the sleeping partner, it is a life-threatening also. The risk counseling about the motor vehicle crashes, job-related hazards, and judgment impairment. The high-risk driving, educate the patient, document warning, resolve apnea quickly, and not only resolve, you have to follow up also. Effectiveness of the treatment and compliance. In this compliance, why the patient not complies your instruction or your treatment planning? So there is so many reasons, either alcohol or sedative use, depression, poor sleep habit, non-apneic sleep disorders, persistent or recurrent symptoms, and consider referral to sleep specialist. So coming to after the counseling, the behavior modification, encourage to patient to reduce the weight, avoid alcohol and sedatives, avoid sleep deprivation, stop smoking, avoid sleep pills or other sedatives, elevate the head of your bed 4 inches, and avoid supine sleep position and sleep on your side. So these are the some behavior modification which can apply without any expense or any medication. For the easy counseling for the patient to sleep one side, you can put a tennis ball in their night wear. Surgical treatment will be discussed by our ENT surgeon. Medical treatment already discussed in an earlier session. So why the dental surgeon involved in this treatment modalities? No doubt the CPAP is the gold standard of the treatment. But there is some region where the need of the dental oral appliances. Most common cause is a claustrophobia. Patient को डर होता कि कैसे लगाएं. Skin irritation, sore nose, air leakage due to leakage of the mask, stomach bloating, the air goes to the stomach, chest or lung pain, dryness of mouth, nasal congestion, eye irritation. These are the common factors which caused by the CPAP or any other such type of the device. So that's why patient again go to that. There is no other alternative. So there is a need of the dental surgeon or prosthodontist to fabricate a customized appliance. There is no pharmacological oral appliance. Come to oral appliance. Which appliance we have to use? Do oral appliance work? That is a big question. It was previously considered that there are no role of the dental surgery or dentist in the treating of the OSA patient. But study shows that there is a international publication that the oral appliance can also effective in the obstructive sleep apnea. This is the Indian Journal Endocrinology and Metabolism journal published by our department, my student. Clinical practice. Then come to how to oral appliance work and why, how to make a appliance. A clinical practice guideline for the treatment of obstructive sleep apnea and snoring with oral appliance therapy in update. This is the Cochrane database study. This shows that apart from the OSA, CPAP, the oral appliances also can be used for this treatment. An American study, Academy of the Sleep Medicine and American Academy of Dental Sleep Medicine clinical practice make a guidelines. There is so many pages, but important it is better to treat the patient with the oral appliance in comparison to the no treatment. If patient is not ready to get CPAP or other such type of devices, then you have to treat with the patient with the oral appliances. Again, second is कि oral appliance should be a custom made and preferably mandibular advancement device. So these are the some guidelines to dental surgeon to how to make a oral appliance. FDA approved oral appliance. There is 3 types of the oral appliances recommended by FDA. That is tongue retaining device, palatal lifting device, and mandibular advancement device. So these are 3. According to need, according to indication, we can use tongue retaining device or tongue retaining appliance. This is the hollow bulb which holds the tongue. This appliance is basically recommended for the edentulous patient or macroglossia, where the tongue is in large size or there is no teeth. This you can see here. There is a soft bulb which holds the tongue, which prevent to drooling up or back positioning of the tongue. You can see here mechanism of action. There is a that appliance hold the tongue and open the airways in upper behind the tongue. Disadvantage. There is a disadvantage also. Irritation of the tongue, drooling of the saliva, or nasal obstruction is a contraindication. If the patient is a mouth breather, then we have to हमें इसको देना नहीं होगा. Palatal lift appliances. In the classification, you can see there if there is a Mallampati classification 3 or 4, that palate goes down and touches the tongue also. So there is no passage to pass the airways. In such cases, we can use this palatal lifting device also. Most widely used appliance is a mandibular advancement device. The mechanism of action is that the mandible goes forward and create a space, open the upper airways. This is the basic concept for oral appliance. You can see here, elevate the base of the tongue, tense the palatoglossal muscles, and pull the soft palate forward, decompress tissue around pharynx, and allow pharynx to extend. You can see here also how to this device pull the mandible forward and open the upper airways. You can classify this appliance in 2 categories, customized and prefabricated. Again, this customized divided into 2, monoblock, it can be monoblock or twin block, again twin block, further divided into adjustable and non-adjustable. So these are the some name of the oral appliances or mandibular advancement device available in the literature and market also. These are the patented by the different researchers and clinicians. These are the different salines. One of the mandibular advancement device is one piece. Another one piece appliance. This is the type of the orthodontic appliance. This is the another splint. This is another appliance. So these are the basic some appliances which used in the treatment of the obstructive sleep apnea. Basically, these are of the thermoplastic material or denture-based material which used in the fabrication of this appliance. So basically, we recommend tritable mandibular advancement device, which is easy to wear the patient and adjust the maxillary protrusion. Then how to make a mandibular advancement device? This is the matter, not a matter to discuss here. Patient assessment, maxillary and mandibular impression, processive jaw relation, record, articulation of the cast, wax up and designing, investing and flasking, and finishing and polishing of the appliance. These are the basic concepts or steps to make a appliance. The basic concept is how much you have to protrude the mandible. The literature says, and on the basis of the exercise and research, it's shown that not less than 50%, but not more than 75%. The total protrusion of the mandible can be adjusted minimum at 50% or 75%. Amount of the bite opening. The bite opening is not a mandatory to open the amount, a larger amount of the jaw, but it's indicated that the 1/20th part of the total opening, or not more than 5 millimeter. So the various studies and researches conducted in the department in the form of the thesis and research work, cephalometric elevation of the mandibular advancement at a different horizontal jaw position in obstructive sleep apnea. A pilot study, it was shown that the different jaw relation, 50% and 75%, there is a significant change in the jaw protrusion from 0 to 70%. But is no marked difference between 50% to 75%. Then again there are another study and evaluated by the CT scan. These are the CT scan pictures about the opening of the upper airways. Another tomographic evaluation. There is picture shows that there is a marked change in the lumen size, dimension of the upper airways. And another study shows that this is not open the upper airways only, that reduces the inflammatory markers in the blood also. This is my cases treated in the department, that is palatal lifting device, and cephalometric study shows that there is a increase the opening of the airways. Again, there is one piece of mandibular advancement device, non-adjustable, and here there is also show the opening of the upper airways. Again here, two-piece mandibular advancement device that is adjustable. And again, in cephalometric study, there is a increase the dimension of the upper airways. How to treat, adjust the appliance in the oral cavity. There is a orthodontic expansion screw which increase the mandibular protrusion. This is another type of the MAD. This shows there is a before the appliance and after the appliance, there is increase in the dimension of the upper airways. Come to conclusion, OSA is a common problem, dangerous to health, easily recognized and treatable. The oral appliances are effective. 60 to 70% cases are mild to moderate OSA patient. It is easy to fabricate and has better patient compliance and economical also. There is no irreversible side effect, but in some cases there is a chances of change in occlusion or pain in TMJ. So you can correct it or observe and correct it in the patient after the discontinuation. Okay, thank you.
Thank you, sir. Very nice presentation regarding the different appliances used for management of obstructive sleep apnea and how to fabricate these things. Is there any question from the audience?
No question.
Okay, sir. Yes, yes, yes.
Regarding OSA, like they don't tolerate. So what is the decontinuation rate in your devices, sir? For the devices are discontinued. They discontinued the devices because they also feel uneasy in these scenarios, sir. Non-compliance to the sir. Now patients are non-compliant to these devices, sir. पर्पस यही है सर, वो कब बंद कर देते हैं आप? मतलब ऐसा होता है क्या कि जैसे हमारे बाईपैप में इरिटेशन हो गया, आंख में जलन हो गई, वो कुछ बातें जो हमारी हैं, पर आपके जो डिवाइसेस है सर वो कितने आराम देते हैं पेशेंट्स को? अगर मान लीजिए कि ऐसे कह रहा है, अमेरिकन सोसाइटी कह रही है सर कि कोई नहीं ट्रीटमेंट देने से बढ़िया डेंटल लगाते हैं सर, तो उसके ऊपर डिसकंटिन्यूएशन आप सर कितना ऑब्जर्व किए सर?
That increase the size of the dimension of the upper vase. So that's act in the long time. But if the patient is suffering from another problem or continue, we can continue the treatment. But after 3 months, we have to discontinue at least for 15 days. Because we have to prevent permanent deformation after one changes in the muscles or TM joint. So there is a repositioning appliance also. कि हम उससे कहते हैं कि हाँ ठीक इतने लगाए, अब ये दूसरा अप्लायंस लगाना ताकि आपका ऑक्लूजन चेंज ना हो या TMD चेंज ना हो. So we have to discontinue after at least after 3 months. Thank you.
Thank you, sir. It was very insightful to learn the interventions that are helpful in managing OSA. I now request Professor Rajendra Prasad, sir, to kindly come on the stage to felicitate our guest speaker and chairpersons. Professor Puran Chand, sir. Dr. Balendra Pratap Singh, sir. Dr. Sunit Kumar Jurel, sir. Dr. Raghuvendra D. Singh, sir.
Our next session, actually it was the initial section got delayed, is about introduction of obstructive sleep apnea. May I request the chairpersons to please grace the stage and take their seats. Professor G.K. Singh, sir. Oh, sorry. Professor G.P. Singh, sir, ex-HOD, Department of Anesthesia, KGMU. Professor R.K. Garg, sir, Head of Department Neurology, KGMU. And Professor S.K. Dwivedi, sir, Head of Department Cardiology, KGMU. Welcome, chairpersons. I request you to kindly introduce our next speaker and start the session. Thank you.
It is my proud privilege to be a part of this meeting. It was unfortunate that we had to come to learn about entity after it has been discussed. But sometimes it is always better to go back to basics after reading a lot. So here we'll be going back to basics of the obstructive sleep apnea, and we are going to introduction of obstructive sleep apnea. And there is no better person than to talk about it than our own Professor Rajendra Prasad Sahab. He has been my teacher, teacher of teachers. His career is illustrious, no need of introduction, but just to remind the newcomers who may not be knowing that he has been former director of VP Chest Institute in Delhi. Then he has been former director of Sci-Fi. He has been former head of pulmonary medicine also, and he's one of those persons who has received B.C. Roy Award. He has been ex-president of various societies, and more than 200 publications and more than 2,500 citations. The credentials and list of his achievements is long. I would not come now in between you and him, so let's learn together about basics of obstructive sleep apnea. Professor Rajendra Prasad, sir.
Thank you, Dr. Dwivedi and other two chairpersons. And I know that they are the stalwarts in KGMC. So I am rather happy that my session is chaired by three very great persons of this institute where I have served for very long years. So what I'll not tell you something very new, although my lecture has been made very easy. Some of the things I spoke during the inaugural address also. But what I'm going to do in next, I don't know how much time I have, 20 minutes. In next 20 minutes is to introduce and to find some Indian scenario, what is happening in obstructive sleep apnea, sleep medicine or sleep disordered breathing. And nowadays, Dr. Dwivedi, I am fond of showing this Japanese proverb that better than 1,000 days of diligent study is one day with a great teacher. I don't find myself a great teacher. This is a proverb because now in our time there was no bunking in the classes, but now we see a lot of bunking, and so I teach my students, I tell them
Anybody coming to a class, please must attend that classes. And I said these words for my mentors, I must say. And the first photograph is Professor B.K. Khanna and rest of other teachers. And there are few persons in the country who they have mentored, maybe during Patel Chest or my other assignment, like Professor P.N. Tandon, Dr. Gautam, Dr. N.K. Ganguly. I happen to interact with them. So they have been my mentor at least, apart from my teacher, Professor B.K. Khanna. These are my institute. I don't want to waste time. You know, sleep medicine, I said, is not very old thing. Maybe maximum 100 years when interest in sleep disorder breathing started. And, but you know, the first, ये भाई कैसे जाएगा इधर सामने आ रहा, इधर आओ जरा, ये क्या जाए, कहाँ से खत्म होगा ये चीज, हाँ ठीक है. You know, the 1970, I told during inauguration also, it means not very far off, about 50 years, literally. Same year I entered into the MBBS in KGMC. So first sleep lab was established in Stanford University to focus all these sleep-related breathing disorders. So we are not far off. In KGMC, I'll show one of the photographs. I'm happy that Dr. Dwivedi is sitting. His seniors will be seen in that photograph. And so it's not very old thing, something new. That's why what Madam Pinky Jawal has said, that awareness is poor. I agree that awareness is poor. We as a clinician, we as a teacher has to make aware people more and more. You know, Indian Sleep Disorder Association was started in India in 1995. That was so it is not, this association is also very young. I happens to be part of this association also. And I will show you, although many people have talked to you, know, this gentleman, when he came to me, देख के क्या लगता है? ये लगता है देख के कि इसको स्लीप, मैं जब यहाँ KGMC में था, मैं थोड़ा काफ़ी इनफॉर्मल हो जाऊँगा, तो मैं अपने रेजिडेंट को ये डांटता था, हर मरीज से पूछो खर्राटे लेता है कि नहीं लेता है. खासकर कुछ लोग यहाँ मोटे मोटे बैठे हैं, बोले जब ऐसे लोग आवे तो जरूर पूछो. So I made this compulsory, although in our case sheets it is not written. क्योंकि we have studied, we have known, तो धीरे धीरे हमको पता लगना शुरू हुआ. So this gentleman, you know, was, you can see his face. अभी मालापट्टी स्कोर का हर आदमी बात कर रहा है. इसी जब उसने जवान खोला तुरंत पता लग गया ये तो ऐसे वाला मरीज होगा. तुरंत पता लग गया, जो जानकार है उनको पता लग जाएगा. So then इसकी कंप्लेंट्स क्या थी? कंप्लेंट्स तो loud snoring, unrefreshing sleep last 3 years, choking spell in the night. Usually wives, अभी किसी ने कहा ना कि जगाती हैं वाइफ की, उठो खराटे भर रहे हो, तुम्हारी सांस रुक रही है. Nocturne and excessive daytime sleepiness. You know, in America, one of the major reasons for automobile accident is obstructive sleep apnea. So nocturia, early morning headache. लोग उठते ना, साहब मजा नहीं आ रहा सुबह, नींद लगता आई नहीं ठीक से, क्या हुआ? These are, he had all complaints, but nobody had detected कि इसको ये हो सकता है. So then ultimately inability to concentrate. So literally every symptom this gentleman had, and BMI 32 था, और neck size पे हम लोगों ने बहुत स्टडी करी कि अगर 17 इंच से ज़्यादा है, अपना नाप लो. जिन लोगों का 17 इंच से ज़्यादा शर्ट पहनते हैं तो beware, हैं?
or abdominal base, respiratory, and then these people are talking about modified Berlin questionnaire. Berlin questionnaire is a screener for obstructive sleep apnea. It has got 3 groups of symptoms. I'll not go, but this gentleman, when we filled that form, we found that many of them were positive, as complaints are. And so final was on the Berlin questionnaire, we found that he had a Berlin questionnaire decides about 2 things, high risk or low risk. So he had a high risk. So we did perform, we were lucky at that time we had a polysomnography in our department. As I said in our inaugural address, first sleep lab of this state of Uttar Pradesh was established by us when I was in KGMC way back in 2008. You know, I'll just repeat, first sleep lab of the world was started in 1970. So I said it is, and it was very good for KGMC. Maybe after 20, 30 years, we have able to establish this. So stop bank questionnaire, somebody touched it. This is another screener where we decide. तो मैं ये कहना चाहता हूँ, खासकर जो यंगर लोग बैठे हुए हैं, मैं अपनी क्लिनिक में शाम को जब मरीज देखता हूँ, ये दोनों क्वेश्चनेयर हमारे यहाँ भरे जाते हैं, हर मरीज का. और जैसे ही भर के हमें अंदाज लग जाता है, वैसे तो देखने से ही अंदाज लग जाता है, लेकिन फिर भी भर के रखते हैं. Then we have daytime sleepiness के लिए there is another scale, Epworth sleepiness scale. और इसका जो Epworth sleepiness scale था 20 था. 11 is the normal, 20 था. It means he has all the parameters, objective parameters, to say that. Then what we do, we did polysomnography. Luckily we have at that time department. We did polysomnography. And what is polysomnography? It's a simultaneous recording of many channels. I'll not bore you, and this is how it moves in the computer, and it is recorded. And you know, his polysomnography report says that his AHI is very, very high, total time analyzed. So he was about 46 or 47 AHI, and apnea, hypopnea, index B. How many apneas and how many hypopapneas, and during whole night sleep. This is a study done in the night, and then you divide it per hour, and then you get, and 5 is normal, 15 up to 15 is a mild, 15 to 30 is moderate, and more than 30 is a severe. That is why what is classified in this. You have heard since morning what is OSA, need not to say, but that is the diagrammatic. Normally, during sleep, the muscles which control the tongue and soft palate holds the airway open. But what happens that if these muscles are relaxed, the airway narrows and causing snoring and breathing difficulties. And if these muscles relax too much, the airway can become completely blocked and prevented breathing, and that is what is called as now apnea. If the half is being prevented, this is known as hypopnea. So obstructive sleep apnea, you know, prevalence-wise, it's not very rare. What I'm trying to say, it's about 4% in men and 2% in women between 30 to 60 years, and sleep. Many studies has been done globally, always in India. And about the Indian scenario I was talking with, we did conduct first study, I said in my inaugural address, and at that time we don't have polysomnography because we conducted in 2003. My first PG student who did this thesis, it was based on Berlin questionnaire, just a screener, because we don't have machine, there's no option. That's why I'm saying to youngster, you have to have innovation in your mind, then you can progress. कहाँ डिपार्टमेंट का टीवी का था ये सुधीर थोड़ा जानते हैं ये लोग, कि अब कहाँ चला गया वो, कहाँ बढ़ गया। तो आपको इनोवेटिव होना पड़ेगा, लकीर की फकीर पर नहीं चलना है। You have to think something. We thought when nobody was thoughting about the sleep apnea. So this first thesis was done, and we presented this thesis in one of the international organization, ACCP in Montreal. And the person who conducted this thesis, he was R.K. Burma. Now he's a very famous sleep specialist in USA. I'm happy to inform you. And he was very simple man, एक गोंडा जिले का रहने वाला था, उसको अंग्रेजी नहीं आती थी डॉक्टर साहब। हमने उसको पहले डांट के अंग्रेजी थोड़ी, वो अंग्रेजी हमें भी कौन सी बढ़िया आती थी, थोड़ी डांट के सिखाया, फिर वो अब now he is in America, leading a very good life and very good sleep specialist. So this study was conducted, and in this study I'll not bore you what we could find that, because I said, no, this screener tells you whether there is a high risk of obstructive sleep apnea. So we found that high risk of obstructive sleep apnea was around 4%. More in male, 2.7, and less in female. So, and this we presented at many forums at that time, many conferences, even publication has been there, and this we did the first sleep meeting maybe in 2008. And you see, Dr. Dwivedi, आप ही के विभाग के लोग खड़े हैं, प्रोफेसर सारान एंड प्रोफेसर नारायण, और कोई दिख रहा है था, मुझे 2 लोग तो दिख रहे हैं जाने पहचाने. So at that time even awareness was not there कि ये हार्ट में भी ये ब्लड प्रेशर करता है और ऐसा करता है. तो they were also very astonished to listen, क्योंकि मैंने तो किताब से, मेरे भी बहुत ज़्यादा एक्सपीरियंस नहीं था, लेकिन थोड़ा पढ़ के उनको सुनाया, भाई ऐसा है, ये बहुत ज़रूरी है. एंड दैट हैज़ लेड टू, फिर हमने टीबी डिपार्टमेंट की सुनता कौन था चेस्ट की, भाई हार्ट वालों की तो सब सुनते हैं, द्विवेदी जी बुरा न मानिएगा. मैं अखबार वालों से कहता हूँ, हार्ट का रोज निकालते हो, कभी लंग का भी निकाला करो, हैं कभी निकाला करो भाई. So anyhow, we convinced our vice chancellor at that time, Madam Suraj Churamani was there. She provided us about 6-7 lakhs of grant, and we opened first sleep lab in the state of Uttar Pradesh in KGMU. So immediately 70 to 2008, 38 years, after 38 years, we have been able to establish in this KGMC. This is all sleep lab you are seeing. Sleep disorder, then there are many people in India, they worked. Not we work, many people like Udwadia from Mumbai. In Mumbai, his figure were very high. Then Dr. S.K. Sarma from AIMS, India, he did a study and he found that same, about 5% and 2%. And then we conducted further one study with one of our PG who is now DM and who's now professor in one of the medical institute, was the study to estimate the prevalence and risk factor of obstructive sleep apnea, and this was published in Monaldi Journal, and I'll not go into details. And you know, the first, every guideline is developed. The first guideline for sleep disorder, what is known as INOSA guideline, popularly known as INOSA guideline, consensus and evidence-based INOSA guide. It was developed in AIMS under Dr. Sarma, and we are all part of it. And this is again a published evidence. So community-based, the epidemiological studies, several parts of India have estimated that prevalence of 2.4 to 9 points. So it means what? This is existing in our society. ये सिर्फ Americans का नहीं है जो मोटे-मोटे होते हैं, लंबे चौड़े होते हैं. In our part also, I see 2-3 faces sitting here, I'll not name. If you test, even you may have some obstructive sleep apnea. और मैंने indicator दे दिया, है? Obesity है अगर. So, diagnosis of OS is very easy. When मैंने तो डॉक्टर द्विवेदी अपनी क्लिनिक पर मैं एक चार्ट लगा रखा हूँ, वही 4-5 सिम्टम के. तो जो अटेंडेंट बैठते हैं हम हर एक चेस्ट फिजिशियन को एडवाइस करते हैं, लगाओ अपनी क्लिनिक में कि स्नोरिंग तो नहीं है, आपका वेट कितना है, आप ओबीस तो नहीं है, आपको ब्लड प्रेशर तो नहीं है, आपको डायबिटीज़ नहीं है, आपको दिन में सुस्ती। 6-7 स्क्रीनर और सिंपल स्क्रीनर है। कई अटेंडेंट मेरे पास जब वो आते तो मरीज दिखाने, लेकिन अटेंडेंट पढ़ते हैं, कहते हैं साहब ये तो मेरे को भी लग रहा है। हमने फिर भैया जांच उच करा लो। सो दैट इज द अवेयरनेस. So I hope every clinic should have, not only chest clinic, every physicians, cardiologist, neurologist, हम luckily हम 2 हमारे neurologist और cardiologist हर के उसमें होना चाहिए. Then you will be able to increase the awareness. And so neck circumference size, we did lot of study and we could find if male has more than 17 inch, शर्ट अगर 17 वाला पहनते हो इंच वाला तो beware. Females में थोड़ा कम है. And we did, after that, at least I did conduct more than 15 theses on obstructive sleep apnea. In era where I am currently working, 5 theses has already been conducted in era itself, in various metabolic disorders, diabetes, many things. And so my take-home messages. I've come to end of my presentation. वेद साहब ने मुझे 20 मिनट अलाउ किया था और 20 मिनट हुआ है. नहीं भाई, बिल्कुल नहीं. मैं ही लूँगा तो फिर दिक्कत कैसे होगी भाई? आपको हम कैसे रोक पाएंगे? First, the leader has to be perfect. मैं हमेशा कहता हूँ, लीडर ही परफेक्ट नहीं तो नीचे वाला तो परफेक्ट हो ही नहीं सकता. So my take-home messages is very simple. I would like to put one case in front of you. अब आपको देख के सबको समझ में आ गया होगा ये मरीज क्या होगा, हैं? अब इसका symptoms सुनिए. He is my own patient, 43-year male, COPD, known COPD patient. Has also complaint of heavy snoring. Bed partner reports that he sometimes stops breathing while he sleeps. मरीज से पूछो खराटे लेते हो, कहेगा नहीं. ये कैच पॉइंट्स हैं. बीवी अगर पीछे खड़ी है वो कहेगी अरे सर बहुत तेज खराटे लेते हैं. सो नहीं पता लगता है. जब आप सोते तो क्या पता लगेगा. सो bed partner reported that he stops breathing while he sleeps, feeling sleepy at times when he drives. मैंने कहा ना ऑटोमोबाइल एक्सीडेंट का one of the major reasons is obstructive sleep apnea. And then has hypertension, द्विवेदी जी की बीमारी है. And then physical examination, you see he was overweight का obese था. BMI was 33 and neck circumference की बात कर रहे हैं 17 इंच से ज़्यादा है. And so what do you suspect? We suspect obstructive sleep. COPD on obstructive sleep apnea. This is also known as the overlap syndrome and very common. So in this situation, if you treat COPD, you will not be successful unless you treat this also. So that is the message what I'm trying to tell. And I put a question, what do you do next in such patient? Leave him as such, मतलब COPD का इलाज करते रहोगे. Treat just COPD and hypertension. Give some drugs for the daytime sleepiness or polysomnography. He is a fit patient to perform sleep study. And polysomnography. So my before I thank you, I was referring this YouTube lecture on during my inaugural address. मेरे ही बच्चों ने मुझसे जिनको पढ़ाया था अब तो डायरेक्टर जनरल्स तक हो गए हैं. वेद जैसे लोग प्रोफेसर हेड हो गए हैं. उन्होंने वो they have become my Facebook friend, some of them. तो उन्होंने कहा सर जब आप एक्सरे पढ़ाते थे MBBS में, धीमन ने अभी मुझे 4 दिन पहले कहा कि आपसे हम पढ़े साहब एक्सरे बढ़िया पढ़ाते, उस वक्त पढ़ाई जाती थी डिपार्टमेंट में. हमने कहा तो that lecture we put on the demand of students. My old student, they are not students now they are big guns. जरूर पढ़े होंगे जो KG से. So I put this YouTube lecture and never thought that अभी इसमें 4 लाख, मैंने कहा था 4.5 लाख लोग व्यू कर चुके हैं. It means X-ray is required for everyone. मैं कहता हूँ एलोपैथिक का ही डॉक्टर नहीं, क्या होम्योपैथिक वाला एक्सरे नहीं देखता, आयुर्वेद वाला नहीं देखता, लेकिन इतना गलत पड़ता है because of the poor teaching and training. That's why I put this YouTube lecture, and now you have seen my book is also released. This is the latest book I got in X-ray, which is in 2 volumes. Its e-book is also available, and it's very cheap book. But I asked my publisher when my book was completed, X-ray किताबें बहुत महंगी होती हैं. हमारा जो फेल्सन जिसकी हम पढ़े थे, उसकी 1 वॉल्यूम की किताब की कीमत 8,000 है. तो मैंने कहा भाई देखो ऐसा है, I don't write book for earning money, I write book for education. So that's why they put about 600 per volume, and it is in 4 modules, module 1, 2, module 3, and module 4. Everything it covers about. And beauty of this book is it is totally Indian patients. Not Indian, I must say, my own patients. उसमें जरूर होंगे कुछ मस्कट उसकट के मरीज जिनका इलाज किया होगा, लेकिन majority they are Indian patients. So with this, this book is also on Amazon, and I would like to end by saying this word again. Anyone who keeps learning stays young. आप देखिए द्विवेदी जी, गर्ग साहब और डॉक्टर साहब अभी जैसे दिख रहे हैं, अभी आए हैं कल MBBS में, हैं? So they are looking young only because they are.
आप भी ऐसे ही दिख रहे हैं.
Thank you. कि they are learning. So अगर आप किसी चीज़ के लिए नहीं सीखें, तो anyone who keeps learning stays young. This is a very famous quote, and that's why in my end slide, whole of the India likes this. कि सर अब अभी भी आप सीखते हो, हमने बिना सीखे काम कैसे चलेगा? So I am still learning. So thank you very much. Thank you, Dept, for organizing such a wonderful conference till this time, and giving me this opportunity to share some of my thoughts with the younger audience, which I always love to do the things. Thank you very much.
Sir, first of all, thanks very much for your nice deliberation, and I would like to congratulate you for your book, 4-volume book on X-ray, and I hope this audience will definitely procure this book and read and get benefited by the words from the doyen of the respiratory medicine. Thank you, sir. Thank you for your, again.
Any questions from the audience regarding some basic issues? It appears that they are all people relating to respiratory medicine, but if there are others, I am seeing psychiatrists also. And so any questions? I'll request my co-chair, Professor G.P. Singh, kindly say a couple of words.
Thank you, sir. Thank you, Dr. Prasad, for giving this very nice deliberations, basics of OSA. And after listening this lecture, I am of the opinion that even I am suffering with OSA. I have to check with you. Thank you, sir.
Thank you. Thank you very much.
Thank you, Professor Rajendra Prasad sir, for that wonderful presentation. It's always a pleasure and delight to listen to you, sir. I now request Professor Ved Prakash sir to kindly come on stage to felicitate our guest speaker and chairpersons. Professor G.P. Singh, sir. Professor R.K. Garg, sir. Professor S.K. Dwivedi, sir. Next किसका है? आर्यम स्लीप का टाइम है 3 से 5 के बीच में, खाना खाने के बाद तो एक
Moving ahead for our next session of the day, chronobiology in older adults. May I request the chairpersons to please grace the stage. Dr. Anil Nishchal, sir, Professor, Department of Psychiatry, KGMU. Dr. Ram Narayan Rawat, sir, Senior Chest Consultant, Balrampur Hospital. Dr. Shweta Kanchan, ma'am, Associate Professor, Department of Physiology, Hind Institute of Medical Sciences. And now, I now request the chair to kindly introduce our speaker.
Hello, good afternoon, everybody. So now we have a very interesting session coming up, and it is on chronobiology in older adults. This is the sleep disorders itself is a specialty area, and the problems of sleep in older adults is a more specific area. And who better to deliver this lecture? It is my pleasure and honor to introduce the speaker for this session. I would request Professor Shrikant Srivastava to kindly come on the stage and join us. Dr. Shrikant Srivastava is FRC Psych. He is professor and currently the head of the Department of Geriatric Mental Health, KG Medical University. He has extensive clinical experience of more than 15 years in assessing and treating psychiatric problems in older adults. And his training actually in geriatric psychiatry includes almost 4 years of training in UK. His areas of research have been treatment of depression in older adults, taste sensation in older adults as related to depression. He has more than 50 publications in national and international journals, and he has 10 books, book chapters to his credit. Above of all of this, he is a very good human being and a very good speaker. So let's enjoy listening to Dr. Shrikant Srivastava. All to you. Oh.
Thanks, Anil. It's pleasure and joy to be here. So thanks to dear Ved. And as I'm a geriatric psychiatrist, I'm talking about older adults. Age is a number. Everybody says that. So there can be a very young 70-year-old coming to the clinic, or there can be a very old 62-year coming into the clinic just after the first one. But all of them share the same chronobiology with variations. So let's get on to it. Chronobiology is in every part, almost every part of the human body. It affects there. It's not only sleep. Sleep is a part of the chronobiological cycles where we go. And you can see that blood pressure, blood glucose, these are the local clocks which are working on their own. That's why we get hungry before 9 a.m. in the morning, because that's our usual breakfast time. Or around 1 to 2 p.m., when it's a natural time for us to have lunch. But if somebody is in the habit of having lunch late, say around 3 or 4 p.m., they'll mainly go around at 1 or 2 p.m. when everybody is thinking about food. But the master is the suprachiasmatic nucleus. That's the director. It keeps a hold, it keeps a check on all these local clocks which are running through. These clocks vary in duration for hours, days, and now it is said that they can vary over months as well, as in the case of a seasonal affective disorder, which is a new diagnostic entity in the last 30 years. And these are not unique to humans. All vertebrates have their own clocks. The lower ones will only have the SCN and very few peripheral clocks if there. Otherwise, SCN is there. Melatonin is secreted in every vertebrate. That's what makes them go to sleep. It may come on at different times, which dictate the habit of that animal. Luckily for humans, it starts secreting after sunset. So, National Sleep Foundation says that 7 to 8 hours of sleep is essential for physical and mental health. But anywhere between 6 to 9 will do. And this is over 24 hours, over a 24-hour cycle. If it's less than 6 or more than 9, there are problems with physical health as well as the mental health. And as a geriatric psychiatrist, I'll say that it has problems with cognition as well. Now, cognition means memory, intelligence, working, judgment, thinking. It can, less sleep or more than enough sleep can adversely affect these parameters as well. To nap or not. Napping is a daytime sleep. We all feel a bit somnolent after lunch, after a good lunch, like the one we had a couple of hours ago. Right? Should we take a nap or not? But I think we should. As long as we still keep to that 9 hours time frame in 24 hours. The students would do that they will be up late in the morning, early morning, 2 a.m. or 3 a.m., going through the textbooks. But when they come back after school, college, at 3 or 4 p.m., they'll take a couple of hours of nap. So that is still sticking to that 6 to 9 hour window. It's just that they have broken it in two. Or one can say you can sleep for 9 hours, 6 to 9 hours straight through, and it will be the same. And that depends on a type of a person one is generally. And there are two types, morning type and evening types. Morning types are those who work the very best in the morning times. So if they can choose at what time they will go for a viva in the final professional, they'll prefer 10 a.m. They will try to get up early in the morning and probably go around for a walk. The evening types, if you ask them what time would you like to have your viva, sir? Just before lunch would do. So that's the difference. And there's a morning and evening questionnaire, which, if anyone is interested, is freely available on the net. Anyway, I digressed. Because if you are sleeping more, then we have got all these problems happening, falls, especially in older adults. And why it happens? When I mentioned earlier that the cognition is affected, then why? Because of less or more sleep, there's an accumulation of beta amyloid protein and tau. Now, both of these proteins are the same, which get accumulated in Alzheimer's dementia, and to some extent in Parkinson's as well, Parkinson's dementia. So the higher levels of these signify that the cognitive processes are slowing down. So their mental arithmetic will be slower, they will become more forgetful, they will not be able to concentrate that much, the efficiency will go down. And that's the reason, accumulation of the beta amyloid and the taus. Right. So this is a meta-analysis which was published in Lancet a few years ago in pre-COVID times. And it included around 80 studies. And they dug up all the studies where a polysomnography was done in a healthy adult. And they had over 5,000 patients. However, having so many dissimilar studies included in one meta-analysis means that the heterogeneity was very high, more than 80%, for all the parameters they tested. So TST is the total sleep time. And as you can see at the bottom, the x-axis is the age in years. So from age 18 to about just before 80, there's 1 hour difference in the sleep. The normal sleep, sleep in normal adults, it's decreased only by 1 hour from age 18 to 80. And then there's a sudden dip. And this is not only for the total sleep time. The other parameters which are on following slides, you find the same thing. That's late 70 or early 80, there's a drastic reduction in the sleep time, sleep efficiency, sleep onset latency, which is on the left-hand side of the graph. Although the AHI events per hour, they start increasing somewhere around mid-50s. So aging is not good for sleep parameters, as tested in a sleep lab. And for each decade of age, all these parameters go down, some less, some more. Do you want me to read all of it? मैं एक एक लाइन पढ़ के सुनाऊं या आप लोग पढ़ लेंगे? I thought so. So in general population, the prevalence of insomnia is 1 to 3%, and Vivek is going to talk after me more about insomnia. But when there are these conditions, chronic pain conditions, cardiovascular problems, respiratory, any other system problems, the prevalence of insomnia and the daytime drowsiness, they both go up drastically. So it's very essential that these metabolic illnesses or the respiratory illnesses should be kept in check. I think Professor Rajendra Prasad alluded that the daytime sleepiness was very high in the last case he showed. So we come to melatonin. This is our usual melatonin secretion. Low levels during the daytime from 7 a.m. to 2 p.m. and after sunset, say around 7:38, probably an hour earlier during the winter times, they start creeping up, peaking around 11 p.m. And that is for most of the normal people, I mean normals, not doctors, when it is a time for the first yawn. Okay. And then they wake up early in the morning. Again, the normal people, not the doctors, 7 a.m. and start the morning routine. But interestingly, the total melatonin secreted in the body in 24 hours increases after birth to just about 10 years of age. And then there's a gradual, steady decline. And by the time the person reaches age 60, it's about 10% of what it was when it had peaked. And melatonin is the hormone of darkness, the hormone of sleep. It is there when it comes at 11 p.m. It starts knocking us, time to go to bed, mate. So if there's less melatonin, the quantity and possibly the quality of sleep will not be as good in a person 60 years or above. And that's our normal cycle, which I just explained. That morning time on the left, the black numbers are the night when the melatonin levels are high. And by 6 o'clock, the sleep urge is going down. But interestingly, there's a peak around midday. Although the melatonin levels are not high at that time, but there's a peak around midday, and that's time when napping happens. And that's what we colloquially call postprandial somnolence. And the need for sleep goes on increasing. Now, the sleep can be altered in two fashions, or the circadian rhythm can be altered in two fashions. Either it's a phase delayed, means the melatonin secretions start increasing a bit later in the evening, and the levels do not decline as early as they should. So sleep late, and wake up late. That's the phase delay. And the phase advance is just opposite. Sleep early, wake up early. Again, a comparative graphs for younger and older adults, younger being in blue. The amplitude of melatonin secretion is flatter, and the SCN firing rate is slower as well in older adults. Same thing about the waking activity, cortisol, glucose levels. There's a difference between younger and older adults. And that proves the point that the circadian clock governs not only sleep, but a lot many physical parameters in the body as well. That's again the relationship between body temperature, glucose, and the cortisol levels. both are, all of these parameters are much less in red, i.e. older adults. Yeah. And their peaks, like in the plasma glucose, is flatter and comes on a bit earlier as well. So, people wake up early, and hence Lohia Park or Janardhan Mishra Park are full of 60 years and above in the morning when they are coming out for the morning walk. One is less likely to find a 30-year-old there. They'll feel out of place. So, how much time I have? 6. 20 minutes time is with questions or without questions with? With questions. Sure. So if anybody is interested in the aging brain, you can come to Genetic Mental Health for a lecture. I'll skip this. हाँ ये slide हमने इसलिए लगाई थी, in short. The box which just popped up. Older adults use both and left and right prefrontal cortices. ये सुना कभी किसी ने? Has anybody heard about this? No? Yes? Maybe? None of the above? ये WhatsApp पे group पे चला था. Older adults are more efficient because they use both their cortices together. I can't remember if it was peri or post-COVID time, but the WhatsApp University had a big following of this. And I was trying to find that paper since that time, what it actually meant. Older adults do use both because they are short of reserve on both of the hemispheres. Not because they are more efficient. Okay, so this is an interesting hypothesis as yet, that the suprachiasmatic nucleus, the director of the whole chronobiological system in the body, the neurodegenerative processes take place there. And misalignment of the circadian function is the primary cause of aging. It's not the other way around. It's not that because people age, the circadian system slows down or worse less. It's because the SCN is working less efficiently, thus the aging process goes up. And like I said, it very well may be a chicken or egg situation, but it still is a hypothesis. Now they did interesting studies in animals, which I think anybody will find very hard to replicate in humans. They transplanted the suprachiasmatic nucleus tissue from a very young animal into older animals. And surprise, 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 that brought the circadian rhythm parameters back to that of a younger animal. न्यूरोसर्जी वाला कोई होता तो पूछते हम लोग उनसे क्या कर सकते हैं. So take home message, regular bedtimes, keep within that limit of 9, and don't be stingy with 6. Avoid over-the-counter medications. And for older adults, morning is better for physical and mental activities. I think I'll stop here. This is what this talk should be titled. It's just a taster. It's not the whole chronobiology. So, with suggestion for you. Thank you.
Thank you, sir. Very nicely covered your topic, sir. And we all are enlightened by chronology in older patient, not only older patient, in younger patient also. Following the biological cycle is, I think, important for every person, because if we are following the biological cycle, everything, sleeping at the fixed time, early to bed or early wake up is always good. And physical activities, if you do in the morning, and mental activities also, it is more fruitful and more efficiently we can do what we are doing in the morning. Even then, daytime is also very good if we take sound sleep in the night. Very nicely covered. So, any question from audience?
So are there any questions from the audience? Sir, it was a very interesting as well as informative talk. Thank you so much for it. A question came to my mind while I was listening to it. Like with regard to nap, we have some protocols like napping should be of limited duration so that it doesn't disturb the homeostatic urge to sleep. And perhaps in the earlier part of the day, with regard to older adults, sir, is there some recommendation or what you suggest them, how should they nap so that as such their ability to get a consolidated sleep is disturbed or it decreases with age? So what is the suggestion for a nap and which doesn't disturb the nighttime sleep?
The napping should be as short as possible and as early in the afternoon as possible, right? And that's the chronobiological bit of it. The physical bit of it is, if they add physical exercise in the evening time, then the increased physical tiredness will again help them to go to sleep easily and at a time desired by them.
So that is something important with regard to sleep hygiene in older adults. Yes. Thank you, sir.
Right. So I also have a question, sir. Just came to my mind that all physicians often get patients who are very comfortable, especially older adults, taking 0.25 milligram of clonazepam or to 0.25 milligram of alprazolam or say 10 mg of amitriptyline कि डॉक्टर साहब ये बंद नहीं करिएगा बस इसको चलते रहने दीजिए. What is your take when you are handling these kind of things with older adults?
The polite answer to that: don't rock a stable boat. In reality, if somebody is sleeping fine with something which is not going to harm them physically, then don't touch it. Don't go anywhere near it.
Right.
The problem being, if somebody starts with 0.25 of clonazepam and has progressed to 2 milligrams of clonazepam, then that's a problem. But if the clonazepam is only 0.25 for the last 12.5 years, now we say that the sedative effect of benzodiazepine wears off or a person develops tolerance to it after a few weeks. But there are some reports in early 90s which say that tolerance to the sedative effect of benzos never develops.
So I get the point. Should not disturb their quality of life and sleep.
Prescription में उसको एक अलग box में करके लिखना चाहिए. Do not disturb.
So if there are no more questions, then we can close this session and we'll hand this session over back to the organizers. Thank you so much.
Thank you, sir, for throwing some lights on this part of sleep disorder. Now I request Professor Ved Prakash sir to kindly come on stage to felicitate our guest speakers and chairpersons. Professor Shrikant Srivastav sir. Sir, please come on the stage. Dr. Anil Nishchal, sir. Dr. Ram Narayan Rawat, sir. Dr. Shweta Kanchan, ma'am.
Let's proceed to our next session of the day. For our next session, Insomnia, Clinical Evaluation and Management, may I request the chairpersons to please come onto stage and take their seats. Dr. Shrikant Srivastav, sir, Professor and Head, Geriatric and Mental Health Department, KGMU. Dr. Bandana Gupta, ma'am, Professor, Department of Psychiatry, KGMU. Dr. Naresh Kumar, sir, Professor and Head, Department of Pulmonary Medicine, Maulana Azad Medical College, New Delhi.
So the next session in this series is Insomnia, Clinical Evaluation and Management Options. That will be taken by Dr. Vivek Agarwal, who is Professor and Head Department of Psychiatry, KGMU. His area of interest is child psychiatry, ADSD, conversion and stress-related disorders. He has published more than 150 papers in national and international journals. So over to you, Dr. Vivek Agarwal, please.
Well, good afternoon. Thank you, Dr. Ved, for inviting me for this talk. Insomnia is fairly common. Dr. Shrikant ने थोड़ा कम बताया था. So if we talk about the symptom as insomnia, then it can occur up to 50% of the population. So we all have experienced some transient insomnia and the short-term insomnia. As a disorder, insomnia is again very prevalent, up to 20%. There are many risk factors. It is especially associated with female sex and it increases around menopause. Older age, already talked about, low socioeconomic strata, concurrent medical and psychiatric disorders. It usually takes a chronic course in 40 to 70% of the individual for years together. So I have seen children or young adults who have reported that right from their early childhood they never slept well. So there are cases like that. It leads to lots of consequences, and insomnia can be reason for development of psychiatric disorders like depression. It may affect the course of the psychiatric disorders or substance use. It may be associated with metabolic syndromes or cardiac diseases. Coming to the diagnosis, it's fairly simple. If the patient is reporting any problem with the initiation or maintenance of the sleep, and it should be differentiated from people are not getting adequate time to sleep from people who are getting adequate opportunity and time to sleep. Again, it has daytime consequences. Duration must be 3 months with at least 3 times per week. One of these daytime symptoms must be present for the diagnosis. So I won't go into details. You all know about what are the daytime consequences. In assessment, sleep diary, we ask questions about usual routine of the patient, what time patient goes to bed, many attempts to sleep, wake up, getting how many times out of the bed, sleep latency, so when the patient goes to bed and how much time it takes to sleep onset, number and duration of awakenings, wakefulness, it is early morning onset, early morning awakening, or even if the patient is awake, he is still in the bed, and total sleep time, as well as quality of sleep and satisfaction with the sleep. Then there are factors you should record about the sleep, like what patient does while he is going to sleep, using screens and other activities. How is the environment? It's too hot, too cold. There is light, there is sound. Problem if the bed partner is snoring, or there are pets in the home. And you should also record the perceived causes of awakening. If the neighborhood is too noisy, घर के बगल में शादी हो रही है, डीजे चल रहा है, that will be the reason. Then one must inquire into the associated or presence of other sleep disorders. OSA, restless leg syndrome, parasomnias, or just talked about chronobiology. Then other causes, especially related to the sleep hygiene. If somebody is napping too much in the daytime, more than 30 minutes a day, vigorous exercise in the evening, what work or activities related, especially if they are doing work for the late night, which is stressful. There are other stresses, psychosocial factors, which patient is stressed about. Use of caffeine, alcohol, or tobacco, especially after 4 in the evening. All these things affect the night onset of the sleep. Medical causes, neurological, especially traumatic brain injuries, is one of the reasons for onset of insomnia. Pulmonary, already talked about, chronic pains, endocrine problems, GI reflux, cardiovascular problems, all these things affect the sleep. Large number of psychiatric disorders are associated with sleep problems. I won't go into the details. medications, one must carefully check the list of medication and their side effect of insomnia. Antidepressants, especially fluoxetine or bupropion, many antihypertensive, steroid, decongestants, adrenergic agonists, all these can interfere with the sleep. Test primarily is maintaining a sleep diary, recording the details about the sleep, sleep-wake timing, quality, quantity, actigraphy. Actigraphy is something like a smartwatch which records the details related to sleep. Polysomnography is not recommended for insomnia per se, but it is helpful in evaluation of other sleep disorders like sleep apnea or parasomnias. Behavioral interventions are the best interventions for short and long term, which is called cognitive behavior therapy for insomnia. It's a multimodal treatment. The first part of this is sleep hygiene, which is very, very important for anybody to practice to have a good sleep. So going to bed at a regular time and waking up at the regular time. Room should be dark and quiet. Avoiding substances, especially after 4 p.m. Exercise in the daytime, not in the evening, especially vigorous. Daytime nap, not more than 30 minutes. Avoiding screens, which is very important, 1 to 2 hours before bedtime. Second part is stimulus control. So there is a vicious cycle. When the person is not able to sleep, he is worried a lot, and as the day progresses or with the onset of night, they start ruminating whether I will get sleep, what will happen, how I will spend my night. So this takes care of these ruminations and worries, and this breaks the cycle, especially association between worries and the going to bed, because it significantly interferes with the onset of sleep. Relaxation training, very, very helpful. Deep breathing, muscular relaxation, or guided imagery. Sleep restriction is avoided advised in some. Basically, it is the spending time on the bed only in sleeping. Avoid wake time spending in the bed. So that is something crudely called sleep restriction. Then the last part is cognitive therapy. So cognitive therapy addresses the errors or the cognitive errors of thinking associated with the insomnia. So there might be errors like overestimating the number of hours कि बहुत ज़्यादा सोने की ज़रूरत है नींद पूरी करने के लिए, apprehension about controlling the sleep, fear about missing opportunities for sleep. So one can write their apprehensions in a journal, so reduce in ruminations. One can give them some behavioral experiments for their beliefs about the sleep. So cognitive therapy is the best, and it has the high impact factor. In pharmacotherapy, we have large number of drugs. So there are jet drugs, which are non-benzodiazepine hypnotic drugs. Then we have benzodiazepines, zolpidem, then lorazepam, clonazepam, alprazolam. Recent one, orexin receptor antagonist, suvoroxant, lamborexant. Antidepressants, trazodone, amitriptyline, doxepin, mirtazapine. Antipsychotic like quetiapine. and melatonin receptor agonists like melatonin and ramelteon. So I won't go into details of all these drugs. In the latest network meta-analysis published in 2022 in Lancet, the highest evidence of effectiveness is for benzodiazepines, that is 0.83, followed by Z-drugs and Rexents. And all these for the short-term use, 4 weeks. In long-term use up to 3 months, Z-drug, azopiclone and lemborexant has been found efficacious and safe. So drugs are not recommended for long-term use. So CBT for insomnia is as good as benzodiazepines, that is 0.83. So coming to conclusion, insomnia is a very common problem but ignored both by patient as well as the doctors. It has severe psychological as well as physical consequences in long term. Patients in any clinic should be routinely screened for the sleep problems, and at least one should advise for the sleep hygiene first before prescribing the medication. And behavioral treatment are the best treatment for long term. These are my references. Thank you.
Thank you, Vivek. Good. From diagnosis to management, you covered everything within a stipulated 18 minutes.
Thank you, sir.
So we are open for questions.
It's a very nice presentation, and we are very much benefited by the behavioral techniques, the cognitive distortions, how to take care of them, and minimal use of the drugs, and that too not for a very long time. So a very interesting and wise presentation. If any questions, we can entertain that. Otherwise, we'll close this.
No questions? Okay. So we close the session here.
Thank you, Professor Vivek Agarwal, sir. We are grateful for the time and effort you took to share your thoughts and experiences with us. I now request Professor Ved Prakash, sir, to kindly come on stage and felicitate our guest speaker and chairpersons. Professor Vivek Agarwal, sir. Professor Shrikant Srivastav, sir. Professor Bandana Gupta, ma'am. Professor Naresh Kumar, sir.
Thank you, everyone. Moving ahead towards our last session of the day, focus on obstructive sleep apnea. May I request the chairpersons to please grace the stage. Dr. Ravi Bhaskar Sir, Professor and Head, Department of Respiratory Medicine, Career Institute. Dr. Rahul Srivastav Sir, Professor and Head, Department of Respiratory Medicine, Integral Medical College. Dr. Mohit Sinha Sir, Professor, Department of ENT, Ram Manohar Lohia Institute of Medical Sciences. I now request the chair to kindly introduce our speaker and start the session. Thank you.
Good evening, ladies and gentlemen. Now the next session is on sleep-related breathing disorders with especially focus on obstructive sleep apnea. And to share experiences on OSA, we have our favorite, सबके favorite Dr. Ved Prakash, and he is head of department Pulmonary and Critical Care Medicine in KGMU, UP. He is former Deputy Medical Superintendent in KGMC Lucknow, former Deputy Registrar KGMU, former OSD COVID Control UP Government. He has got Young Achievers Award, Coroner Warrior Award, UP Ratna Award, and several other awarded by Honorable Governor, Honorable Chief Minister, and Deputy Chief Minister of Government of Uttar Pradesh. He is thesis supervisor of DM, MD, PhD, and PDCC courses. His area of interest is lung cancer, critical care, and interventional pulmonology. And Dr. Ved Prakash is like my elder brother. He is always there to help us whenever we need, right from the first day. And as far as I know, boss, you are the only person who is having fellowship of American Academy of Sleep Medicine. उस समय आप गए थे करके आए थे जब मैं नया नया ज्वाइन किया था तो it's a matter of great privilege for us. So now to discuss on OSA, over to you, boss.
Thank you, Dr. Ravi, for nice words. So today's sleep-related breathing disorders, mainly I can say the focus on OSA, and we all are dealing with obstructive sleep apnea and its syndrome. So this talk was scheduled in inaugural time, लेकिन सब लोगों ने यहाँ पर धक्के मार मार के मुझे यहाँ तक पहुँचा दिया है सबसे लास्ट में. ये पहले था सर, आपसे भी पहले, लेकिन मुझे सबसे पीछे कर दिया गया है. तो अब अभी सर्केडियन रिदम की बात हो रही थी, क्रोनोबायोलॉजी पढ़ा रहे थे श्रीकांत सर. अब श्रीकांत सर आप बताइए कि जो सर्केडियन डिप है वो दिन में कब होता है? श्रीकांत सर, सर्केडियन डिप का जो दिन का समय है वो कब है? हाँ, तो अब ये काम मुझे पकड़ा दिया कि सबको जगाए रखो और सर्केडियन डिप को हम लोग उसको ओवरकम करें. लेकिन फिर भी मैं कोशिश करूंगा, क्योंकि जब हमारे सर सामने बैठे रहते हैं प्रोफेसर राजेंद्र प्रसाद, तो हम लोगों को एनर्जी मिलती रहती है, कहीं ना कहीं वहाँ से ऊर्जा मिलती है. So thank you sir for being always up to the last session. कैसे चलेगा भाई बताओ, ये इससे कौन आगे कैसे बढ़ेगा? ये इससे है क्या? इससे नहीं, ये है. हाँ, अच्छा, कहाँ हुआ ये? तो आगे, अच्छा अब होगा, इससे भी हो जाएगा. हाँ. So my tribute to my mentor, my teacher, our guiding force, and I can say teacher of teachers, and always guiding us. मैं तो ये कहता हूँ कि जो जर्नी हम लोगों की टीवी डिपार्टमेंट से लेकर के और यहाँ तक की है, उसमें सर का जो एक फोर्स है, गाइडिंग फोर्स, जो उनका एक हमेशा ही हम लोगों को लगातार प्रोत्साहन मिलता रहता है, गाइड भी करते हैं, रास्ता दिखाने का काम भी करते हैं सर. सो थैंक यू फॉर बीइंग विद अस ऑलवेज. So what is sleep disordered breathing? It includes abnormal respiratory patterns like apnea, hypopnea or RERA, or central sleep apneas with hypopnea syndrome including Chinese stroke breathing syndrome, or central hypoventilation leading to hypoxemia or altered gas exchange. So these are the component. And apnea. So what is apnea? When we have to score apnea, so for apnea scoring, we need these criterias. One is oronasal thermal sensor, or alternative drops by more than 90% of baseline, duration of more than 10 seconds, and at least 90% of events duration must meet apnea amplitude reduction criteria. So this is how we score the apnea, and we classify like obstructive, mixed and central. In obstructive apnea, it continued or increased inspiratory effort for duration of apnea, and mixed like initial absent inspiratory effort in the first portion of event, and then resumption of inspiratory effort during second portion of event. So, and this is mixed. And central apnea is absent inspiratory effort for duration of apnea, and desaturation not needed to score apnea. So this is how we score apnea and classify apnea. Then hypopnea, what is the recommendation? All criterias like NP excursion or alternative score drop by more than 30% baseline amplitude, duration more than 10 seconds, and at least 90% of duration must meet hypopnea amplitude criteria, and more than 4% arterial oxygen desaturation from pre-event baseline. And another is hypopnea alternative recommendation, that is NP excursions more than 50% of baseline amplitude, duration more than 10 seconds, at least 90% duration must meet hypopnea amplitude criteria, and more than 3% arterial blood oxygen drop from pre-event baseline, or followed by arousal. So this is alternative recommendation. Then there is another term, RERA, that is an sequence of breaths lasting at least 10 seconds, increasing respiratory effort or flattening of the waveform, followed by an arousal from sleep, and doesn't meet criteria of apnea or hypopnea. So this is RERA. And hypoventilation is increased in PaCO2 or ventilated surrogate more than 10 mm of mercury above a supine awake value. So these are the criteria for apnea. So with arousal included in the alternative definition of hypopnea, the relevance of RERA, respiratory effort related arousal, diminishes due to its overlap streamlining diagnostic criteria in sleep medicine. This evolution ensures a more focused approach in identifying and managing sleep disordered breathing events. So this is, and with what are obstructive sleep apnea and obstructive sleep apnea syndrome? So subset of sleep disorder breathing, OSA, occurrence of average 5 or more episodes are normal. For obstructive respiratory events, apnea, hypopnea, or rera, per hour of sleep with either sleep-related symptoms or comorbidities, or more than 15 such episodes without any sleep-related symptom or comorbidities. And what is syndrome? It defined as OSA associated with daytime symptoms. So if we have the daytime symptoms associated with OSA, then most of the time the excessive sleepiness in daytime, then we will call it like syndrome, obstructive sleep apnea syndrome. So these are the risk factors like obesity, present roughly 70% of OSA cases have the evidence of obesity. Then male sex is also a risk factor. Aging, elderly aged individuals are also prone for this OSA. Then post-menopausal state, black race, there are some studies pointing towards black race are more affected than alcohol intake or smoking. So these are the risk factors. And burden of obstructive sleep apnea, the prevalence of OSA varies significantly based on population being studied and how OSA is defined. So prevalence of OSA has been estimated to be 14% of men and 5% of women. So you can see how much is the magnitude. 14% males and 5% females are affected. In a population-based study utilizing an AHI cutoff of more than 5 events per hour of hypopneas associated with 4% oxygen desaturation combined with clinical symptoms to define OSA. So these are the huge burden affecting both sex, male more than females. So in the USA, these are some studies in USA, Hong Kong, Australia, Japan, Singapore. These are some studies pointing towards male sex is more affected. And this is the study from USA in where 804 participants in the sleep heart health study cohort, and there were increased incidence among the males. In India, there is also one study including 365 subjects from the South Delhi district in 2005-07, and Chicago scoring criteria, and they also find the same results. So this is the normal breathing airflow. This is normally, you can see the normally breathing airflow, and this is snoring. The airflow is obstructed here, and this is complete cessation. So this is apnea here. If this cessation is for more than 10 seconds, then this is obstructive sleep apnea. So this is the pictorial presentation, and you can see the normal and obstructive apneas with abnormally enlarged tongue, long soft palate or tonsillar enlargement, extended uvula, high palate vault, and posteriorly positioned mandible, that is retrognathia or micrognathia, as the dental department also presented, and loss of normal occlusion for sleep apnea. These are the normal and anatomical factors, and this is for sleep apnea. loss of normal occlusion, adenoid hypertrophy, reduced pharyngeal upper airway space, increased distance between the mandible and the hyoid bone, increased neck fat deposition surrounding the upper airway. So these are the features the OSA patient have. And then the obstructive sleep apnea patient exhibit a range of upper airway features, both anatomical and functional. To better understand and treat OSA, the Palm scale assesses key factors like airway collapsibility, arousal threshold, loop gain concept, and muscle responsiveness. By utilizing this scale, healthcare professionals can tailor interventions based on the specific physiology, each patient upper airway enhancing treatment effectiveness. And this is the loop gain concept, measures the stability of the feedback control system in regulating breathing, and quantifies the system's response of disturbances such as airway collapsibility in OSA, and determines how quickly and effectively the body corrects these disturbances. And high loop gain indicates a system that is overly sensitive to disturbances, leading to exaggerated response and potential instability. Conversely, a loop gain indicates a more stable system with less sensitivity of disturbances and more controlled response. So this is the concept of loop gain. And application of loop gain in OSA, high loop gain means that even minor disturbances in airway patency trigger exaggerated responses, leading to frequent arousal from sleep and disrupted breathing patterns. So this heightened sensitivity can lead to a vicious cycle where frequent arousals exacerbate sleep fragmentation and worsen OSA severity. And the sleep depth is, increasing day by day, and they are in sleepless nights. So these are the some predictions. There are some nocturnal symptoms and daytime symptoms. You can see about this snoring, observed apneas, frequent nocturnal symptoms, obstructive sleep apnea syndrome, and snoring is most characteristic nocturnal symptom of OSAs, and observed apneas and frequent cause of is for consultation. The patient came with these apneas, and then arousals followed by apnea, and others like night sweating, nocturia, restless sleep, somnolence, and symptoms of GI reflex, additional nocturnal symptoms related to obstructive sleep apnea syndrome. So this is the nighttime symptoms, and daytime symptoms include most patients having excessive daytime sleepiness and poor concentration, tiredness, which is due to sleep fragmentation. In addition, morning distension, headache, apathy, depression, irritability, or changes in affect, memory loss, social issues, decreased libido, and erectile dysfunctions are other characteristic daytime symptoms of the patient with obstructive sleep apnea syndrome. So these are the symptoms, and how we predict. The Berlin questionnaire consists of 3 categories. Category 1 comprising of questions 2 to 6, where a score of 2 or more positive responses indicate a positive result. For that category, similarly, category 2 encompasses questions 7 to 9, and a score of 2 or more positive responses is considered positive for that category. Category 3 is positive if there is at least 1 positive response, or if the individual's body mass index exceeds 30. 2 or more positive category in high likelihood of OSA. By stop bang, high risk is scored in 5 to 8, intermediate risk is 3 to 4, and low risk in less than 2. So this is the questionnaire. And in this meta-analysis, the Berlin questionnaire demonstrated a pooled sensitivity of 76% and a specificity of 45% for predicting obstructive sleep apnea when using as an AHI cutoff of more than 5% as normal. In the meta-analysis, the stop bank questionnaire exhibits a pooled sensitivity of 93% and a specificity of 36% for predicting obstructive sleep apnea, and when utilizing an apnea-hypopnea index cutoff of 5%. And the Berlin begin by assessing the patient clinical history, symptoms, and risk factors for OSA, then utilize validated screening tools such as the stop bank. Positive screening results may prompt further evaluation, then consider ordering a full in laboratory polysomnography for patients with high clinical suspicion of OSA. In selected patient without significant comorbidities or with a high pretest probability of moderate to severe OSA, evaluate the result of polysomnography and SSAT to determine the presence and severity of OSA based on parameters such as the hypopnea-apnea index, oxygen, and oxygen desaturation levels, and associated sleep disturbances. Then based on the diagnostic findings and the patient's clinical presentation, decide on appropriate management strategies, schedule follow-up appointments to assess treatment, adherence, and symptom improvement, and objective measures of treatment efficacy. So this is how we diagnose the OSA. There is the concept of phenotyping of OSA, the need for an individualized approach for each and every patient. So OSA is increasingly recognized as involving a clinical spectrum that far surpasses the classical picture of the male obese and sleepy patient. A range of varying phenomena are now recognized that affects many aspects of the disorder. Pathophysiology, especially relating to pathogenesis of upper airway obstruction, loop gain, and arousal threshold. Clinical presentation, heterogeneity of symptoms, daytime sleepiness, insomnia, and mood disturbances. Some patients have only minimal symptoms. Associated biomarkers such as inflammation, microRNA, vascular and polysomnographic parameters predicting prognosis and response to treatment. And the comorbidities recognized to be highly associated with OSA, like arterial hypertension, non-dipping nocturnal blood pressure, insulin resistance, and increasing obesity. So these are the proposed phenotypes. We have the subgroups. The author suggests that OSA can be categorized into distinct phenotypic based on factors such as anatomical variants in the upper airway, comorbidities, and response to treatment. So subtype A in younger obese, predominantly male individuals with severe OSA and classic symptoms such as sleepiness and drowsy driving, they tend to benefit most from CPAP treatment and are at higher risk of cardiovascular disease. And subtype B is older, obese, predominantly male individuals with minimum to moderate symptoms burden, but marked hypoxemic burden. So they have frequent comorbidities and may exhibit lower CPAP success rates. Although fatigue and apneic episodes may improve with treatment, and the subtype C is middle-aged, mildly obese, predominantly female individuals with symptoms of insomnia. They may have moderate to severe OSA and higher prevalence of hypertension, diabetes, and cardiovascular disease. So CPAP success may be lower, but regular users may experience improvements in sleepiness and restful sleep. And subtype D, that is relatively younger, non-obese, predominantly male individuals with primarily upper airway symptoms such as snoring or sudden awakening. They have severe OSA but may not exhibit significant sleepiness. So CPAP success rates may be lower, similar to subtype C. In subtype E, predominantly male individuals with higher severe OSA, highest BMI, and marked hypoxemia. They have high levels of sleepiness and obesity with increased risk of cardiovascular diseases. And in subtype F, predominantly male individuals with severe OSA, lower BMI, and low degree of hypoxemia. Of a given AHI, they may have lower levels of sleepiness and shorter respiratory events duration, suggesting factors that then pharyngeal collapsibility may contribute to the OSA pathogenesis. So these are the proposed phenotypes subgroups for further study. ASM, obesity, severity, you all know that less than 5 events per hour is normal. AHI index 5 to 15 events per hour is mild, and 15 to 30 is moderate, and more than 30 events per hour is severe. So this is AHI severity in oversimplification. You can see the obstructive sleep apnea severity can be visualized in a 3-dimensional model, and x-axis represents the frequency of respiratory events like apneas and hypopneas during sleep. The y-axis signifies the acute systemic effects caused by these events, such as oxygen desaturation, and z-axis reflects the chronic impact on organs like heart, blood vessels. The volume of X, Y, Z encapsulate the interplay between events, frequency, acute effects, and long-term organ damage, highlighting the complexity of OSA severity. So this is how we quantify the issue. Then the proposed multi-component grading system for obstructive sleep apnea severity integrates symptomatology, Epworth sleepiness scale, scores, vigilance test, results, and cardiovascular metabolic impact. Patient with ESS of less than 9, no daytime dosing episodes, normal vigilance test, and absence of self-assessed hypersomnia are categorized as having mild symptoms. Severity increases if any parameter is positive, with classification into subgroup A, B, or C. A or C based on presence of comorbidities or end organ damage. Group A or B signifies minor impact, while group C or D indicates major end organ involvement. So this is the proposed multi-system grading of obstructive sleep apnea syndrome patients. And now is the management. You can see the we have medical management and surgical management. This is the medical management like supportive care, PAP therapy, other management strategies. Then supportive care includes exercise as tolerated, receive routine vaccinations, counseling against cigarette or cannabis smoking, and maintain a normal body mass index. This is, I think, a most important feature. We have to control it. And patient with OSA should be additionally treated or any comorbidities known to be associated with a worsen OSA. So this is positive airway PAP therapy, like polysomnography test. Then if AHI less than 5, then 6 to 14 and more than 15. More than 10 RDIs plus excessive daytime sleepiness. If yes, then we have to enforce PAP therapy. If no, the PAP therapy not indicated. In AHI 6 to 14 symptoms or sequel present, yes, then PAP therapy. If no, then mission critical worker. If yes, then PAP therapy. If this is some driver, then we have to enforce the PAP therapy. If no mission critical worker, then PAP therapy not indicated. And if AHI is more than 15, then you have to enforce PAP therapy in each and every patient. So this is how we enforce PAP therapy. Then other therapeutic interventions, like Palm scale categorizes OSA patients based on anatomical and non-anatomical factors. 23% fall into Palm scale 1, indicating severe anatomical issues, warranting major anatomical interventions like CPAP. 58% are classified as Palm scale 2, where 35% Palm scale 2A have no major non-anatomical factors and benefit from anatomical interventions like CPAP, MAD, or positional therapy. Within Palm 2B, that is 64% of patients have multiple non-anatomical factors necessitating a multi-pronged approach such as combination therapy or multiple non-anatomical interventions. Palm scale 3 encompasses 19% with minor anatomical issues and indicating potential efficacy with more than one non-anatomical intervention. So this is the other interventions. And limitation of phenotypic management is measurement of Palm variables is still complicated in the clinical setting. Currently, there is very limited data on reproducibility of phenotypic clusters within the same data sets, and available interventional studies tailored to physiological trait are still small scale, short-term proof of concept studies. So this is the limitation of proposed phenotypic management. And then the take-home message from my side is obstructive sleep apnea is a disorder that is characterized by obstructive apneas, hypopneas, and or respiratory effort-related arousals. Well-defined risk factors of OSA include older age, male sex, obesity, and craniofacial and upper airway abnormalities. The heterogeneity of breathing disturbances associated with OSA, daytime or nighttime symptoms, and end organ damage advocates against in simple approach focusing mainly on AHI. Then there is an urgent need for the definition of phenotypes based on polymorph monographic clinical outcome parameters, and this may facilitate an individualized and critical use of positive airway pressure emerging as new therapies. So this is my take on this subject. Thank you for patient listening.
Very enlightening and elaborated lecture. Thank you, Vidbos. If anyone is having any question, they may ask.
Rajendra sir, one thing I want to ask you, Dr. Ved, why you have chosen this sleep topic on your platform? On the pulmonary and critical platform, you are talking about the sleep.
Yes, so this is, I think, very important question for other colleagues dealing in other specialties. You know, the obstructive sleep apnea syndrome is affecting 93 crore of population worldwide. And the event is in respiratory system. That is obstructing upper respiratory tract and affecting lower respiratory tract and oxygenation or air exchange. So this is all about the disturbances related to gaseous exchanges, leading to further complications and involving other specialties. So now the specialty of sleep medicine is evolving. I can say when I was in USA in 2011 and 12 for sleep fellowship from American Academy of Sleep Medicine. Now the departments in India also are Department of Pulmonary, Critical Care and Sleep Medicine. So this is how we have to take this complex. Rather, I can say there are other issues like insomnias. Insomnias can be dealt with psychiatry or geriatric mental health. Circadian rhythm disorders, also they can take care. And others are like parasomnias and other events in neurology also. So this is something like multifactorial issues. And
that's
you
why I'm
can
asking,
see
the multifactorial things, the sleep disorders and related issues are multifactorial, but you are organizing on your platform.
Yes.
Just what is the main key point? Why you have?
this is basically
Yes, sir.
you चलिए सर से भी आप
Actually, your question is very right. You know, when sleep disordered breathing came, probably you were in my lecture, it is not very old science. It's science literally about 100 years. Most of the sleep labs, they are in the respiratory department. Why? Because main is obstructive sleep apnea. Although it affects many departments, it affects cardiology. इसके outcome तो cardiology में है, neurology में है. तो जो अब departments के नाम जो नया nomenclature शायद कुछ दिनों में आ जाएगा, जैसे ये कह रहे हैं pulmonary plus critical care, but it's and plus sleep medicine. तो इसीलिए ये sleep medicine chest के संग ही associate हुआ, जहाँ भी nationally internationally.
I think there is some philosophy we have read, come through after many teachings. I think so. I want to highlight because हमने यहाँ पढ़ा है कि मन का जो रिलेशन है, लगते हैं कि दिल और दिमाग का रिलेशन बोला गया है. दिल दिमाग के साथ आया है. कभी दिमाग को जो है फेफड़े के साथ या एल्यूलाई के साथ जोड़ा नहीं गया है. ये लेकिन अब जो फिलॉसफी आई है वो ये कहती है कि जो स्लीप है इट इज़ अ मैटर ऑफ माइंड. जैसे आपका न्यूरोनल सॉफ्टवेयर है, इट इज़ अ माइंड, एंड वी आर टॉकिंग अबाउट द आत्मा, दैट इज़ अ डिफरेंट इशू. आई एम जस्ट टॉकिंग अबाउट द मन एंड द बॉडी. बॉडी मीन्स एट द लेवल ऑफ एल्यूलाई, एंड फॉर मन आई एम टॉकिंग अबाउट द स्लीप. Just like you are charging your mobile, just you put a charging, and when it is compatible with your charger and all set, it charges. Otherwise, it is not compatible. There will be heat. The more of issue is like that. What I am understanding here. So I have heard some lectures from philosopher that they have said कि जो मन है वो दिल से नहीं बधा है, ना दिमाग से बधा है. मन रियल में सांसों से बधा है. अगर मन को रोकना है तो सांसों पे जाइए. इसलिए आपने सही टॉपिक और सही जगह पे चुना है. मन को रोकने के लिए, मन को शांत करने के लिए ये पल्मोनरी वाले ही रोक सकते हैं. और वास्तव में आपने बहुत अच्छा काम किया. हम इसलिए आपको बहुत बहुत धन्यवाद देता हूं और इसलिए मैं इतनी देर तक बैठा रहा.
बहुत बहुत धन्यवाद आपका. जी,
थैंक यू सर फॉर सच ए लूसिड प्रेजेंटेशन. सर आई वांट टू आस्क वन थिंग. समटाइम्स जैसा आपने बताया AHI 5 से कम में और जनरली पैप थेरेपी इज नॉट रिक्वायर्ड. समटाइम वी सी पेशेंट की they have AHI of 5 or 7 or sometime 4, but they are desaturating so much, saturating to almost 60% or 55%. So is PAP therapy indicated in such patients who are desaturating during night, but their AHI is less than 5?
Yes, definitely. In cases of central apneas also, there are longer apneas, and we need BiPAP also. Now we have the solution with the uh, uh, breath cycled, that is time cycled also. So we have to give mandatory breaths in these patients, and now even snoring, snoring only can cause sleep fragmentation. So, if patient is having symptoms, if patient is desaturating, that is alarming symptom. And if there is only symptom of excessive day sleepiness due to increasing sleep depth or fragmented sleep, then you have to treat the patient accordingly without considering the AHI also.
Acha sir, what is your experience with one sleep test device, that one single small coin-shaped device, the night owl device, which Resmet had brought recently?
There are many solutions.
Can we rely completely on that?
There are many solutions coming up, and future there may be some chip for all these solutions. But nowadays, till today, the gold standard is level 1 polysomnography for diagnosis of these ailments.
Thank you, sir. So any more questions from the audience? If there are no more questions, then we can close this session. And thank you, Ved sir, and congratulations to the Ved sir and Prasad sir for organizing such a wonderful sleep summit. Thank you, sir.
Thank you. Thank you.
Over to organizers.
Thank you, sir, for such an amazing presentation and for facilitating such a positive learning environment. May I now request Professor S.N. Gupta, sir, to kindly come on his stage and felicitate our guest speaker and chairpersons. Professor Rajendra Prasad, sir, kindly come to stage, please. जी sir. Professor Ved Prakash, sir. Dr. Ravi Bhaskar, sir. Dr. Rahul Srivastav, sir. Dr. Mohit Sinha, sir. Sir, Dr. Mohit Sinha, sir. So, the end of one chapter is just the beginning of another. So, read on, the best part is always yet to come. This brings down the curtain to this wonderful evening. Thank you for listening, inspiring, encouraging, for being here, and most importantly, for giving your time and for making your presence. On that note, we would like to take our leave until the next time. Thank you very much.
We'll begin with our workshop now. All our workshop participants are requested to move on to the second floor.